Buenos días. Vamos a comenzar en unos 15 minutos por el tema de la lluvia. Estamos esperando que lleguen los demás profesores para poder dar inicio a las pláticas del día de hoy, de nuestro segundo día de jornadas. Entonces, iniciaremos en 15 minutos. Gracias. Muy buenos días, bienvenidos a todos. Vamos a dar por inicio este segundo día del Symposium Internacional de Columna aquí en la ciudad de Guadalajara, este séptimo.
Second International Spine Symposium in Guadalajara City. We are eager to listen to Dr. Delfino from Brazil. He'll be talking to us about some complex deformity challenges and the advantages of using Perigard in spine surgery. Thank you very much, and we want to welcome you, Dr. Delfino. Morning. It's a great pleasure to be here with you for me. Thank you very much for your invitation and for being here. The topic I'm going to talk about is about the usage of Perigard in complexity deformities and complex deformities of spine surgery. The spine surgery is necessary whenever we talk about anchorage to make fixations to correct deformities. It is very important, but it is necessary to have a stiff support area. There are, however, different structures that might be used. And among these structures we have pedicles, and our implants are going to stay there. However, there are some other structures and some other implants like hooks but screws, for example, are the ones that represent a very important implant kind to do this anchorage. However, we have a problem. When we use pedicle in proximity, the vertebral structures have problems in give us problems in fixation. As you can see in these images, the complications come whenever there is a greater proximity with the structures. The pedicle diameter this is a study on that, and it showed a variation and a trend to increase the diameter of the pedicles from the thoracic area to the lumbar one. It is interesting, however, that the best diameter, the smallest diameters, are placed there in the thoracic spine. We should also consider, in the case of deformities, that pedicles are not symmetric, and that in the concave side there is a narrower area or a narrower space. And this is important when we think of deformities. We have to remember also about the asymmetry between pedicles in the concave and convex areas. If we consider all this, we have the following classifications of pedicles, and this is present in all pedicles. More or less 10% of vertebral pedicles are hypoplastic, and it's important to remember about the preoperatory evaluation in order to establish the ideal diameter we have to work with. Let me remind you once again how we can distribute the transversal diameter. We should remember in pedicles that deformity is asymmetric and with a narrower diameter that has to be smaller than the concavity. That gives us a special consideration when surgery. And a problem that when we talk about pedicle screwing, it is related to accuracy, and apart from that, it is also related to fluoroscopy and navigation, which are the two main items we have to care for. In our literature, we have some percentages that are variable in relation to the pedicle screws. They refer to the technique or the way or the method this was assessed. Regardless of the variation that exists now in literature, there's no publication showing the 0% failure. That means that the placing An internal pedicle screw is always bringing a risk. As you can see in this thoracic fracture, in this case, there was a previous treatment, and we were really satisfied with the placement of this screw. When the CT scan was made, we saw that this was a problem that was there was situation with this screw. That's an advantage for us. Disculpe, el doctor está hablando en portugués. El servicio de traducciones de español-inglés. Sorry, but we are getting the doctor's speech in Portuguese. Whenever it is possible that I understand, I can bring it to you in English. Thank you. Sorry. We're sorry to tell you that translation is supposed to be in Spanish into English.
Maneiras, né, de transmitir a onda, um meio que é fácil, transmite muito, o intermediário, que é o esponjoso, e aquele que não transmite, que é o osso cortical. Então aqui, você poderia passar o som? Consegue? É só clicar em cima do quadro. Isso. Eu clico de baixo. Mais abaixo. Então, esse é o som emitido pelo aparelho e vocês vão observar a diferença de quando você está no cortical, fora e no interior. Esse é o som quando está fora, tá ok? Pode passar. Isso é uma vista intraoperatória. Pode passar o vídeo da esquerda. Então vocês vão observar eu colocando o aparelho com o meio salino, né? Sangue ali. Pode passar do lado esquerdo, da esquerda. Isso.
Ó, ele transmite rápido, tá? Ó.
Esse é o aparelho disparando.
No cortical, ele já transmite menos, ó.
No cortical não transmite. Agora vamos perfurar o pedículo.
Ó. Esse é o barulho do esponjoso. Ok, Patrícia? Esse barulho convencional de Deus. É assim que tem que manter. Você ou menos.
Tá bom.
Ok?
Então vocês percebam que, pelo som, esse último som é o som cadenciado e mostra que eu estou dentro do pedículo e que a ponta do aparelho está em contato com o osso esponjoso, ok? Esse aparelho ele também permite não só você escutar o som, mas é possível, no ato operatório, você observar as ondas naquele tablet que aparece ali. E ele permite, isso já tem vários estudos mostrando, uma melhor acurácia, reduz a taxa de radiação e permite também a antecipação. Então, se o som diminui ou se o som aumenta, você sabe que você está na direção errada e você pode reposicionar. Isso já foi mostrado em vários estudos aí, que resumidamente estão representados aí. Então, é possível, além de você escutar o barulho, aquela faixa, que é a faixa pré-determinada, e você trabalhar nessa faixa. Então, é mostrando o início, mostrando a faixa da perfuração e quando você remove. Aqui eu vou mostrar, pode passar esse vídeo? Pode passar o vídeo. Aí vocês vão observar a perfuração de um pedículo, um paciente com escoliose, e o registro da onda. Então é possível não somente escutar, mas também acompanhar a onda no tablet. Que é um outro recurso que o dispositivo, por meio do Bluetooth, permite. Ok? Vamos adiante. Então, esse dispositivo tem vantagens para o paciente, a segurança, para o cirurgião, que consegue executar o ato operatório, principalmente em casos mais complexos, de modo mais seguro, recebe menos radiação e é um dispositivo barato, que não precisa de grandes equipamentos e grandes investimentos pelo lado do hospital. Como eu já mencionei, vários estudos mostraram a melhora da acurácia, a redução da radiação, e também serve para o treinamento. Né? Os menos experientes que estão começando a perfurar pedículo podem ter nesse dispositivo uma segurança maior. É possível você registrar, então aí mais uma vez mostrando a maneira como funciona. Você, durante o ato operatório, pode... aí já vai sair fora, você redireciona e volta o barulho do osso esponjoso. Tá? Então é possível registrar toda a perfuração em todos os níveis vertebrais, até do ponto de vista médico-legal, isso atualmente é importante. Eu vou mostrar aqui alguns casos da nossa experiência com o material, mostrando o quanto foi útil. Tá? Aqui uma paciente com deformidade, percebam aí, pela morfologia, a dificuldade técnica era um caso de reoperação, e observe nas tomografias o bom posicionamento aí dos implantes. Tá? Então, realmente, em situações como essa, ajuda bastante. Aqui um caso mais simples, né? Também realizado aí com auxílio do dispositivo, que foi de grande utilidade. Caso mais complexo, uma neurofibromatose, tá? Inclusive com déficit neurológico. Inicialmente nós colocamos o paciente em tração, houve uma melhora relativa e encaminhado para a cirurgia. A deformidade era tão grande que vocês observarem naquela figura de baixo, a raiz torácica ela está saindo em direção para cima, em vez de estar para baixo. Uma anatomia totalmente alterada. A colocação aí dos implantes, a correção que foi obtida, e mostrando controle com tomografia, um bom posicionamento. Quer dizer, uma ferramenta que ajuda bastante em casos tão complexos como esse, para você conseguir uma boa ancoragem. Tá? Esse é o resultado final. Outro caso é uma deformidade neuromuscular. Percebo a rotação na região torácica, na região lombar. Foi instrumentado e percebo o controle, mostrando um posicionamento adequado. Tá? Então, em casos, repito, complexos como esses, tem sido de grande valia. Controle. Outra deformidade, vem com dificuldades devido à morfologia, e o dispositivo ajudou bastante. Aqui, para encerrar, uma deformidade, um adulto, uma colega inclusive médica, a colocação dos tornilhos, percebam o controle, mostrando aí o bom posicionamento. No momento, uma outra técnica que tem sido divulgada é o VII, né? a correção anterior, e esse dispositivo também auxilia muito na perfuração e respeitar a cortical oposta. Né? Então, é outra aplicação que tem surgido. Existem diferentes modalidades, pode ser curvo, existe o menor, pode ser utilizado na cervical, tem a modalidade para cirurgia menos invasiva e temos também o canulado. Então, existe aí uma grande variação e técnica e você pode escolher o curvo, o reto, o menor para cervical, existe o perigard para cirurgia percutânea e você pode também utilizar direto o macheamento. Em resumo, é uma ferramenta muito simples e que ajuda muito o cirurgião a melhorar a acurácia e reduzir a radiação intraoperatória. Obrigado.
Muchas gracias al doctor Delfino. Buenos días a todos.
It's now time for us to listen to Dr. Marianela Campos, talking to us about the relevance of the intraoperatoric monitoring in spine surgery and its current status. We kindly remind you may make your questions throughout the app, and later on we'll be moving into the Q&A session. Thank you. Thank you, everyone, and good morning, everyone, too. While I set everything up, I would like you to tell me, please, let me know a little bit about yourself. I would like to start with a survey. Would you please take your phone out and just answer that one single question? I have one single question to make for you. Even though today I would like to talk about the relevance of IONM. The question is the following. Here it is. Why do you use IONM in spine surgery? Why is that used? One, because it increases safety and surgical results, because we're used to do it. It's just because it's something there that we always have it available and it is always to be used, or because of medical legal issues, or probably because the hospital has an internal policy, or we don't use it, or probably we have some other reasons to use IONM. I can see that the most common answer is the first one, the one with the highest score. Thanks for your participation. I know there are many people, however, in the second item that do not use it. Probably there are economic reasons, or because they lack the adequate staff in the hospital, or there are some other reasons. However, I would like to show you the following. I would like to give you like a message related to what I said yesterday, and it is data-based evidence. This is exactly what I'm going to talk about today. Let's move on. Among the objectives of our talk today, the idea is showing or referring to some historical and publications on this topic, and especially some updated information that is part of current literature, and how important it is to use IONM. Also, I would like to touch upon recommendations and the guidelines of international societies on this topic. Why do we use IONM, and how is it the best way? What is the best way to use it? This is a list of some publications. I know many of them are common for you. We all know that the first time that we use IONM started in the 70s by using evoked potentials or ematosensors in order to get some information from the marrow in order to be used or to use it in spine surgery. And we started working with cases of scoliosis. At that time, we didn't have the possibility to develop motor potentials because they were developed late in the 90s. So we had a 20-year experience, more or less, in which spine surgeons mainly focus on the registrations of sensomotor registration. After the 90s, when we started with the motor records in surgery, there was a series of publications that started to be seen, especially when there were different records of false positives for those patients that were paraplexics in spite of being monitored, but only in a somato-sensitive way. After this process, evidence of the combination of both modalities, not only the motor potential, but also the somatosensors are important. And by using them in a combined fashion, they were really important to let us know about the real status of spine surgery. Later on, with the publication of Feelings in 2010, we got evidence, and this is a publication of review in which different publications, very many were checked about the evidence of this kind of monitorizations in spine surgery. In this publication, it is shown that there is an special relevance in the usage of monitoring to get to know deeply the current status of patients. Now, we have some recommendations between 2013 and 2019 from the American Association of Neurophysiology, from the International Associations of Intraoperative Physiology. This is the publication made by Felix in the year 2010. Its conclusion is states that multimodality intraoperative neuromonitoring is sensitive and specific for detecting intraoperative neurologic injury during spine surgery in general terms, showing, however, some limitations that exist in some surgeries, such as in the cervical spine, where we lack some information, or at the lumbar level. Another publication from an American neurophysiologist, McDonough, he made a review of many patients, 1,300 patients, to analyze the efficiency of the combination of the score of the two different types of potentials, of the mechanical one and the sensitive ones. He concluded the same way. He concluded that the risk of having a paraplexia in those spine surgery patients are evidently used by use of monitorization. There's another publication that comes from Japan. This one refers to the same issues. That means that we have the strong evidence that the usage of a multimodal IOM is becoming more and more important because it increases safety of surgery and it reduces at the same time the risk of neurological damage. In 2012, Ashteka came in and he stated an important question at this point, talking about what is the benefit of the IOM in spine surgery. And he mentioned that not every surgery is the same. If we take different amount of data, at the end it is going to be complex for us to understand. So he made a summary and he classified the different steps, which are relevant steps in order to make the right decision when to use monitorization and when not to use it. In many places, we have problems talking about economic issues. Do I really need it or not? These things arise. Something that is very, very important is thinking of the frequency of neurological injuries and how important information we're going to get. How relevant is it to have specific data in this kind of surgeries? In summary, he says that in case that we have low frequency of injury, IONM needs to be located at a highly sensitive and specific modality. And in those cases where we have a high frequency of injury, modalities to be picked to be used in this specific kind of surgery are going to help us in comparison to not having anything on IONM. I mean, regardless of the modality we use, both of them is going to be useful. However, we might not be reaching the optimal level. But anyway, we'll be getting some help, and it is going to be good and useful for us. Probably this helps a little bit more to start thinking about the possibility of using IONM. Regarding the risk of spinal cord injury, this is a very important publication where you can easily see the total risk of adult and pediatric patients. At the top we have pediatric, and down there you have the statistics from the pediatric patients in case of scoliosis or kyphosis. In both cases, in pediatric patients, a little bit less frequently than in adult patients, they have a greater risk that during the operation we can lead to a neurological problem or a neurological damage. For that reason, IONM is so important. On the other hand, you have ventral cervical spine surgeries, and with this approach, the neurological risk comes to be much lower. These are some of the cases in which we as surgeons really need to decide whether we should use IONM or not, depending on the complexity of the case. This is what Stecker refers to in his publication when considering this assessment in order to make the best decision to know which cases are the ones that should be using IONM. Yesterday, I talked a little bit about the strategy of IONM. In order to use it, we need to adapt somehow. We have some types of modalities. First, we have the monitorization with different kinds of modalities, and there's another side that is the mapping modality that brings us to better, let's say, safety level and increase safety and also protects nerve structures. That is the idea from the neurological point of view. In the surgery, we would like to decide along with the surgeon whether we will be using IONM or not. That means we are combining modalities in order to use the best of information and to get the best of neurological information, especially. It's important to remind you that interpretatory monitorization, especially from somatosensor or evoked potentials in combination with the evoked motor potentials, is the one that brings us the whole information from spine, along with the sensitive information that refers to the dorsal areas of the spine, and the motor one that is in the ventrolateral structures of the marrow. So one is not giving me the other's information. This is just a reminder, an anatomical one, so you can understand why it is important to use both modalities to have an integral information. Yesterday, we said that the idea of having IONM is not just to bother you, but to provide you with a very important tool that might facilitate an optical surgical treatment. This is one of our main objectives as neurophysiologists. The idea is dealing with the solution in an optimal fashion, as well as preventing neurological injuries. To do this, by combining all information we already have, is that we have the following recommendations and guidelines from international societies. These are the ones that I consider the most important ones. The first one is touching upon the general guidelines, even in those countries where medical, legal issues are usually solved at the court, because sometimes the people at the court make use of publications, medical publications, to corroborate what is being done in the OR. And that is why they look for this publication and they find them out, understand them, and they really question our procedures. And they say, you did this, you used this strategy, but you didn't use it properly. That's why I'm touching upon them, because it's important to know that there are some publications that really recommend the correct usage of IONM, not only when dealing with spine surgery, but these guidelines are published to carry out any kind of IONM procedures that are being used, and they are also specifically referring to spine surgery. Talking about MEP guidelines, especially touching upon the motion potential evoked potentials, they refer to the best practices and the record of the usage of MEP. It also reviews the effects of anesthesia and systemic effects affecting the interpretation of these potentials. And it also highlights different aspects on the patient's safety regarding motion evaluation or monitorization. We know that the patient may move a little bit in the OR. Probably there might be some injuries, for example, in terms of the tongue, whatever, if we do not have an optimal position for the monitoring devices. Usually the patient moves the jaw very much, and he might even break the respiratory tube. All those recommendations are included in this recommendation guideline. It is important to consider all of them because it's important to highlight what is the damage that we might incur into when dealing with a patient, and to understand how important it is to have this monitoring and what should we expect the monitorist to give us or to provide us with. It is important to see that it is possible to change the type of stimulation to prevent any problem. Talking back to another factor, that is an electrical factor, that is also important. The publication also emphasizes the factor that influences interpretation and surgical warnings. These are the most important items why I do recommend it is important for everyone working with monitorization, especially referring to neurophysiologists, but for everyone, for us, it is important to know there are some guidelines stating these recommendations in detail, and they encompass the reference records or registration tools for the motor monitorization. Now, what about the recommendations we have for SSEP? It summarizes the same thing, but now for somatosensor monitorization. It reviews the best practices. It also checks the effects of anesthesia, systemic effects. It talks about safety aspects that are important and influence the interpretation of surgical warnings. In both cases, we are assessing the what we'll be getting when practicing monitorization in spine surgery. One of the most important points I wanted to point out was in the case of somatosensor monitorization, looking at peripheral readings. Peripheral readings may be carried out in the cubital fossa into devices, contact devices that might be placed this way, or probably in the popliteal fossa. That's another second option, depending on the surgery. This, including the ERPS points, should be control points, not the surgical point, okay, depending on the direction that the signal is running. I also mentioned this yesterday. Let me repeat this a little bit in the case of scoliosis where this is a case of cervical spine surgery. So the cortical and motor potentials are lost, and we can detect them using the peripheral records. The problem is not a surgical one, but in the plexobrachial there, or at this arm, there is a lot of tension and there is an ischemia is being produced in the limb, so it has nothing to do with the surgery itself, but the peripheral records are important for that reason. And the same happens in the popliteal fossa control. In this case, for example, there is a compression of the femoral artery, and there it implies a different kind of records, and only by changing the pelvic support is that we may recover these records. This might only be seen only because we have those peripheral readings already. And this is what you can see in this image. The first part shows us the popliteal fossa control, and it had disappeared because of the ischemia in the leg, and then it appeared once again. Yesterday, I touched upon the warning criteria in the case of motor evoked potentials for the spine, and I would like to highlight the following. In this image, you can see that there are different types of surgeries, the intramedullary, extramedullary, and the one that is performed to peripheral nerves. In the case of the medullary one, we talk about the periphery, and the warning criteria we have for surgeons is the following: if the potential disappears. However, there is also a reduction of the amplitude of the wave. When is it valid? That's why we have a number. You have number 1, and this may only be assessed because whenever we have a loss of amplitude, that means that when that happens, we are carrying out a kind of stimulation that is referred as supramaximal stimulation, and that means that I am stimulating the patient with a maximum amount of stimulation, and I keep it that way through along all the surgery. What this record does not consist is the difference in amplitude in the wave, and that happens whenever we have situations like, I don't know, because of the drug that is being used, a loss of temperature, loss of blood, etc. So in these records, the loss of amplitude in motor potentials will no doubt be a warning for us, not only to be careful, they are not an absolute warning, because in this moment we see that they have a moderate importance. The other way in which we may also evaluate motor records is by considering the elevation of the stimulation threshold. And that means that we need to record potential. For example, talking about amperes, 150,000 amperes, so probably 500 volts. If the amount of stimulation is increased, then at a certain point, that may become a warning. This warning, however, is more commonly used for neurosurgeons, but for spine surgeons, this is not especially relative, and that's why here you can see that it shows with a moderate relevance. Then these are some indicators that show something's happening with the patient, and if the patient wakes up, of course, there will be no motor deficiencies or deficits. However, talking about the warning criteria, in some SEP monitoring, it is important to say that it is so essential to highlight the importance of non-surgical warnings due to the identification of surgical records. People that carry out monitorization should be paying attention to the changes of temperature and the anesthetics elements that are being used in the surgery. Warnings refer exclusively to what is happening in terms of surgery. For example, we can say that we have the usual classic warning criteria that first comes to talk about the amplitude of reduction, 50%, and the 10% of the latency increase. We should also say that this criteria is now obsolete. This is because if we increase latency, for all the neurologists that might be present and surely are present, or neurophysiologists, you know that the changes in latency in a potential will only be recorded whenever nerves undergo a chronic change, and that is not happening in surgery. On the other hand, we are having acute changes. That means that the records we have in intraoperative changes refer not only to nerve damage, but what they refer to a change in general status of the patient. And with that, we mean that there's a change of temperature, whatever. But this has nothing to do with a neurological damage in the patient. The 50% of amplitude reduction will no doubt depend on the quality of our record. Whenever we have a record that is becoming complicated to take, that needs a lot of calculation of many medians in order to reach a good number, that is a problematic record that is not really with the highest validity. In those cases, that is not going to be taken as a reference to refer to the reduction of amplitude. So for that reason, we have some other criteria that probably is not as concrete, but we consider the visually obvious amplitude reduction when it is abrupt and focal. Every record that showed an amplitude, and probably 2 records ago it was okay, and now the record changed, but it only changed in one leg. That is a real record, and it is a warning for us. We should consider it. That means that those 50%, 10% strict values, in fact, are completely out of shape. Currently, we have the following. Let me give you this summary. We currently have enough evidence to justify multimodal IONM and its usage. The correct selection of those cases that require IONM increase the probability to detect lesions. The optimization of the recordings and signal stimulation of evoked potentials give us play an important role to give quick status of nervous structure. It is also important to emphasize how important it is to reduce confusion factors because they refer to the changes of monitorization due to some other external factors. The importance of avoiding non-surgical warnings to facilitate an optimal surgical treatment. Here I can get you some other information on neurophysiology courses for those neurosurgeons in case they are of your interest, and thank you very much for your kind attention.
Thank you so much, Dr. Marianela. A very interesting talk, and we thank you for your contribution to this symposium, particularly underscoring the importance of neurophysiology and the trans-surgical monitoring in order to safeguard our patients' health. And as a token of our appreciation, we have this present for you. Thank you so much. We are now going to welcome Dr. Federico Landriel, who will discuss the use of screws with augmentation and an update to the software system for imaging studies. Good morning, everyone. I thank the organizing committee for their invitation. And of course, the chance they've given us to share with you our experience in the clinics where we practice medicine in Argentina. These are my disclosures, and the target of this talk is to share with you in 10 steps some ways of preventing or avoiding complications. The first tip can be applied to any medical practice, whether we're placing a screw or we are resecting, whatever. A good indication will always lead to a good outcome. When we use cemented screws, we should try and prevent the pull out of the screws. So therefore, we know that there are specialized screws to prevent osteoporotic fractures, and we know that these screws were used in other pathologies such as secondary osteoporosis because of the chronic use of corticosteroids or tumors. And we know that one of the most frequent indications that we have for the use of these implants is fixation, instrumentation, and of course we have to be aware of metastases that may make the placement of the screws unstable. So we try to have adequate fixation in long areas of the body, and of course if we want to strengthen the instrumentation, well, we also use screws. And also in revision surgery, when screws are loosened, then we need to pay close attention to this. So we use screws in vertebrae that are soft. When we have a weaker bone, of course, we have to first look at DEXA. We need to look at bone density. If we have a fracture, if we have metastasis, or if we have more than one standard deviation in our measurements, the result of bone density, for instance, in this case, lumbar spine, will not be as specific. This is why we advise to take a bone density measure at the wrist. But in our day-to-day activities, we have patients with metastases, with bone fractures, and we have no time to ask for bone density and wait for results. Sometimes we can also not know how to read the report and how to read the actual image, and we have to wait until we get a report. But the first thing is to determine whether we have a soft bone or not, and for this, the most efficient method is a CT scan, and where we need to evaluate the average of the sponge's bone, and if we have less than 120 Hartfield units, the vertebral body that we need to instrument will tell us that we need to add cement to our screw in order to prevent pull out. And this can be remedied by up to 250%. So CT scan is a study that we usually ask for because it facilitates our decision making. So we are using this technique to evaluate different pathologies. We started working with spinal metastases, and at the beginning, we used to consider instrumentation without fusion because these were patients with metastases. And of course, we have different factors to take into account, for instance, survival rate. But then we moved on to shorter instrumentations, as in this case, where we directly worked on a level above, a level below, and we reinforced with cement. We used to place also intermediate screws in kyphotic angles, and if necessary, we also considered an anterior support, but this all has to do with the life expectancy of the patients. Sometimes we have patients with neurological deficit also. So our idea is to decompress and to make our patient ready for an additional procedure that, for instance, a chemotherapy, whatever. So we started using this option for shorter fixations in vertebrae where we could even add an anterior support, but we always used cement. And this is how we evolved our technique. And we also saw that this technique could be useful for other type of pathologies. This is a female patient I operated on some years ago using a minimally invasive approach. And the idea was to try to prevent damaging the joint, the facet joint. And because, as you can see, this patient has spondylolisthesis. So our idea was to remove synovial cyst at L4, L5. But in the post-op, this patient unfortunately had a relapse, so we decided to operate on. And this patient had a very osteoporotic bone. So we decided to use augmented screws for an additional support and improve the fusion of the intersomatic cage. All right, let's move on to tip number 2. That has to do with K-wires that we use in order to guide our cannulated screw. If we know that the target is to leave the tip of the K-wire at the joint of the anterior third of the vertebra, for instance, we carry out these procedures as a mirror with a resident or a fellow to try to approach at the same time from both sides. So as surgeons, we have a little bit more of experience in placing the K-wire, but to use a K-wire with a round tip is safer than to use the K-wire with a blunt end, because then we run the risk of breaking the anterior cortical, because if we break it, when we cement these patients, that cement will go all the way. So we can also try to do this manually. In soft bone, the sensitivity of the surgeon is better in order to bring down the K-wire slowly and try to prevent any damage that could be caused by a blunt end. And the same thing goes where we are using screws. We With a screw, we can also break the anterior cortical, and since these are screws that have a hole at the tip, they can move forward in the vertebral body. So we have to go step by step and very slowly. Now I move to tip number 3. You need to know the screws that you are going to be using. So we need to know that we have different types. We have the green screws where they have holes where we have where you can see the key wires going through, and also the cement will come out a little bit more to the back of the screw. And you need to take this into account because this will give you a more homogeneous filling of the vertebra. And we also have the cannulated screw, where the tip of the screw will be releasing the cement. In Argentina, the smallest diameter of the screw is 5.5. So we are going to instrument with a short pedicle. We need to have we can use a 3x4 screw, and then we need to be very, very careful when we use these screws that are longer, or if we use a cannulated screw with a hole at the tip, we can even go at a longer length. So, but if we use a short screws, you have to remember that the holes are at the back of the screw. So you have to remember that when you are applying cement. So if you're using the green tip screw, you have to remember that that is the short screw, and the cement will go to the posterior segment. Now, tip number 4, secure attachment. You have to remember the extension or the length of the instruments that you are using. First, we know that sometimes the secure attachment is not something that we see, it's something that we feel. So if we are not aware of this, once we introduce the cement will leak. And when you later on want to place your bar, you have to remember that when you are going to be placing the bar, you are going to have cement already in place, and it will be very difficult to bring the bar down. So if you have a leak, sometimes you have to open with a percutaneous incision in order to control the leakage of cement. So you have to be very careful so as to not to have cement leakage. Tip number 5 has to do with cleaning all the way where you are going to be introducing cement. Cement has to be running through a very clear pathway. So you can do this with a saline or physiological solution, and you can use a physiological solution to clean all the way. You can see how liquid is coming out the other end. This means that the pathway is clean. Because when we start applying force is when the cement starts sticking, and we can run into trouble in the surgery. So we have to clean the pathway for cement, and this will help us realize whether the fixation is going to be okay, because when we have a physiological solution after we clean, we know that the path is clear. Also, we need to know the volume of cement. We need to know the cement that we are going to be using, because cement comes in different types of viscosity. And so we need to know that the attachment in its interior can have a capacity for 2 cubic centimeters of cement. We are going to have 2 cubic centimeters of cement inside the syringe. So we need to know that this is going to be filled by cement. And then if we add 1 centimeter per tower, we can have between 4 to 6 cubic centimeters of cement per vertebral body. Of course, it's different when we have a lumbar vertebra or a thoracic vertebra. And we can cement 4 screws, for instance, and we can do everything simultaneously using these syringes that give us a better feedback. It is also different to not just the different type of cement, but also we need to know that we have different types of screws. We can have a fenestrated screw or an angle screw. And of course, we need to protect screw extensors or extensors. So here we usually find resistance, and then cement starts leaking when we are introducing the bone filler. And so the cement can go into the interface with the extensor. And so to prevent this, we use gauzes, and this is one way of keeping the cement out. And tip number 8, we already have everything in place. We have opened our pathway, and we have used our gauzes to prevent cement leakage. And then when we are introducing cement, we introduce it slowly with radioscopic control in order to have better control. And of course, we will try to apply it simultaneously, if possible, in 2 vertebrae that are within the same field of the radioscopic control. We will move on now to the next tip, tip number 9, which is don't panic. You have to remember that we are working with vertebrae that are very soft. Oftentimes, when we introduce the screw, the micro movement of the screw can increase the circular trajectory of the screw, particularly with fenestrated screws. If we see that there is cement leaking, then we can have oblique controls in order to make sure that we do not have a cement leakage. So not necessarily all posterior leak will go inside the canal. If we had a leak within the canal, we can ask the anesthetist to perform a Valsalva maneuver that push the dura, and when the cement is fresh, it will flatten, and therefore we have a lower opportunity of causing a neurological damage. And tip number 10 is whenever we place an implant, we need to bear in mind how to remove it. In the picture below, you can see a cemented screw. But this was created in order to prevent the pullout of the screw. It is not difficult to pull out a screw because we are breaking the anti-torque with the small fenestration that we created between the screw and the interface with the cement. Thank you. Let's move on to the next topic, which is the value of time. It's difficult to determine. It depends on what we're doing. A 7-minute talk. In a 7-minute talk, to waste 1 minute is a lot, and particularly when we're dealing with a surgical complication, 1 minute may seem eternal. For others, 1 minute may seem imperceptible. For the majority of us, time is something extremely valuable. The objective of this talk is to share with you a problem, an idea, and a solution that we're working on. Spinal surgeons for over 15 years have learned to use spinal parameters in order to plan our surgery and improve our surgical results, but also with short instrumentations to prevent generating or creating problems for our patients. So if we're going to be eliminating lordosis, this is extremely important. Over 10 years ago, we had this program, or this that we all know of, which is Surgery Map. It is a semi-automatic software that in order to use this software, we need to calibrate it to determine the distance between 2 points. And if we can enhance the image and say, all right, between this point and that point, we have 1 centimeter, that measurement may lead to a mistake associated to us, to humans. It was a human mistake. So once our system has been calibrated, we have to show the software each of the anatomical points based on the X-ray, and then we will determine the majority of the spinal parameters. But then we need to mark each of these parameters, and this is also subject to human mistakes. And I assure you that if you perform measurements in the morning and then in the afternoon of the same individual, there will be differences, because this is all based, it's also based on the variability as associated to human mistakes. So this is a major issue whenever we talk about measuring. And of course, this is something that we need to take into account because it is associated to variability in measures. And this semi-automatic calculation is also subject to mistakes. These are examples when, if you look at the thoracic curve of these patients, it is placed either ahead or behind the actual thoracic curve, because the software has functions that shorten steps, but this is not a perfect software. So the software has some issues also. So we decided to measure how long did it take for us to measure the majority of the spinal parameters that we use, that are, to give you round numbers, 20. So we took more or less 4 minutes to take all basic measurements for the spinal pelvic parameters. And at the hospital, we have approximately 15 minutes at the office to be with our patients. So if we take 4 minutes to measure, 30% of the time we're with our patient is already gone when we were taking measures. So the time we have left to interact with the patient is minimal. Of course, if we add secretaries that can bring measurements already, that can save time. But think of an option where you are with your patient Smith, you are discussing the type of surgery, and all of a sudden the resident knocks at the door and he says, "Doctor, here I bring you the values that you asked for." And we read the report, and then we say, "Mr. Smith, according to these measurements, we are going to perform a T10 pelvis because the curve, we are going to do this and that." And that will be the face of Mr. Smith. So precision is very important, whether we evaluate with a software program or physically. We have an issue. An issue is to measure spinal parameters with precision and within a specific time window. So we need to have an adequate software that may perform all measurements automatically. At our hospital, we have been using AI with images that detect issues in thorax X-rays or mammographies. And our department in charge of AI at the hospital asked us if we could share with them an idea for them to develop a program. So we decided to go for this option. We started by evaluating the 19 parameters that were the ones that we used the most, using an AI option, which is deep learning. Deep learning has the advantage of being able to interpret parts of a whole. For instance, when we look at the face, it can interpret the border of an ear or a nose, and they can understand, therefore, that this is a face. Now, this type of technology is something that the majority of you have in your cell phones, And this is something that is relatively new. You have remember when we first when we first started using our cell phones, particularly during COVID, we had our face mask or dark glasses, but now we know that we need to remove them in order to have a facial recognition. And now we're starting to work as a team involving 3 departments at our hospital, the Department of Software Engineering and AI, and then the radiologists and us, the neurospine surgeons that coordinated the other 2 teams. And as a whole, we developed an algorithm. But how did we develop the algorithm? Well, this is something similar to teaching a 2 or 3-year-old toddler, explaining what is good, what is bad, what is black, what is white, what is hot, what is cold. We first have to teach the software, I want an X-ray. Then I want a spine RX and an adequate RX, not just a blurred image. So all this requires training, and we need to show the software how to work a spine RX. And then we had to teach the software to detect each of the vertebrae. So we marked 31 points along the spine so that the software could recognize the spine, what is C1, what is C7. Now, how did we do this? We started by marking each of the anatomical landmarks. For instance, here we mark the tip of the odontoid, and then the posterior and anterior of C1, and then the middle of C2, anterior C2, and so forth. And we change using a color code, because sometimes we could make a mistake, and then we could modify the landmark by using a color assigned to each segment. And then with the software, we had the option to enhance the image in order to identify the anatomical landmark. And if we could not find it, if it was invisible, for the software, we had to remember that we are educating a child. So for the non-visible landmarks, they were simply marked so that the software would understand what we were trying to do. We also had the option to identify whether it was left or right, and this was done randomly. If in the image the figure was always pointing right, sometimes the program or the software would give us images that were looking towards the left, so we could identify which was the right direction. And if there were instrumentations in place for any additional instrumentations, we started discarding images so that the software could learn with the most common vertebrae. So we started explaining why we discarded, because we had a spondylolisthesis or a fracture, and then we developed an algorithm with vertebrae that had no issues at all. And this is how we started with over 800 spine RX. And you can see that there were also points that were not visible, and this was most frequently in the upper cervical and lower lumbar, because in the upper cervical is where we have the shadow of the shoulders. But nonetheless, we were able to develop the algorithm that initially all it did was to identify where the landmarks identify the vertebra. But for this, the algorithm could first have to be able to determine the objective, the spinal parameter, and we combined this with the human measurements. And we realized that the most difficult areas to measure were the upper cervical and lower lumbar. And then we carried out an internal variability where we compared experienced surgeon versus software, and then fellow with fellow, and then fellow with algorithm aid. And then we saw in blue where we had the highest variability in measurement, and those continued to be the upper cervical and lower lumbar. And of course, we have a time benefit that is significant. We can see how with AI we are improving. If we are surgeons aided by AI, we can be more time efficient. So if we look at the time it took to correct the software, we eventually starting catching up, and the software reduced correction to a matter of seconds. So the next step was to fully develop the software and then test the software in our day-to-day practice at the hospital. Because whenever one wants to develop a project, is as if you were working or developing anything at the lab. You can develop something at a lab, and then you have to bring that to the real world. So our idea is never to replace humans. Today, when we measure the spinal parameters, in none of our spine RX are eliminating human personnel, because we need to have additional information. So our idea is just to improve the measurement of spinal parameters. And with this, I finish. Thank you. Thank you, Dr. Landale. Very interesting talks, very interesting talks for all of us. We wish we had this available here locally. Let's now welcome Mr. Matias Roller, who will discuss facts and realities of lumbar braces.
Muchas gracias por tenerme aquí. Gracias. Miren, ayer ya hablé un poquito sobre estos procesos certificados y bueno, ahora tengo que decirles que me siento muy bien y gracias por su hospitalidad. Fue algo muy interesante lo que
from you, and I like to bring you now in the world of the conservative treatment and have a few general facts about orthotics. So orthotics doing a lot of different things: stabilize, immobilize, mobilize, relieve, correct, fixate, redressing, replace. So you can do a lot of things, but you have to know what you want, and you ask the certified orthosist and prosthesist what you want. So on the side, I have two pictures. This could be a separate lectures. So nothing new under the sun because of the biomechanics, but also in the ONP, we have a lot of machine deep learning and 3D printing coming more and more, but this would be a different topic. Yes, you see here only a few examples of what you can do with orthosis, and this is important that you communicate to the certified prosthesist and orthosist what your aim of, that you don't send the patient to them and say, give him a brace. You really have to say, I want to have a relief, I want to have immobilization or mobilization of this segment of the spine, so that you really become accurate orthosis. You see how different orthosis can be in kind of the function and the aim, what they have to do. So I want to give you a few facts about the bracing. So what I hear and what often is, do brace work at all? Maybe placebo. Or back braces cause muscle atrophy is also what I hear often from the patient and from the doctors and from the physical therapists sometimes. Patients are lose the flexibility in the back brace. Can back braces reduce pain? It's only a few questions you have maybe in your mind if you hear the word brace. So I'm always important for me is that we ask the patient what they feel. It's more a feeling, I know it's not so scientific, but sometimes we as a professionals, we are very happy if we have a nice X-ray or we have a nice result, what we think it's very good, but maybe our patient is not so happy about it. So we learn the feedback of our patient, and this is a survey from independent German institute. I don't know exactly now how many, but a high number of patients was telephone interviewed about how they go with the subscribed brace. So 45% of the patient, they have a long time back pain. 81% have a great benefit of it. 48% less pain, and 65% reduce the amount of medication. 27% of the patients said they are more mobile, and 66% of the patients they thought that they are asked to return to work more quickly. So I think this is a very interesting survey and the feedback from the patient. So this is very important for me, what the patients say. Also is maybe interesting what literature say. I know in this field we have not so much literature. This is really a problem, but it becomes more and more literature, and we have a little bit a better idea what we do. So the big question is the trunk muscles atrophy doing use of the brace? And two systematic literature reviews say clearly no. They could not find any signs to weaken the muscles. And I think this is a very interesting result out of these reviews. Other studies say they checked out the same issue, and they did endure the EMG and spectral parameters, and I could not find a difference between brace users and not brace users. One study used healthy persons to check this out. So why? And patients lose flexibility in spine and using back braces. This is also very important. And you would think if you have a back brace, you stiffen in this back brace. But you don't use a back brace if you have nothing. But you use a back brace if you have pain. And if you have pain, you do nothing. This is the problem. The braces are relaxing the muscles, the tense muscles, because pain is tensioning the muscles. And if you relax them, has less pain, and less pain creates you more mobility. You do more, you are more active. And this is, I think, the circle, what is very important. You see here, overloading painful muscles are cramping and painful, and orthosis support leads to significant pain relief. That is the important point. In physical therapy, the first thing what you want to do is relieve the pain, because then you can do the physical therapy. If you have a patient in pain, you are restricted. And the pain, reduce the pain, you become more quality of life for the patient, and they are more mobile, and studies show that decreasing of the painkillers and increasing the quality of life. So summary, you can say back braces can reduce pain, improve mobility, can help reduce pain medication, can excessive use to anatomical structures, can use for immobilization or partial immobilization, or also used post-operatively or conservatively. So you have a lot of fields you can use it. but I know they are not 007, so they cannot do anything. They can help. They are friends of other procedures. You need physiotherapy, medication still. Maybe you can reduce surgery for sure. And very important is to talk to the patients that they change the lifestyle. I think this is a very important part, and this is what we know. The time, we heard in the presentation before, the time is really a big issue, and I think this is an important part that we talk to our patients, or we find a solution in our organization, in the hospital, that somebody talks to the patient to change the lifestyle and what's going on with the patient. This face you have in your presentation before, when you talk to the patient, I saw also sometimes, and what's happened. Yes, this was a short presentation about facts about orthotics. Thank you for your attention and for having me here.
Muchas gracias al ingeniero Matías Roller por su presentación. Damos la bienvenida al ingeniero Armin Donhauser, que nos va a hablar de las mediciones de la columna vertebral de alta velocidad y sin radiación en el diagnóstico preoperatorio. ¿Cuándo es apropiado usarlo y cuándo no? Gracias.
Okay, thank you for having me again. And I'm talking a bit about how this high-speed diagnosis device can be used pre-operational. And I want to show you a bit about the practical daily work of doctors, of physiotherapists, etc., how they use it and why they use it. So to approach the whole thing, I would like to talk a bit about the whole value chain. So as a surgeon, most of your surgeons, you're in the preoperative planning and the planning, and the life of a patient, so the user journey, how you say in marketing, begins a lot before you see the patient. So we see that diagnosis is applied a lot in the prevention. So I will show you a bit later. Then in the diagnosis, when you see the doctor, and then at a certain point in time, the operation decision is taken, do operation or not, can we go for a conventional or conservative treatment, and then there is the whole phase of the rehabilitation, which I will not touch at the moment. So, what is a big trend, especially in Europe, in Germany, we see is the health management in companies. So there are a lot of companies who invest in the health of their employees. And we see, you see the picture here, someone doing a measurement of the spine at the working place where people sit the whole day. And this is something that that helps in the prevention space to very early see when something is going wrong, and then to direct the people into the real diagnosis to the doctor. So at the working place, you see that you can examine the general fitness of a person, the postures that they have while working. There's a lot of ergonomy consulting going on, especially during the period of Corona, when people went home in their home offices, working on the beds, in the kitchen and wherever. That was a big problem. And here, this can help to improve the ergonomy of a working place. And what you can also help people there is to visualize how they are sitting and show them a 3D model of their spine, what is happening. So this is something that we see a lot. In the prevention, you can also examine not only the posture, but also the function, the shape, the range of motion of the person. And there's an objective of quality assurance of the therapy. A lot of people who have back pain, they don't go to the doctor at the first, but they go to a physiotherapist or maybe go to the fitness center. This is where we see also that a lot of diagnosis is happening. And here, it's always good to not only touch and feel, how a lot of physiotherapists do, but to have some kind of an image that is generated and to show numbers and figures and a real truth, how the situation is. So we see that a lot of fitness and physiotherapy is going on with this diagnosis, and this is a sure thing. A very special case is the sleeping. So there are specialists for mattresses, and if you just think about how many hours you work at in a chair, sitting in a chair in an office, and how many hours of your life you're lying on a mattress, and if like 2/3 of a whole day of your life is in bad conditions because you have a bad working place and a bad mattress that doesn't fit your shape of your weight, your shape of the spine, this is something that can help a lot to relieve pain of patients. So that's what I would call an everyday life fit scenario. So in all these scenarios, we see that the diagnosis is going on. In the real practice, in the diagnosis, we see that it is very useful to have a quick response. I don't know how the health system works here in Latin America, Mexico, but we are working together with a hospital in the UK, in London, and in the UK we hear that there's a long period of time until you get an appointment at a doctor and you can do an imaging, 3 months, 6 months, whatever. So in this hospital, they use actually 10 of our devices with a team of 26 people, and they are doing the diagnosis every day to do triage settings, so to decide quickly, is this someone who we should direct urgently to a doctor and do an imaging, X-ray, MRI, or whatever, or we can do something more conservative, look at conservative treatment, physiotherapy, or whatever. So quick response triage is definitely something that can help with such a device. Decision support for you as a surgeon, as a doctor, to decide how to move on. And we have also some special cases in sports medicine where it's important that the sports doctor can go on site with a team in a training camp or where something is happening. So the mobile use of diagnosis also very important. So we do that a lot with this device. I showed you already yesterday. And I explained yesterday, so I will quickly repeat it, the principle of the analysis. So it's about measuring the length of the spine on the surface of the back. And this is working because we have a correlation between the line on the skin surface and what is really going on, the 3D model of the spine inside the body. So we measured the length and this line in the 3D space, and there is, based on reference data, a reconstruction of the spine model made by the software. So this is clinically validated. It's reliable. I show you the details here. So there have been many studies going on with this device, more than 50. Some of them I want to show you here. So when it comes to the position of the spine, there is an R of 0.97, and when it comes to mobility, so flexion, extension, etc., the R has been found of being 0.82, which is quite a good value compared to the golden standard of imaging. And if you wonder how precise the angles between the vertebrae can be measured, we found out that it's about plus minus 1.96 degrees. So that's definitely not an accuracy where you would do an operative planning for spine surgery, but it's good enough to decide quickly what to do. So the big advantage is, of course, it's radiation-free. So you don't expose your patient to radiation. That's very important for children, for pregnant women, etc. And it's a time-saving alternative to evaluate the posture. So how is the posture of the person, the mobility, range of motion, and the stability. So you see that on the right side with these three pictures, that's how we measure these three dimensions, so postures, and there are different postures possible. This is upright standing. You can do it also in sitting, in 4-point kneeling, etc. Then the range of motion in the middle picture on the right, and the stability where we typically use the Matthias test with weights, and we measure the compensation movement of the person holding the weights for 30 seconds. The other accuracy or reliability that I showed you already yesterday, so when it comes to lordosis, kyphosis, we see very nice reliability figures, 0.98, 0.96, and for the range of flexion, range extension, 0.95, etc. So we are very convinced that it's really reliable, good enough to do true diagnosis. It's not just a toy. What is also very, very important to know is where can you use this device and methodology for children. So the data that we have is validated for children from 6 years on upwards, and especially here, the radiation freeness is very important. And so also here we see an ICC depending on the use case of 0.87 and to 0.96, which is quite good. So just to show you, because the title is high-speed diagnosis, and I just show you how the posture diagnosis is happening. It's just a few seconds. So you measure from C7, so at the end of the cervical spine, down to S3, to the sacrum. And that's how it's working. So it's really, really fast. And out of this measurement, you get a full 3D model of your spinal curve and of every single vertebra. So here a little screenshot out of the software just to show you. So you can create your own measurement protocols in standing, sitting, 4-point kneeling in the frontal or sagittal plane, and you can combine that. We have a few standards there, but this is used very freely as a measurement device. So the software itself shows you deviations from reference values. So it shows you, for example, if you have a flat back, hyperlordosis, hyperkyphosis, hypermobilities in the range of motion, or hypomobilities, stability defect, and not only the posture, but also concerning the harmony. So how nicely are the vertebrae, the relative angles to each other, distributed around this S-line. So if you have big angular jumps or paradoxical angles, this is visualized in the software. Just some screenshots. Here is a visualization of the hypermobility. You have the thoracic spine, which is hypermobile, and also in the connection to the hip. And you can also visualize that on the single vertebra level. So you see here where you have jumps in angles, more than 7 degrees is something that we think is critical, and that is something that you're pointed out after the diagnosis in this model. So typically what we see is that if you do, and there are devices that only measure the regional angles, so thoracic spine has 42 degrees or whatever, so it can be very nice looking. But if you dig down on the vertebra level, you see that you have sections of hypermobility and hypomobility, which causes stretch in the overall structure. And this is something that you should look into the details. So typically, this is what we see where the problems then arise. And these are some examples inside a diagnosis of the software where you see exactly which vertebrae are affected, where should you look into. What we also think is very important, because this is something, a picture that you wouldn't show your patient in detail to not cause some bad feelings. We have developed a score system. That means that if you have like a posture or a flexion score or a stability score, we have the perfect spine posture, and that is comprising the angles, how they are distributed, that is the harmony score, and the posture itself, so how well are you doing the upright position? How well or how is your range of motion in the flexion? And in this flexion, that can be very well in terms of degrees totally, how well is it distributed in the thoracic, in the lumbar spine, and in the sacrum. And these scores are very easy to understand for a normal patient, for a normal person. And after that, you can do a therapy, physiotherapy, fitness training, stability, mobilization, whatever. And over the time, you can improve these scores, and that's a nice learning and a nice experience for the patient. So that is something that we found very useful in communication with the patients to tell them, okay, compared to your age group and the sex, that's the reference values that we have. You have a score of 64, which is quite good. It's not perfect. There's some potential, and now you should this and that. And after a few months of therapy, you can raise the score to 70, for example, and that's a nice experience, very, very useful. So where are the limits? Of course, so based on the principle of the measurement, we measure the length of the surface on the skin. If you have highly adipositous people, this is something that doesn't work. So you have too much error in the measurement. And we don't have reference data, and doesn't make a lot of sense for children under 6 years. So there you would need to do something else. Also, as we don't have an imaging in the traditional sense, we can't look inside of the body into the spine. So if you had already spinal surgery in the past, or you have implants existing in your spine, this is something that the measurement device will not detect. You could do the measurement, and probably it would point out some problems there. But this is something where we say, no way to do it. You can use it, and it might help you in the therapy after the operation to track some, like the lumbar spine, if you had a thoracic spine implant or something like that. So in total, I would say this device and the software especially has a very good reliability. We have really nice standard values. for radiation-free diagnostics. Compared to X-ray, it is a complementary system to X-rays, definitely, or MRI. It's an extremely fast measurement, so you don't have to wait. It's something that also non-doctors could do who have some basic training. It's a mobile system that can be used outside, especially in the sports medicine we do that. And it can help you doing triage very early, doing supporting in taking your decisions. And it's very well implemented if you do repeating measurements on, like, every month you do a measurement and over time you track the therapy success. This is something that we can recommend, definitely. That's it. Thank you.
Muy bien, comentábamos que un agradecimiento para el ingeniero por su participación y le entregamos
Presented a token of our appreciation to our guest speaker on behalf of the organizing committee. And next we will have Dr. Delfino, who will discuss the Ocentum system for the treatment of spine diseases. Please go ahead, doctor. Unfortunately, Dr. Delfino speaks Portuguese, and we do not offer a translation option. Lamentablemente, el doctor Delfino está hablando en portugués y no ofrecemos la traducción portugués-español.
Foi desenvolvido o sistema cuja denominação é UCEN. Né? Para quem não sabe, a USP fica em Ulm. Na foto acima, mostra o local onde foi fundada a primeira loja e depois aí a fábrica atual, que se expandiu bastante. Uma das características da URGS foi sempre inovar e procurar fazer coisas diferentes. Em 1988, eles desenvolveram o primeiro sistema universal para fixação de coluna. Era chamado sistema USIS, que era a sigla do Universal Spine Instrumentation System. Tá? Isso foi em 1988. Esse material ele era constituído de aço, acero, tá? E constituído por tornilhos e barras rosqueadas que poderiam ser utilizados tanto na parte anterior como na parte posterior. Representou um grande avanço na época, né? Nessa época aí, poucos instrumentos de coluna estavam à disposição. Esse sistema, o USIS, ele poderia ser utilizado tanto na parte posterior, com tornilhos pediculares, como na parte anterior. Tá? E oferecia uma grande gama de utilização. Vocês veem acima a utilização no tratamento das fraturas, que foi revolucionário, porque nessa época o padrão era a utilização do Harrington, que fazia uma fixação muito longa e sacrificava muitas vértebras para tratar uma vértebra fraturada. E o sistema proporcionava a fixação monossegmentar ou de 2 segmentos. Tá? Era utilizado também para correção de escoliose, que foi um método desenvolvido por Zilk, na Alemanha. E podia ser realizado tanto anterior como também na lombar e na torácica. Tá? Então, na época foi um sistema assim, revolucionário e já mostrava essa característica de sistema universal. Em comemoração aos 100 anos, então foi desenvolvido o sistema UCENTO. Eu tive a oportunidade de participar junto com outros colegas aí na elaboração. E esse sistema, ele também é universal e de uma maneira já mais sofisticada, né? Com tornilhos de desenhos diferentes, funções diferentes, permitindo tornilhos com abertura e canulados, como o Dr. Landriel já mostrou, a utilização em ossos osteoporóticos. Permite também a utilização tanto aberta como percutâneo, né? E com diferentes modalidades de torneio. Então, assim, é um sistema que seguiu a mesma filosofia de ser um sistema universal, mas com material já mais sofisticado e fornecendo outras opções. Então, nós temos aí os desenhos dos tornilhos, nós temos o poliaxial, nós temos o pré-fixado, de cabeça estendida, e o monoaxial. E de diferentes diâmetros e comprimento. Como o Dr. Landriel mencionou, todos são fenestrados e perfurados, com exceção dos tornilhos de 4,5. O diâmetro é muito pequeno, não permite isso. A cor também diferencia, né? Pela cor, você sabe o tipo e o diâmetro. E aí mostrando o poliaxial, o pré-fixado e o monoaxial. Tá? Mais uma vez, aí a cor, no caso, são os poliaxiais, só pela cor você tem ideia do diâmetro. Isso facilita muito no manejo, no reconhecimento, no intraoperatório. Tá? Aí também cores diferentes, né, para diferentes diâmetros, e aí o parafuso monoaxial. E o parafuso de pré-fixação. Então, esse é o sistema. Além do sistema de implantes, baseado em tornilhos e hastes, esse sistema fornece também uma facilidade técnica. Uma delas é a perfuração do pedículo. É possível, por meio desse instrumental, você introduzir o fio guia por dentro dele, após perfurar o pedículo, e isso facilita muito e reduz muito os passos cirúrgicos. Isso vale tanto para aberto como percutâneo. Né? Aí mostrando aí a maneira como você perfura o pedículo com esse instrumento especial, introduz o fio guia e a partir daí, tanto aberto como percutâneo, você pode fazer todos os passos. Outro detalhe muito interessante desse sistema é o travamento do fio guia. O Dr. Landriel também mostrou o perigo de você utilizar o fio, principalmente o pontudo, e ele perfurar a cortical anterior. Esse sistema permite a colocação do fio guia, o travamento do fio guia, e com isso você pode introduzir os implantes, no caso os tornilhos, com muita tranquilidade. Tá? Permite a utilização percutânea, tanto curta como longa. Então é um sistema realmente assim muito, muito dinâmico, permitindo aí, com fenestrado, a colocação de cimento, já foi muito bem demonstrado, colocação percutânea, né? E aí depende do cirurgião, qual o tipo que ele quer utilizar, e permite ainda, percutaneamente, realizar compressões e distrações. Então, é realmente um sistema muito, muito dinâmico. Nós chegamos a, inicialmente, utilizar, no número até reduzido de pacientes, em doenças degenerativas, tumorais, em fratura, né? Foi até motivo de publicação. Na avaliação de todos os pacientes com 12 meses, todos os outcomes aí mostraram resultados favoráveis, né? Percebam pelo score, e também o SF-36. E vou aqui ilustrar com alguns casos clínicos a utilização do sistema. Então, o primeiro caso é dor lombar, com discopatia, paciente já operado, optado por uma artrodese de 2 níveis, aberta, né? Vocês veem o sistema, comparando o VAS pré e pós-operatório, com bom resultado, um caso em que foi utilizado aberto. Aqui um outro caso, também dor lombar associado à ciática, e utilizado aqui a cirurgia menos invasiva, porque como os parafusos são canulados, fica muito fácil realizar esse procedimento com abordagem menor. Tá? Então, já mostrando aí a versatilidade. Um outro caso, aqui já o segmento e pelos outcomes, uma boa melhora. Outro paciente também com dor lombar, com dor radicular, e aqui uma modalidade que a gente tem utilizado e com bom resultado em casos bem selecionados, que é a fixação unilateral. Né? Então, você faz o TILIF e fixa somente de um lado. Economiza a cirurgia, economiza material e também com resultado satisfatório. Outra paciente com um quadro semelhante, também realizado essa modalidade de fixação unilateral com o cage, né, um tilife de um lado só, e pelas características aí do implante que eu já mostrei, facilita muito esse tipo de abordagem. Aí percebam o segmento com boa evolução, um bom outcome. Tá? Com 6 meses. Essa modalidade não é tão difundida, do ponto de vista biomecânico, ela é inferior a colocar 4 tornijos, mas em casos selecionados funciona muito bem e você evita uma cirurgia de maior morbidade. Nas fraturas, aqui um paciente politraumatizado, caso grave, também a utilização percutânea desse material facilita muito. Né? Então vocês veem o aspecto intraoperatório da ferida, um paciente politraumatizado, com pouca morbidade, você consegue resolver. Tá? Aí já no segmento. Outro caso também de fratura, uma fixação percutânea, né? Facilita bastante. Em fraturas antigas como essa, você tem 2 opções. Você pode realizar tudo pela abordagem posterior, que é uma cirurgia de maior morbidade, ou fazer procedimento associado. Então, nesse caso, nós fizemos a fixação percutânea, né, posterior, e a corpectomia com o cage. Vocês podem observar o resultado aí com 1 ano de segmento. Tá? Outra grande aplicação é no tratamento das metástases vertebrais. O tratamento das metástases sofreu grande alteração, grande mudança nas últimas décadas. Esse foi o primeiro caso que nós operamos, onde eu trabalho, era uma metástase de CA de mama. Até então não se operava, era um tabu operar metástase. Fizemos aberto com um material antigo que eu mostrei. Na época nós não tínhamos carras, então nós utilizávamos placa de osteossíntese associada ao cimento para fazer o suporte anterior. E tínhamos. Com o passar do tempo, a cirurgia de metástase começou a ser realizada mais pela via posterior e hoje, graças à cirurgia de separação, porque houve um grande avanço na radioterapia, a cirurgia diminuiu bastante. Tá? E nesse aspecto, esse sistema também ajudou bastante. Então, hoje, seguimos aí essa classificação e, quando necessário, realizamos somente a separação. Tá? Lógico, quando tem instabilidade, também tem que reconstruir. Mas houve um grande avanço e o tratamento das metástases é bem menos mórbido do que era. Em algumas situações, como aqui, nem cirurgia precisa. Somente o tratamento rádio e quimioterápico é capaz de eliminar um linfoma. Em algumas situações, a cirurgia, como a vertebroplastia, auxiliou demais. Estamos vendo um paciente com várias metástases sendo recuperado aí, sem dor, já no pós-operatório. No entanto, em algumas situações, é necessário a fixação, né, para fazer o tratamento complementar com a radioquímio. E aí mostrando exemplo de fixação percutânea, pouca cirurgia, e o paciente consegue ter uma qualidade de vida muito boa, sem grande morbidade. Em algumas situações, no entanto, é necessário você abrir para fazer cirurgia de separação. E o que nós temos feito, de uma maneira caseira e muito simples, é utilizar a via de Wilson para fazer a separação e a fixação quando necessário. Tá? Então, com isso, a gente fixa. E a ideia é, em vez de utilizar 4 tornijos bilateral expondo tudo, temos exposto a coluna somente de um lado. Né? Quando possível, só fixamos e descomprimimos e, quando necessário, fazemos a reconstrução. Então, é um método menos invasivo, não é sofisticado, e o sistema permite isso aí. Aí, mostrando um condrosarcoma, vocês estão vendo que foi necessário reconstruir, colocar cimento na vértebra, mas a abordagem foi somente unilateral. Então, isso você preserva a musculatura do outro lado e fica um pós-operatório mais tranquilo. Em casos mais selecionados, como esse, você pode fazer a utilização do tornígio, utilizando a via de Wiltse, você coloca cimento, se for necessário, ali está representado, e a descompressão da separação foi feita por via endoscópica. Tá? Então, percebam que a morbidade, o tamanho do tratamento melhorou bastante. E o sistema ajuda muito. Aí, só ilustrando a abordagem que eu tenho utilizado, abre a pele no meio, preserva a musculatura de um lado e expõe pela Wiltse, ou, quando necessário, um pouquinho mais para fazer a corpectomia, como no caso, para tratar a metástase. Tá? E o sistema tem ajudado muito nisso aí. Em alguns casos que é necessário a fixação para efeito da radioterapia, né? Aqui, em casos como esse, você não precisa fazer a separação. Mas os colegas da radioterapia pedem para fixar, para melhorar. Então, você consegue, com esse sistema, fazer isso de modo percutâneo, como representado nesse caso e aqui, um outro caso. Okay? Então, é um sistema muito versátil, né, que trabalha hoje dentro dos conceitos modernos aí da instrumentação, segue essa linha que a URGS sempre preservou, de ser um sistema único para você poder tratar diferentes doenças da coluna. E essa é a nossa pequena experiência, mas tem se mostrado de uma validade muito grande. Okay? Mais uma vez agradeço o convite, foi um grande prazer estar aqui, sempre um prazer participar desses eventos aqui. Muito obrigado pela atenção.
Muchas gracias al profesor Heltol Delfino por su participación en este 7º Simposio Internacional de Columna. Agradecerle y a nombre del comité organizador un pequeño presente. Muchas gracias. Recordarles a todos, tenemos el coffee break. Volvemos aquí a las 11:50 para la plática del profesor Marcus Richter y les pedimos de favor participar con el QRS con sus preguntas porque viene la fase de las sesiones de preguntas. Gracias.
Dos, 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 dos. Cuatro, cinco, 6, 7, 8, 9, 10, 11, sí, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 22, 23. Prueba de audio, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Chino, le di más potencia a la bocina al lado izquierdo de aquella. 2 líneas. Porque Y, ok, prueba de sonido. Parece que todo bien. Sí, ey.
please kindly join us in the room, in the conference room. Thank you. Hello again. We invite you to join us in the conference room so that we can start our session. Very well then, we welcome everyone back, and we are going to resume our activities right after our coffee break. And now I would like to introduce Dr. Marcus Richter from VII with indications and techniques for advanced sacroiliac fixation. We will wait a couple of minutes more. Yes, welcome. We invite you to take a seat. So, as I was saying, welcome right after our coffee break in order to continue with the activities of this symposium. Next, I will introduce Dr. Marcus Richter from VII with indications and techniques for advanced sacroiliac fixation. Voy a esperar un par de minutos porque todo el mundo está apenas entrando a esta sala.
So, door is closed. Dear Chairman, dear colleagues, ladies and gentlemen, topic of my talk now is indications and techniques for advanced sacroiliacal fixation, and everybody doing long construct fixed to the sacrum knows that this is an area where you can have a lot of problems. What are the problems? First is we have the highest implant failure rate for pedicle screws if we use S1 screws compared to other levels, like screw loosening, like in this case, or screw breakage. And the risk factors, what are the risk factors? These are long constructs, 3 levels or more, a high implant load, for example, if you have to do a deformity correction, if you do a PSO, if you have a high-grade spondylolisthesis, and a poor bone quality. At least in Germany, our patients getting older and older, and the standard patients for a long instrumentation is above 70 years, and many of them have osteoporosis and insufficient anterior support. You have in L5S1 no good anterior support. There is a very high likeliness of an implant failure, and if you have an implant failure in this instrumentation, it's mainly at the sacrum. So we need some technologies, we need strategies for an optimized sacral and sacroiliacal fixation. First, I want to show you only some publications because I think it's important. First, on the placement of S1 pedicle screws. This is a good publication which compared the normal bicortical purchase versus the tricortical purchase. Tricortical means the screw ends exactly in the promontorium of the sacrum. And it's known from biomechanical studies that you can double the torque of the screw if you go tricortical. And what is interesting in this study, they showed if they use in shorter constructs only S1 pedicle screws, the implant failure rate, the non-union rate, is significantly reduced if you use a tricortical technique. I will come back later on this, but you see what is meant on these images. Next study is a study on biomechanical evaluation of S2 alar iliac screws, or also S3 alar iliac screws. The pelvic fixation traditionally in the last years was mainly iliac screws, but iliac screws have several problems. Therefore, people introduced S2 alar iliac screws. I'm doing now S2 alar iliac screws for 15 years. And they compared different combinations, S1 pedicle screw, always with a short S2 alar iliac screw, a longer one, and then they tried a quad cortical screw and an iliac screw. And they compared it to a pedicle screw alone. These are the constructs, not so interesting, and that's what they call tricortical screw. I would never do it like this, but they had the thought that maybe it's more stable than the normal S2 alar iliac screw. But interesting are the results. And what you can see that the pedicle screw S1 alone, that's on the right side here, this marker, has not enough stability. But when you use S2 alar iliac screws, the initial stability, important, this is only a biomechanical study. The initial stability is the same if you use a 65 millimeter screw, a 80 millimeter screw, or a quad cortical. And it's the same like the iliac screw, but it's no cyclic loading, it's only biomechanical. You have to keep this in mind, which means it's not so important from the initial biomechanical stability if you use a long screw or a shorter screw, but it's much more stable if you use S1 pedicle screws in combination with S2 alar iliac or iliac. And the question is, why not using iliac screws, or what is with the iliac screws compared to S2 alar iliac screws? And I want to show you this publication. It's a single study center which do a lot of these instrumentations, and they could show that you have a really significant reduction in clinical and radiological complications when using S2 iliac screws instead of iliac screws. So although the iliac screw is easier to place, the complication rate with an iliac screw is higher than when you S2 iliac screw. And I like this publication very much here. They had many patients and they looked over a long time what happens with patients. Yeah, they compared S2, S1 pedicle screws with iliac screws versus S1 pedicle screws, S2 iliac screws, as you see here. And I think these Kaplan-Meier curves are impressive. The blue one are the S2 iliac screws, and you see the survival of this without any complications or revisions is much better than the red one, which are the iliac screws. And one problem of the iliac screws, in my opinion, is, and therefore it's not my standard screw, on cyclic loading. The initial stability is good, but on cyclic loading, they are pure cortical screws. And on cyclic loading, you have a high load there, you have a higher loosening rate. And the second problem is, very often the screw head is more near to the skin in the iliac screw than the S2 iliac screw. And this makes also complications with pain or wound healing problems. So in summary, if in this study you have fewer reoperations when you use S2 iliac screws, you have less wound-related complications and the patients have less pain. So for me, this is a very interesting study and it's very important. And the next one and the last one, this is also an interesting study on the same topic. And what they looked, what is the difference in the distance between the screw head and the skin, and related this to complications. So they measured the distance between the screw head and between the skin, here in iliac screws, here in iliac screws, and they draw also for calculation where an iliac screw would be. And first of all, they could show that the screw loosening in their study was much higher. It was 24% compared to 8% the iliac screw, very high. And the symptomatic pelvic screw prominence was more than 10% of the patient with iliac screw. And then they made a correlation between the distance between the screw head and the skin, and they found a cutoff. If you have more distance than this cutoff of 23 millimeters, it's not very likely to have any wound healing problems or pain problems due to the screw. If it's higher, you have a problem. And there you see how many screws are below 23 millimeters. In the S2 iliac screw, it was only 3%, but in the iliac screw group, there were 31%. So with the iliac screw, its risk is much higher to have a small distance to the skin. So coming back, what can we do based on the literature to optimize our sacral and sacroiliacal fixation? First one is we should optimize short constructs, the placement of our S1 pedicle screw. It should be at least bicortical, better is tricortical, and you need a good angulation to the midline, because sometimes screws which are straight on. And then you have biomechanically a very low rotational stability of your construct. And you can use additional screws to your S1 pedicle screws. These are the ALA screws. They are only in the sacrum. They give some additional stability, but we nearly left it. If we want additional stability, then we use the S2 iliac screw, like you can see here. And an alternative is an iliac screw. If the S2 iliac screw is not possible. Sometimes you have anatomical problems that may not be possible. Here again an image of a navigated table with a S1 tricortical screw. And here you see what can be the problem if you want to have enough angulation. That's the iliac crest. You see this navigation image, and you see my instrument is where the iliac crest is. This is only possible because I resected a partial part of the iliac crest, get an adequate angulation. If you don't do that, then you have it quite straight. And this is a normal trajectory for S2 iliac screws. as well the trajectory for iliac screw. If you have no S1 pedicle screws, in some indication, tumors, fractures, implant loosenings, then you can do a sacroiliac fixation without the S1 pedicle screws. And in most of these cases, because the fractures or tumors, also S2 iliac screw is not possible. And what we always do, we place always 2 iliac screws on each side. 1 iliac screw in these cases is not enough. The S2 iliac screw is not stable enough for that. So coming back to this problem, the S1 pedicle screw. If you want to place a tricortical, you have to drill through the anterior cortex, especially in good bone quality, because otherwise you bring in the long screw, it pushes to the anterior cortical bone, it will not go through to turn further, and what happens, you don't have a screw anymore, you have only a nail. You have a very thick nail, but it's no more a screw. Yeah, because your bone hole is now the outer diameter of the screw. So if you want to make a tricortical, you have to perforate the anterior cortex, and before placing the screw, you need a K-wire which is through this hole. Otherwise, the screw has difficulty to find this hole. And therefore, several years ago, because it was a problem and you always had to make X-ray to see if the K-wire is not proceeding anterior, I developed this instrument. And this is quite good. It's a K-wire holder. You first put in your screw with a screwdriver, then you put in the K-wire and look that it goes through the anterior hole in the sacrum, and then you can fix it at the back. And there is a thread in the back, and the thread in the back is the same pitch like the screw. So with every rotation, you bring in the screw, you pull the K-wire back from the same amount. And this means the K-wire always stays in the same place without any X-ray control. So for this tricortical, bicortical, you can also use it in osteoporotic bone when you have fear that you have an anterior perforation, then you can use this instrument. It's quite useful, but it's very helpful. And what's important is, if iliac crest is in the way, don't make compromises, don't make a straight screw. You see a lot of these screws when we have to revise it, does not really work very well. And then resect the iliac crest, and then you get a good screw angulation for a longer screw and more rotational stability. And the side effect is you have less risk of vascular injury if you come out in the middle of the sacrum, because you all know the iliac vessels are more lateral. If you have a straight screw, you do it bicortical, you have a high risk of iliac vessels. See, this would have been the screw if you have no resection of iliac crest. So now coming to the other S2 iliac screws. What is the problem? First is, these are the entrance points for your pedicle screw. All know. This is the entrance point for an S2 iliac screw. That's for an S2 iliac screw, where you have to come a little bit more from the midline to get the correct angulation. And that's the entry point for the iliac screw. And you see, they are not in line with your rod, and especially in complex deformities and whatever, all know that bending a rod 2 planes is complicated. This means if you use here polyaxial screw, you have the problem, it's in a different position. You have to bend not only in the sagittal plane, you have to bend your rod also in the frontal plane, and this is not very funny and makes problems. And we have cancellous bone, we have no cortical bone, we have no pedicle, we have a reduced soft tissue coverage, and at the caudal end, especially long instrumentations, we have a very high biomechanical load. So what does it mean for the implants used? We need a cancellous thread, we need adequate screw diameters. As a standard, I take the 8.5, and then I have the 10 millimeter for the revisions. And you need, because it's in the caudal end, you need a very rigid rod screw connection. And if you use polyaxial connectors, you lose a lot of stability. You need a low profile rod screw connection, because we have learned that especially in slim patients, you can have soft tissue problems when you have a high profile of your spot screw connection. And you should have offset connectors which are stable and which are not bulky, so that you can bring your rod straight down and you don't have to bend it in the frontal plane. And therefore, we designed these screws 15 years ago. For those who have used neon, they know it's the same like the old neon screw, but it's much bigger. But it works very good in this place. These are the offset connectors, and here you see the difference in height of a normal polyaxial screw as well as this spot screw connection. And you have also, it's not polyaxial, you have different and correct angle. And that's what you see here. Sometimes when I have to revise patients which are operated with other implants, and they have stable screws above, I don't want to remove the whole implant. This means I use the S2L from the other company, and you see on the left side that an additional significant bending to the midline and the frontal plane is necessary. Here, I hate it. And here you see the rod is going straight down. There's no bending necessary in the frontal plane. Also, it's a little bit complicated to understand. I want to show you this short animation about this technique. I mean, for sure, you can also do this polyaxial screw, but in my opinion, this has significant advantage. These are the iliac screw placement, and this the S2L iliac screw. And the important thing is now you can, we have these connectors, put them over the rod, and then at this screw you have this pin type connector, and with this you can fix it. It's a little bit more fiddling, the fixation of the rod and the screw, for sure, like a polyaxial screw. Nevertheless, rod bending is much more easy. These are the different connectors again. And turning the screw, you can change the height rod if sometimes the rod is more high. And you can also change the angulation of the rod. It's not true polyaxial, you have a little bit to think about it, but time you spare in rod bending, you don't for instrumentation with this. So coming back, first clinical case, that's our typical patient, 81-year-old female. She's obese. She has a camptocormia with gait ability due to Parkinson's disease. She had a prior decompression for 5-5S1 and interspinal spacer, a degenerative disease for 5. There's the prior planning with a saturated profile with awful. That's intraoperatively. We use an intraoperative CT. That's the intraoperative setup. These are some of the navigation images. And that's the result. And maybe you ask why I have on the right side a lot of cement. Everybody knows. Because I made the derotation, and on the side where I made the derotation, I used cement in the old patient not to have a screw loosening in areas. When I do in the older patient the implant, then I use cement side compared to your planning. Another one, quite similar, kyphoscoliosis with second depression spinal. That's a typical patient case. We did an anterior release and A-lift levels, and the posterior instrumentation. Again, there is no rod bending at all in the frontal plane. This also an interesting case, but highly unstable. This was a patient, he had an instrumentation, L3S1, and then fall down, had osteoporotic fracture, complete destruction of the sacrum, and in this case, I want to have as much as possible, so here I did a combination of the S2 iliac as well as an iliac. You can combine it together. And these are the standard patients where we still use iliac screws, tumor structure of the sacrum, and in this case, the only possibility are iliac screws, but I never rely on one, always side to have an adequate stability. So in summary, We have the highest implant failure rate in sacral fixation, the whole spine. And in my opinion, what you do should be adapted to the individual case, the biomechanical things you have, the biomechanical load you expect, and then you can reduce implant failure. Always optimized S1 pedicle. Not so difficult, but it's much more stable. And if you need an additional stabilization, you can use the S2-Ala iliac screw. And the S2-Ala screw, not very frequent, or working horse, the S2-Ala iliac screw, and you can same on S3. They are a little bit shorter, they are a little bit more difficult, that's fine. And in my opinion, we have an optimized implant system developed, which has a lot of benefits, I showed you, and for the patient and for the surgeon better, because we all know after 5 hours operation, rod bending may be a problem, and you have bending of the sagittal profile, and then you have the midline at the end. It does not work very. Thank you for your attention.
Damos las gracias al profesor Marcus Richter por su plática, por este apoyo en este simposio. Agradecerle toda la experiencia, todo el aporte en estos casos que nos viene a presentar. Muchas gracias por todo. Les pedimos a los profesores que nos pueden acompañar, por favor, aquí al frente para la sesión de preguntas.
Thank you very much. Thank you very much. It was really a pleasure to be here, and it's very great conference. Thank you.
Vamos a comenzar con las preguntas del sistema y después procederemos a las preguntas del auditorio que tengan que hacer para uno de los profesores.
Dos, tres.
All right, we are now going to start with questions from the audience. We have a question for Dr. Delfina. In what percentage of your surgeries do you use Pedigar, and particularly in which cases would you advise its use? In Brazil, we have to consider the economic factor. Unfortunately, he's speaking in Portuguese, and we do not have translation from Portuguese available.
Utilizo somente em casos muito especiais, como o que eu mostrei, tá? O que é uma desvantagem pelo custo. Mas se eu pudesse, eu utilizaria de rotina, porque o grande benefício para o cirurgião, além da segurança da acurácia intraoperatória, é a quantidade de radiação, né, que diminui bastante. Ok?
Muchas gracias, doctor. Para la doctora Marianela Campos.
Marianela, what percentage of spine surgery do you use transop neuromonitoring? What happens is that I am a neurosurgeon, and as neurosurgeon, we not only operate on the spine. So for me, it would be difficult to answer. I can tell you a third of the surgeries are being monitored. Won't help you to realize what is the number of spines that we operate on. It depends on the specialty hospital. There are hospitals where they perform many complex spine surgeries, and they have will have over 40% of cases being monitored. And it varies from hospital to hospital. I'm sorry, I cannot give you a better answer. Dr. Federico.
Les aporta el
About less than 120 ounceal units. Have you observed any correlation of this measurement in patients, and what levels have you found the T-score in your patients? We have not carried out studies to determine the equivalence between Hounsfield units with bone density measurements, because if we look at medical literature, it is very difficult to take Hounsfield as a unit of measure, but we do not have developed our own system, our own measurements. Dr. Richter, what advice would you give to place S2 screws iliac and use navigation? Es una muy buena pregunta. Lo primero es que se necesita un punto de entrada correcto, que es más medial de lo que uno pudiera pensar.
Thing is, you have to remove the spinous process to get the adequate angulation. If you don't do this, you will not get the adequate angulation. So where you are for your in the level S2, you remove the spinous process, and then it's important to have the correct angulation, and that's the most difficult thing. And with navigation, it's much easier because you can look where is the best place. You can also do it without navigation. To be honest, I never did it without navigation, because since 20 years we navigate every screw. So for us, navigation is a standard, so we have less radiation and so on. But I know colleagues, they do it with radiation, with X-ray, but it's more difficult. It's more difficult to get the angulation, and if you have no navigation, I mean, iliac screws are easier to place. That's true, but from the clinical point of view and from the biomechanical point of view, the S2 iliac screws have some significant advantages.
Y ahora una pregunta mía. En ese caso,
Question. And the use of the in and out trajectory of a screw, do you contemplate that before the placement of the screw? Perdón, no entendí. ¿Puede reformular? ¿Se refiere a tornillos y ilíacos alares?
Yeah, you need inlet and outlet view to see that you're in the correct position. But it takes a lot of X-ray if you want to do this. So to be honest, navigation in this case is very beneficial and makes it quite easy. Because if you don't use the navigation, you tend to be more lateral, and then you get a cortical breach to the sacroiliac joint, and then you have less stability. But people which using polyaxial pedicle screws, they always try to tend to go more lateral, so they don't have the big problem with frontal bending, but then the screw is less stable.
muchas gracias.
La siguiente pregunta sería para el doctor Delfino. Doctor Delfino, ¿qué tipo de cánula pedicular prefiere usted a la columna torácica? ¿La recta, la curva, canulada? ¿Por qué?
Eu prefiro usar a curva.
Because it depends on the technique, but I prefer the curved one. The professor is speaking in Portuguese. We cannot offer translation.
Costume, porque acostumei a usar esse tipo de probe. Mas é a mesma coisa, não vejo também grande diferença. Tá? No começo parece estranho, porque você quer fazer um orifício piloto reto e usa um probe curvo. Mas ele ajuda a desviar da parede medial.
Esta pregunta no está dirigida a nadie en particular, aunque es referente al tema.
But it's related to Dr. Federico's topic, and it's open to everyone. Do you use non-cannulated screws or non-fenestrated screws, that is conventional screws with augment? Do you use that?
We never use non-cannulated screws, and we never use non-perforated screws. So this is our standard screw, and this has a very big advantage because sometimes you decide during an implantation of the screw if you want to use cement or not. And if you have a non-fenestrated screw, you see the screw purchase is not good enough, you throw the screw away, at least in Germany, because you cannot use it anymore. And then you take a new screw. And therefore, the implant system I use has only cannulated and perforated screws, and exactly for this reason.
Gracias. No, nosotros tampoco utilizamos tornillos.
Screws without an intermediate hole. This was a technique described a long time ago. And the advantage of fenestrated or cannulated screws had to do with how difficult it was in the past to use cement in a non-perforated screw and all of the difficulties associated to that technique. And this is why we saw the development of a new technology. But of course, we need to have the right instruments in place for our surgeries. If we do not have the right screws, well, therefore, the result won't be as expected. Now that you have the microphone with you, Doctor, yes, please, go ahead. You wanted to make a comment. Apparently, no. Well, when talking about screws with augment, do you make projections during your AP's work, or do you work from a lateral approach only? Well, it depends on the patient. We almost always work with lateral projections. But if we have a doubtful image and we suspect a leak, then we look for oblique projections or an AP view in order to determine whether we have a lateral leak. But it depends on whether we have a fracture or metastases. But if we are using the right technique, as with the placement of any transpedicular screw with minimally invasive technique, we use the necessary projections to take the K-wire to the joint of the two posterior thirds with the anterior third of the vertebral body. But once we have the K-wire there, the placement of the screw is easier. But of course, when it comes to cement, we have to look at the right views in order to try to avoid excessive use of x-rays. But if we know that we need almost 2 syringes to fill that extender, then it doesn't make sense to take x-rays when we are cementing, because then we were going to be exposing everyone in the OR. Well, thank you. We have time for a couple of questions from the floor. Would anyone like to ask a question at this point? If not, we will resume our program. We thank the professors for this roundtable discussion. And continuing with our program, we have a clinical case presentation for discussion, and this will be led by Dr. Aurelio Ramirez Consuegra. I invite you to participate using our QR code. Good afternoon, everyone. I am going to be presenting the clinical case that we are going to open for discussion.
Okay, this is a quite complex case. of a 72-year-old lady that is diabetic, hypertensive, and with a regular control, but she doesn't exercise and is overweight. Started with lombalgia of a long evolution, with paresthesias that were specific, and part of the process was neuropathic because of diabetes. Apparently, there was some pain without any specific origin. The original physical evaluation was carried out by someone else, another doctor somewhere else, so I have no more information, but only what she referred to. She was originally treated a year before the pandemic started. Now, in her evolution, you'll see step by step how this progressed. Due to her involvement and to the fact that she used to live on her own, she moved and started living with one of her children, and she lost almost everything. These are the only images that I could get from the initial evaluation. As you could see, there's a degenerative arthrotic process from 4L, 4L, C1, C5. Eventually, this might lead to a stenosis, and this is all what we could rescue from this original evaluation in 2019, because she moved and she lost it. It's a little bit complicated sometimes with such little information to ask for dynamic studies or some other ones. But with that in mind, we'll continue analyzing the case. First of all, and with that little amount of information, as if it was an online consultation to a patient, what would you recommend a priori? And probably if you have no information and you don't want to render your vote, I understand, no problem. But I kindly invite you to take that option. Well, the trend goes this way. Basically, you're proposing a conservative management, and at some point, if it was to do something that should be minimally invasive, probably someone could think of a larger decompression. And finally, very, very few of you think that an ample decompression would be the way to go. More or less, we have a consensus on the same thing, or having number one as an answer. Sorry, instrumentation, yes. In option number one, it moved between conservative number. I agree. Thanks for your observation. So the first point would be instrumentation. We are split, but most of us think that instrumentation is a way to go, and that is exactly what was carried out with her. We first started handling it surgically. We remember that the injury is low, and 4551. At the beginning, we made an laminectomy in the somatic cage, and these are part of the studies that were lost beforehand. All the information we have is information that she gives us. The problem is that she came to the hospital and started with an infection in soft tissues in the post-op stage, and at the hospital they gave her some conservative treatment, and they retreated the instrumentation and did nothing else. There were 4 or 5 surgical cleaning and washing of the area without any further treatment, and there were some just details that in the evolution she repeatedly complained about being in pain. She got antibiotics from a group from infectologists, and at the end this continued being a problem. At the end, they carried out a new washing up, and they presented a different alternative. And it was at this point that we got the chance to have a reassessment of the whole case. As an initial assessment, as any chronic patient, this is difficult to handle because the patient was already saturated with painkillers and many different kind of drugs. And she came to us practically saying, whatever you can do it, but please do it now. She was already overwhelmed and very demanding to stop pain from her body. And she was under an depression, of course, because she didn't evolve positively. And with her evolution, we noticed that lumbalgia was basically a mechanic evolution. That when the patient was lying down, she didn't refer any pain, but the moment she started moving, then she needed to go back to lie down position. So that was a sensitive mode of deficiency or disorder, but it was not specific. First of all, because she was in pain all the time and she didn't want to collaborate a lot, and because of the diabetic and rheumatic pain because of this. So there was a generalized hyporeflexive status that she presented, and this was all what she referred to. Before moving into, or before undertaking the last washing up that was being proposed once again, we found this, or we got these images. You must remember the first image we had when the sclerosic started and the stenosis 455 at 4551, and now cementation is 34, and there's an intersomatic or interbody cage here, and the simple plates were lost. So there's an important inflammation and infection process. They haven't lost the harmony of the vertebral bodies. They remain being at the same height. But with that, we established another diagnosis that was a spondylodiscitis. And I want you at this point to give us an ARS observation and tell us which of these four is the way to go for you. Let me go back so people can read the alternatives. First, number one, removing the lumbar instrumentation. Number two, that is bars and screws. Third, talking about cage. And fourth, culture, taking samples for culture. At the initial post-op assessment, no clinical changes. The patient appears to be in pain. In the culture, we found a staphylococcus. That is, it's new for you, lugdunensis. I didn't know about it. Sensitivity. We work hand in hand with an infectologist that is very experienced on these kind of cases with infectious diseases, and he has given us lots of support for years, and he helped us in this case too. After giving antibiotics for 3 months, there were 4 different types of antibiotics. I wouldn't like to get into details because of time issues, but this is after giving antibiotics for 3 months, and we can perfectly see the shade of the cage that was used before. It is there around now. We have a lysis, and there's no vertebral body at all. It doesn't look like the original studies, and at this point, the cage is a threat of a channel. No clinical changes. She continued in pain, and we are half a year after the initial management we did. The cage was there, buried and lost at some point, and at some point we would have to take it out. The problem was the following. After 7 months of providing her with antibiotics and with pain that now has become real intense as in association with the changes of posture, the last time she came to my office, she came lying down. She was on a stretcher, and we made some X-rays. We saw how the cage came to the foramen, and it worked as a valve. It was working as a valve. I have never seen this before. She was in much pain, of course. We didn't want to get in, but we had to. At the end of what we did was removing the cage, and we went lateral, and we found it, and we thought it was going to be a big deal, but honestly it wasn't. We could remove it just like that. It was quite simple. It was floating. And we decided to current and to wash everything up, and it was the same problem. Bacteria was affecting that. After 8 months of treatment, we see how the inflammation, especially in soft tissues, became quite limited. The vertebral bodies were lost. Practically 3 and 4 were completely lost. At this point, after 10 months of antibiotics, the infectologist said, oh, come on, please give me a break. Reactants in acute phase are already in remission because of calcitonin. Whatever the infectologist requested was done. Apparently, we were in remission. The patient, however, was really, really nervous. So these are the proposals of management. What treatment would you give him? First of all, to keep having a conservative treatment at the free evolution. Number 2, using a short reinstrumentation with approach coming from the frontal part and leaving the other approach on the side, or probably having number 3, a ventral approach with a corporectomy from L3 and T4. And that would be number 4, that would be using the long instrumentation. So some of you prefer to have a conservative treatment, but I guess the 2 last ones are more or less the same. The problem is at the front, so you should approach it from the frontal part. Remove the body, work on the replacement, and have a new plate. Just a detail to share. There came a time in which, there comes a time in which it is important before a situation like the one I'm talking about. We should see how much we can do with this management. In fact, I do work with a very experienced team. We have worked on these kind of cases for many years. We always do it as a team, where I work with Dr. Victor. He is an expert in this situation, and one way or another, this is what we did. We started by using navigation, and with that we started with a cemented navigation with the last thoracic elements and moving them to where we could move them downwards. And we only had the 5th one. Let me show you an animation we have. And in the bottom section, we only have the sacrum, L5, and the iliac ones. I'll give you this image because there's just a technical detail. We had a technical difference with engineers. I didn't really understand it, but I could not get navigation further away from the 10 centimeters after the screw. So we could navigate until the Lesla, and then we navigated with the guide, and we did this using fluoroscopy to really see where the iliac screws were staying. That's why you can see that this is a compound image with a fluoroscopy and a navigation image. I don't know, for some reason, after 10 centimeters depth, I lost the image. So this is the result of what was done. We had a T12 instrumentation from L1, L2, L5, sacrum, and the celiac screw. This was complemented by a large amount of bone. The tissue was clean. At least we had evidence that in the posterior area there was no infection. However, as a routinary measure, we took some culture and we applied a good amount of bone graft. After discharging the patient, we wanted to have evidence of what has been done. This was intra-op, and we could easily see what remains from L3 and 3-4, and L4. Now, this is information from last year. This is the evolution of the patient. The pain that she used to have when she changed her posture changed. We didn't let her to walk around. She was under anticoagulants for long. And these are the results of the assessment. She improved mobilization, and in reactance in the acute phase appeared to be normal before, and we could confirm that the patient really wanted to start walking. What is it? What do you propose? Number one, leave the patient that way. As a result, she is painless, and we could start the ambulation. Or shall we keep walking with or keep progressing with all the anatomic changes that were carried out? And in the corporectomy, I'm proposing a replacement. That's number two. Or probably number three is any other proposal. The first option is leaving her like that, just to in free progression. No, there are fewer people that think that the anterior approach is a way to go. Now I'm going to ask you, please remind me about asking you for a fourth option, and put it under discussion. Honestly, I cannot think of any other one. Let's move on. Well, so that's what we do. We started working anterolaterally in surgery. It's important to mention the following. Usually our anterior approaches go the usual way, but I guess this case especially was quite complex because of the anatomic changes that took place and from the inflammatory processes that were there and the adherences we could have to all the vascular structures that could appear in our way. We also had the intervention of a cardiovascular colleague. He was part of my training, and I started working with Dr. Cruz Lopez and Dr. Hernando Cuevas. So they both helped me out and coached me in the fellowship to train me in the thoracic lumbar approach. So here I need to confess myself. I was guilty of the following. Traditionally, when you take the frame and you put it in, you have to get a little bit lateral in order to have the fluoroscopic vision. But I asked the surgeon to do that more anterolaterally, because for a recompression, I usually use the microscope. And to get lateral, for me, it is difficult because apart from having an obstruction that is a wall, I run into a problem. At some point, I'm going to find the channel, so I'd rather go from the front and always have the vascular structure displaced in a different place. Okay, that is something routinary, but Israel doesn't like to do that. He was really angry because he didn't want to do that. He stopped talking to me for some time. He didn't even say congratulations in New Year's Eve. But now he was really angry and upset with that. He was not comfortable, but at the end, well, we could get the implant in. These are the control tests that we had throughout the surgery. This was the best that could be done. Whoever tells me that down there's no support, yes, that's correct. We have no support, but there was no place to get support from. This was the situation at the beginning of February this month. And those letters were not placed by me. Probably the technician inspired and gave us different levels. But in this image, we can see how the cage has already been seated. There are plenty of images just for you to see that it is already in the center. This is a reconstruction. I don't like it very much, but at the end it gives us a look of the harmony that you can see in the instrumentation. And this is the patient's current status. At rest, the patient appeared to be painless. She has started deambulation. She never stopped having a passive rehab at home, so she continues working on physical therapy with the rotation, movement, etc. So she was efficient on the bedside, on the bed, and hyperreflexia appeared. It was in general good status, and she told me, "Oh, once I've forgotten about how to walk." There is an important and generalized hypotonia, and she lost a lot of muscular mass, and she is now sarcopenic. She does not want to keep having analgesia. She simply has a visual repulsion to that, and she immediately feels she doesn't want to have it, and she starts feeling bad. I don't know if that happens to everyone, but she is addicted to pregabalin. She does not use any patches or anything, but she continues under physical therapy. Yesterday I made a call with her, and she has been feeling well. She keeps evolving, but she keeps feeling weak. However, she's painless. Now, let me open the floor for a final discussion. Shall we? Is there anyone who would like to ask a question, probably make a remark on this case? In my opinion, the resonance seemed to be quite white, probably with a lake of pus. I don't know. Was that a problem because of the infection? No. There was nothing bad. Another question. After being on the bed for so long, did she lose weight? Because at the beginning you referred that she was obese, so now probably she's lost some weight and she's okay now, no? Yeah, now she's seeing her weight, of course. So at the end, these cases are terrible. I went through a similar one with the cage in R4L5, and at the end, the patient could have a good evolution because of the therapy and physical therapy. And at the end, there was no need to remove the cage, but the cage stayed there. However, the patient became dependent of what you mentioned. Yeah, and the images, we didn't have any previous images, but there was instrumentation at the beginning. The first initial step we took was removing instrumentation. So is there anything you could contribute within this case that was presented? What would you have done in that obese patient that is lying on the bed with a displaced cage and affected instrumentation that had an infection? What would you have done? Todos sabemos estos casos son muy demandantes en realidad. Mi comentario va más en sentido de ser más agresivo. Cuando sabemos que hay espondilocitis, el paciente se vuelve un paciente que es operable. Entonces yo recomiendo la operación con una estabilización posterior y una
tissue and make an anterior support if it is vertebral body replacement or a big cage or whatever. But we are much more aggressive. And there are now very good multi-center data. They were also presented on the German Spine Congress, and they won the Speech Prize. They could show in several hospitals that with conservative therapy of spondylolisthesis, especially postoperative, more people die than in operative therapy. So it's clearly that the mortality of the conservative therapy is much higher than in the operative therapy. And if the patient is able to be operated, if the patient is willing to be operated, we are very aggressive and very early. What I would not do, I would not use cement in an infectious case, because you never know if you have some bacteria there, and the problem is if you have cement there and you have an infection, you have the next problem, because you have to do another vertebrectomy. So no cement, and maybe we would have been in the upper area a little bit shorter. maybe we would have instrumented to L1, and then later on we would remove the screws and give the segment free if everything is fused. So I would try to be a little bit shorter.
Muy bien, maestro, muchísimas gracias por su comentario, es muy valioso. De hecho, en algún momento lo consensamos, el doctor Israel y yo, en ese sentido, si usábamos cemento o no, porque parte del problema es que la
Whether we or not we should use cement or not, because one fact was that there was a terrible bone quality, and she had already had problems in an and she had had osteopenia, and she had had endocrinological treatment. So we discussed on that. An advantage that we had with her is that she had a high level, economic level, so she was really supported by her family. She had a lot of support from a nurse, and she was not abandoned. People, she could really mobilize herself every day, and specialists were working together, infectologists and the physical therapy. So the reason we waited was to have evidence that there was no infection, because we wanted to make a cemented instrumentation at the beginning, basically because this patient had already undergone a complicated process. So one way or another, we wanted to have a definite solution, and that was why we were kind of slow. Well, just to wrap up, I guess we've gotten the answer for this question, but this is a brief summary. What was the surgical indication in this patient to place the anterior implant? Because in the posterior procedure that was already stable, an infusion, so why risking the patient to a second surgery? Thank you. This is a question from the audience. Just to remember that at the end, bacteria are present in the body and the vertebra. So it is important that they will leave the area on when the moment we take the structure away. And the second point would be the capacity of loading. I mean, the possibility of breakage. The level of screws was high, so the idea was removing the infected bone and get the best support we could have, or the most efficient one we could have. This area was discussed to the patient, and we told her that there was a high risk of complication and bleeding, of course, of death. The guarantee that we offered her, if we can talk about offering a guarantee, was that we could get the support from a vascular surgeon, and Dr. Israel and me, with the experience we've shared, we got the responsibility on our shoulders, and the patient said, yes, okay, let's do it. So we are really aware that that meant a big risk, but it was necessary at some point to run the risk to guarantee her a better evolution. We don't know. I mean, she's we continue in the post-op stage, but well, let's wait for some news. Let's see what happens. Is there any other question? Hi, Dr. Espinosa Lares from Hermosillo. Doctor, let me tell you, your case was quite interesting, quite complex too. The situation here is that if we do have a latent infection in that surgical spot, considering that, didn't you think about using or placing bone rather than a synthetic implant? And I have a second question that refers to the expandable spacer. I guess this is not in an angulation, is it? Oh, yeah, it is in an angulation. Yes, and the implant was filled up. And we used both techniques. The implant was filled with bone. However, I also share the opinion that if we already have an infection, a previous infection, the best thing that you could do was removing the cage, and that took you, for that reason, it took you longer. There was a delay, but for me it is too risky to try to place a second implant. I've been told that that was a little bit primitive. I mean, placing bone was primitive, but for me, from my point of view, it is easier to treat an infection with bone. Well, I share the same criteria because De La Huerta professor told me that there's no better antibiotic for bone than a bone. So I do agree, fully agree with you. The detail that we had here is that we do not have a surface that was a good one to let us use this fusion with bone. And we did feel it. We used this combination of elements, and that was what got us to a good result. But yeah, I do agree. We have another detail, and let me insist that her bones are not in good conditions. Talking about the criteria of removing resected bone, I guess that is a general consensus. Dr. Richter explained that before. We should go for the procedure. There's another question down that side. Sorry, due to time limits, Professor. Okay, sorry, he's been raising his hand for hours. This is the last one. Morning, I'm Jaime Becerra, a neurosurgeon from Bogota, Colombia. Which is your experience on carrying out corpectomy all at the same time, all in one single surgery with an extracavitary BCR, and at the same time avoiding taking longer for rehab or this time in which the patient was going to be in the cubitus position? I mean, due to time limits, I omitted some details. Anyway, we went through some extra details, but something important was that we operated her with surgery because she used to be a cardiopathic patient. She had low blood pressure during the operation. So cardiologically, she was an unstable patient. She's an unstable patient. So partially answering the question of why the cage was left there. Well, this was for the presentation, Miss, but in our discussion, we evaluated removing the material, attacking the infection, getting in the posterior and then in the anterior approach. The only thing that made us change this was, removing the cage before, but at the end, the block of what we presented is what at the beginning we got into a consensus after discussing it. So the physical conditions were not good because of Asa and Goldman conditions. They were not in good conditions. So all those elements were the ones that made us lead to this decision. Thank you very much. We'll continue with the next module. Thank you very much, Professor.
All right, so we will move on with our program. And next, we will be discussing the treatment of primary spinal tumors and vertebral metastases. And this will be a topic discussed by Dr. Federico Landriali. All right, let's talk about vertebral metastases and primary tumors. I would like first to share with you the concept of defining our own scenario and see what means we have available in each of our hospitals and how we manage metastases at our hospital, the Italian hospital in Argentina. We have good technology in the larger cities of our continent, but even in larger cities, there is much disparities and there are centers that don't have the right technology in place. And this is important when it comes to decision making in this pathology. Global CAM is a group that measures incidence and prevalence of tumors. This is an international group, and in the last census in 2020, they determined there were about 20 million new patients with cancer per year. And we know that in the course of their disease, 40 to 70% of the patients with cancer will develop metastasis along the spine. But we are used to seeing metastases, and we know that the majority of the metastases are not surgical. And if we look at the lower figure, 40%, we would have 8 million new patients per year, and from 5 to 10% of these patients will have some form of nerve or medullary compression that may require our intervention as surgeons. But we also need to understand that in the treatment of this pathology, we are part of a multidisciplinary approach, and it is probable that the best approach to this pathology is the systemic approach, whether immunotherapy, chemotherapy, or stereotactic devices. And we usually participate when there is a symptomatic medullary decompression or where there is an instability in order to obtain the surgical stabilization of the lesion. But we are just part of the solution, and this is important when we have to select surgical treatment, because stabilize a patient with a long incision will delay radiotherapy by 1 or 2 weeks. And even if there are, well, considering that there are no complications, but if the patient has an infection, we can even take longer and therefore delay other treatments that may be more effective than our surgical intervention. To define our own scenario not only has to do with the surgical component. We can be skillful surgeons, or we have had probably excellent training with excellent surgeons, but in my case in Argentina, we didn't have the right devices at the hospital, and therefore we have to refer our patients to other hospital for an echo, and this delays treatment. And of course, this has to do with our own scenario, with the options of taking a biopsy and have quick results. So all of these things need to be taken into account. If we do not have imaging technology or right technology for biopsies, then we need to contemplate that. Perhaps we could operate on a multidisciplinary center, and that would be the best option for the management of our patients. So we need to understand which is our scenario and our options to RCBT, which is a limited option, at least in my country, and we know that the access to radiotherapy, to navigation, would be a drastic difference for our patients. So this is important. And now that I'm talking about surgical devices, we have to understand that things as simple as a drill, if we do not have a drill, we probably won't be able to perform a minimally invasive decompression in a patient with metastasis, because it will be very difficult to open a canal and decompress and release. So these small things have also to be taken into account when we propose a specific surgical approach. We work with the NOMS framework, which you probably know about. I will simply review it. The neurological component has to be with the compression of a tumor over a nerve structure, and the scale of medullary compression, which is the Vilsky scale, looks at the image in an actual view, because we have a disappear of the cephalic liquid, and the grade A1, C2, and 3 are associated to some neurological symptom caused by the compression caused by the tumor. And this is a classification independent from the surgical treatment. That is, if we have a compression, we need to decompress unless the tumor may be a lymphoma, a myeloma, or a seminoma, because these tumors can be treated with systemic treatment or with radiation. So if we look at these three variables, and these three variables may not require a decompression. So this is why it is important to first find out what kind of tumor we're dealing with. And of course, this also has to do with the stability and whether the tumor is causing lesions in the pedicles or the vertebral body. And we know that between 7 and 12, that is an intermediate level, and we need to determine whether we are going to be promoting the instability with our surgical intervention, and therefore we have to look for other options with a different type of fixation, with cement, with screw, but not involving chemotherapy, because we know that chemotherapy will not solve the instability of the spine. So once we have looked at the neurological component and the mechanical component, we have to look at the oncological component. That is, how resistant are the tumors to radiotherapy. And here we're talking about conventional radiotherapy. In our country, we have stereotactic surgery, SBRT, and no tumor can resist that amount of radiation. But as surgeons, sometimes we need to prepare the space in order to protect the surrounding structures. And with open or minimally invasive techniques, we can provide the 2-millimeter separation required as to not to damage the spine with such a considerable power. Now and then we go to systemic component. Whether the patient is a candidate for surgery or not, whether the patient can tolerate a surgical procedure or not. This is a female patient, 74 years old, with mechanical pain. She presented breast metastases. She presented metastases along the spine and in the viscera. Now, what she didn't, she presented a TILC type 1C compression with no myelopathic symptoms. This was a radiosensitive tumor with a SINS of 12. But we would have to evaluate whether this is a candidate for surgery or not, with multiple metastases outside the spine. So what do we do as surgeons? Well, we'll look for classifications. So if we look at Tokuhashi, we had 6 months of survival. If we look at Tomita, her survival was from 6 to 12 months. Bauer, non-surgical approach. With Oswestry, 6 months. And with SOR, 80% 3 months and 50% of survival 12 months. So I would like to underscore the benefit of having a multidisciplinary approach. That is, we need oncologists to help us in the decision making, taking into account the patient's survival. For instance, for breast tumors, the gyneco-oncologist will help us because it's not the same to consider luminal A or B, and all of these changes would have an impact on the patient's survival. So we need to have a multidisciplinary approach. They gave us the okay to operate on the patient. We proceeded with a short fixation, and this was among our first cases. Perhaps today we should have performed a much shorter fixation, and we had a mini open decompression in this case, as you can see here, and the post-op control. This patient had a 12-month survival. So the classifications that we use sometimes require additional information, and that's why it is important to have a multidisciplinary approach, and in this case, ask for the input of oncologists. Now, let's look at another female patient, 76-year-old with mechanical pain with a VIS score of 8/10, and she had motor alterations due to the complications she had in T6 when we had the lack, we had a pressure with a significant compression. In T8, a compression 1B, T9, 1C, T12, no compression. So we still don't know what type of tumor we're dealing with. We are now going to look at the mechanical component in T6, T8, T9. So these are stable lesions that do not require surgical stabilization. In T12, it has a sense of 13, so that would be an indication independent of fixation. So we know that in this segment, we need to perform some type of stabilization. So what we did, we fixated there. What do we do? What's missing with this patient? Well, what's missing is to know what type of tumor we're dealing with. Because it's a corticoid, we need to know whether we can go from Asia D to Asia E. So we need the oncological input. Do we have time for a medullary decompression and wait for results? So we always are looking for a 48-hour window in order to decompress, because if not, the patient neurologically would have lower chances to improve if we decompress after the 48-hour window. But studies have demonstrated that from the beginning of symptoms, very few patients can wait 2 days, because oncological patients oftentimes have many comorbidities, and studies take a long time to be carried out because usually the signs are very mild initially, and the patient is usually first looked after by palliative care and then the oncologist. So we have a very short window in order to obtain any improvement by decompressing the patient. So it's not just a matter of performing any surgery to do something, because if I am in a hospital when I have no screws, I have no way to fixate, and we don't want the patient to be paraplegic and then we decompress. That is not the right way to do things, because then we would be adding on problems. We would be removing support, and then in the long run, we will worsen things because we will destabilize the spine further. So it's not just decompressing because we can decompress. Another component, important component, is biopsy. In this case, the patient presented myeloma. And this is important to know because this compression perhaps may not require a surgical decompression. So what did we do? We decided to operate on this patient, and we also complemented with radiotherapy. In T6, with radiation, we were able to reduce medullary compression, and there was a significant decrease in the volume of the tumor, and so we saw that we had to stabilize surgery. If we look at the advantages of minimally invasive surgeries, when we can have fixation with 2 levels up or 2 levels below, and that will mark a significant difference in terms of how much we open the skin, because I know that we can place percutaneous screws or open screws, but the thing has to do with how fast will the skin heal. And how fast can we start radiotherapy with small percutaneous lesions that may enable radiation therapy before 1 week after surgery? So we need to take that into account. If we can perform with a minimally invasive surgery, the better. So the take-home message is know your to the arsenal of instruments that you have available, and of course, my multidisciplinary approach, and remembering the window of opportunity. And now I will move on to a totally different type of tumors, primary spine tumors. These are much less frequent than metastases. But we need to always think about these tumors, because if not, whenever we hear gallop somewhere, we always think about a horse, but it may be a zebra. So we might, if we think that we could have heard a zebra, then we would be misinterpreting the patient or the tumor that we have. Because if we have a malign tumor or a benign tumor and we treat it as if it were a metastasis, then we would be removing a therapeutic option for these patients. And we have malignant primary tumors that are resected en bloc, then we can bring a positive opportunity to patients, and to other patients we can extend the disease-free period. But if we do not operate the patient correctly, we would be eliminating this option. So whenever you are in doubt, when you have you have to take a sample in order to know what type of tumor you're dealing with. We use Enneking classification and the WBB classification in order to plan our surgeries, and the main indication for surgeries in block for primary tumors are very aggressive. In this case, we lower the possibility of having that tumor come back, and we are also preventing the dissemination of the tumor. So a block resection is very good, but we must not lose sight of our secondary objective, which is not to leave our patients with a significant neurological defect. So we know, for instance, that we need to take into account the possible consequences of our intervention, because if we preserve a single root of S2, 25% of the patients will maintain bladder function, and we will, if we cut below S2, then we are going to preserve 40% of the bladder function, and by 50%, we will be preserving bowel function. If with a S3 resection and below, we will cause immediate sexual dysfunction, and the patient will not be able to ejaculate, that is, to have children. But we will try to realize that these may be secondary objectives. So when we're between saving the patient's life, or sometimes if we can spare one or two roots, we can save or improve the patient's life. So we need to plan our surgeries, because these are major surgeries. Of course, we are almost always going for minimally invasive surgery, but here we have to turn off the minimally invasive mode, because these are extensive surgeries. We always need to look at secondary objectives, which is to preserve neurological function. So what do? We start planning virtually in the pre-op, mixing MRI, and we eliminate what we are not interested in. We add to our imaging what actually interests us, whether we can have vessels or bone marrow, and this is something that we plan in advance. So we need to plan looking at different views. And the idea is to spare a nerve, to prevent affecting vascular structure. And when we plan, we need to look at the instruments that we are going to use in our surgery. It's not the same to use a drill than to use a saw, and these are things that we need to take into account. Now the difference in the OR, we are used to checking images on the screen, and sometimes when we get lost in the anatomy, we look at the screen. But in block resections, we sometimes cannot see the anatomy, because we must never block the tumor capsule. So navigation is very useful, because this will enable us to have a 3D image of the tumor and the cuts we need to make, and this is very helpful when we are in the OR. This is an example of the advantage of pre-op planning. Plan 1 for this tumor was to have a microcorpectomy, but then we thought that maybe by adding the cut in blue, we could first avoid going close to the vessels and then leave all of the anterior cortical to this vertebral body. And this is something that we do assisted navigation. And I know that in our Latin American companies, we not always have the latest models. What we used was the Striker navigation system, because unfortunately, for economic reasons, we cannot have access to more updated equipment. But anyway, this is the procedure, and here we are identifying where are the discs to proceed to partial discectomies, because we are only going to be removing a fragment of the vertebral, and here is the tumor with the pleura, and then we perform the first incision, which was the one marked in blue. And then we go to the posterior approach, and we cut the nerve roots. And once we have connected the discectomy laterally with navigation, we perform the second incision, which is the one marked in red, and then we can extract a single block, and that was the post-op control, and that was the final instrumentation. As you can see here, what we did, since we removed less than 50% of the vertebra, this is important for posterior controls, because these tumors can come back, and then we need to have, if we had an implant in the vertebral body, it would be very difficult to determine whether that tumor is coming back or not. This is the final control, and these are other cases showing you how we have tried to spare a nerve or two, and trying to preserve a function. Sometimes we have used the 3D technology to bring to the OR these models, 3D models, and here we had to remove the sacrum as if it were a lid. So it was very difficult to see where the transverse and the spinous, because this was a block resection. So the use of these 3D models are very helpful for this type of surgeries. And here you have the resection and block. You can see the defect. Obviously, this is a multidisciplinary approach. We have used flap. And of course, we needed the intervention of vascular surgeons, thoracic surgeons, and the more experts you have, the better. This is a paper that we presented a short while ago with these, and we had 14 en bloc resections with 40 osteotomies with a follow-up of 36 months. With the take-home message in this case is that these multi-planar osteotomies can avoid the use of implants or intervening in preserving fundamental vessels such as the aorta or the cava. Thank you very much. Next in our program, Dr. Thomas Teramani will share with us how to optimize success in the anterior and oblique approaches in the lumbar spine. En primer lugar, Quiero agradecer a los organizadores de este simposio. Estoy impresionado por la numerosa asistencia. En en Estados Unidos todo el mundo estaría recuperándose de haber consumido demasiado alcohol la noche anterior. Muy bien. Mi plática abordaré cómo optimizar el éxito en abordajes anteriores y oblicuos en la columna lumbar. El 90% de mis casos son con abordajes anteriores o oblicuos. Trabajo con cirujanos ortopédicos y especializados en la columna cervical en San Diego. En cuanto a mis conflictos de interés, me sorprende ver que muchos de ustedes no tienen cubrebocas. El COVID nos afectó en muchos sentidos y hemos visto el impacto del COVID. Los puntos claves de mi presentación es que voy a hablar acerca de los abordajes anterior y el oblicuo. Cuando yo hago un abordaje oblicuo, mantengo al paciente en una posición supina. Voy a hablar acerca de la evolución de estos abordajes y hablaré acerca de los detalles técnicos quirúrgicos. No los voy a ver con mucho detalle, pero simplemente para hablarles acerca de qué es lo que hacemos y cuáles son las diferentes etapas que se utilizan para cirujanos, y lo importante es cómo ir reduciendo la velocidad de la técnica para mejorar. También voy a hablar acerca de la experiencia clínica con ALIF y con ZDATP, que es el abordaje oblicuo, y luego hablaré acerca de las complicaciones. Yo sé que el presentador que seguirá justamente después de la comida va a hablar más sobre las complicaciones. Bueno, ¿cuál es el papel del cirujano? Bueno, este es un punto importante, pero en Estados Unidos estamos hablando que 98% de los casos para la columna se trabaja.
Thoracic surgeons, even urologists, is to be a member of the spine team. And really our role is to do safe, efficient, and reproducible or dependable exposures to the spine. And also I think a very important part of our job is to identify, minimize, and then when there is a complication, know how to manage it correctly. I think as an approach surgeon, you need to understand spine anatomy, and you need to understand the disease process. I think that's where a lot of us vascular surgeons tend not to care about that, but I think you'll become a better approach surgeon if you learn spine disease. And I think you have to have a real deep knowledge of the various anomalies in the urological space, in the vascular space, and in the spine space. I think vascular surgeons are the best docs to be approach surgeons because they have the skills to know how to deal with that vascular event, which will happen at some point in your anterior spine surgical career. And I think your typical vascular surgeon that is taught today out of fellowship, yes, they can handle vascular problems, but they're probably not handling vascular problems in the spine space the way they should, because you don't necessarily have to take out a proline to fix a vascular problem in the spine world as you do in a typical vascular operation. So a brief history of the approaches to the spine. I mean, ALIFs have been around for a long time. So over a century, we've been doing anterior spine surgery. It started with the transabdominal approach. Quickly, they realized they can reduce morbidity by converting this to a retroperitoneal approach. Other, sometimes I call lesser forms of operation have been developed, like the TLIF and the PLIF. Then the anterior spine operation in 2002 got revolutionized by making a much smaller incision and not doing so much destructive cutting of the anterior abdominal wall. Then XLIF came around in 2004, OLIF came around in 2012, and then the supine or ZD-ATP was introduced in 2019. So why did lateral surgery come about? Well, because anterior spine surgery, if not done with the right team, does have complications and has morbidity associated with that approach. So by going into direct lateral space, you avoid vascular structure. So why did OLIF come about in 2012? Because there are associated complications of going direct lateral. and particularly if you're not very facile with the operation, and particularly at L4-5. So these evolutions of the corridor have happened to reduce the morbidity to the patient. Does approach matter? And I think you've seen in the last 5 years that there's definitely indicating factors that the anterior approach does realign sagittal balance, does restore a height of the lumbar body, probably better than any other operation to the spine. And does spine size matter? I think we can probably say that a big A-lift cage like that's below compared to a T-lift cage, I think size matters. You're going to see less subsidence in that bigger cage than in a T-lift. I won't go into this in great detail. This is just for you to have if you get a copy or take pictures of the slide. But there has been an evolution in the anterior space. I mean, we used to make incisions for a one-level operation that was probably almost a foot long. Today, a one-level operation is about 5 centimeters. We don't go transabdominal. We have basically converted the anterior approach into an MIS. When I dictate my op reports, it's basically MIS, anterior spine fusion. The instrumentation has gotten better. The hemostatic agents have gotten better. The surgeons have gotten better to identify the anatomy on imaging and to identify complications before they get into trouble and be able to manage it better. So in 1997, the German surgeon Meyer basically coined the new microscopic technique for MIS, anterior spine surgery. And this patient was placed in the lateral position, and this was predominantly for L5-S1, but he used it for multiple levels. It was basically going through the oblique muscles of the abdominal wall and the oblique corridor and coming to the spine, the lumbar spine, in an oblique fashion. Well, in 2002, Sal Brow in Los Angeles, he's one of my mentors, as I was at USC for 11 years of my surgical training, he coined this operation the mini open approach. And so he reduced the size of the operative incision. He took the incision from the flank and brought it more to the midline. He kind of did an oblique incision when it became a 2-level, but the incision was moved from oblique off to the side to the middle. 2012, the French surgeon, this is where O-lift got coined. So this series of, I believe, 179 patients took a lot of the information from Meyer and his technique and basically coined the operation O-lift, and Medtronic took this information and designed retractors, et cetera, to introduce that operation. So what approach is best? Well, there's a lot of factors. And I think it's important that the team, that's including the spine surgeon and the approach surgeon, are involved equally in deciding the best approach. So it depends on previous surgery, it depends on obesity, it depends on the level, it depends on any vascular anatomy, any abdominal surgeries, transitional spine disease, bad osteophytes on the anterior aspect of the spine, spondylolisthesis. All these issues will impact the surgical approach. So are there limitations of the anterior space? I would jokingly say there aren't, but that's a joke. There are limitations. One of the limitations is you have to have a good approach surgeon. I'm sure there's a couple of you in this room that have worked with approach surgeons that suck, that basically take an hour to do L5-S1, that make a big incision, that sometimes can approach the spine at 4-5 and have to bail, or get into vascular problems and have to abort the case. I'm not picking on them, but it's a difficult operation. So your average vascular surgeon who is arrogant, cocky, who thinks he can do this and doesn't really study it will end up getting into trouble and end up causing you as the spine surgeon to have issues. But you can also have the abdominal wall issues. You can have vascular issues. The upper level of L2-3 can be challenging. And if you have adjacent disc disease, like you did a 4-5 one day anterior and the patient blows out 3-4, going back to do 3-4 can be challenging. So in many respects, the bottleneck is the approach surgeon. This is an interesting 5-year analysis from 2015 to 2020 to look at the type of operation that is done in the thoracolumbar space. So clearly the leader is the T-lift operation. So laterals there, anterior space is pretty consistent. Very rare do people in America do artificial disc replacement. I think it's picking up a little bit. But so really, anterior spine surgery is kind of just plateaued, and you would think anterior spine surgery would be number one, but it's not. So why isn't it the king? The bottleneck is the approach surgeons, at least in America. Also, it's, the spine surgeon doesn't want to deal with a slow approach surgeon, or the vice versa. Maybe the spine surgeon takes an hour and a half to clean a single disc space and do a disc prep. Sometimes the issue is money. In America, it's a co-surgeon billing, so you do a modifier 62, and the spine surgeon has to share the money with the approach surgeon. It's also a nightmare for scheduling two surgeons. So one surgeon wants to do a case in the morning, the other guy wants to do his vascular in the morning. That can become an issue. And finally, if you weren't trained to do anterior spine surgery, you may say, well, I'm a T-lift guy, I can do everything from the do everything from the back. I don't need to have someone else in the room. I can correct lordosis from the back, etc. And lastly, if this is how your cases end up, then you're not going to want to do an ALIF. So hip for optimizing anterior spine surgery, this is the first thing I will stress. You guys know this. You have to understand the imaging. I have to admit, in my first 10 years of approaching the spine, I would hardly ever look at the MRI. I really didn't care about the MRI. And was I arrogant? Maybe you can call that to a certain extent. I just didn't think I needed it when I approached the spine. I said, when I get down there, I'll deal with what God has given me, and I'll figure out which direction to expose the spine. But after, multiple spine surgeons hitting me in the head saying, why don't you look at these images, I really now strongly believe that you have to look at images. You kind of have to know where the bifurcation of the IVC and aorta and the internal iliac artery. You should be looking for calcium, looking for osteophytes, if there's any stents, any transitional anatomy. If there is scoliosis, what direction is the scoliosis going? And all those things only can help you as an approach surgeon and make your surgical plan more reproducible. Again, the imaging, you can see anomalies, like this first image up in the corner right here is a duplicated IVC. In the middle is a reversed aorta and IVC, so it would be nice to know that before you did a left-sided retroperitoneal approach for 4-5, because you would change your management and you would do a right-sided retroperitoneal approach. Also, in the lower picture down there, that just shows you the discrepancy of where the bifurcation of the IVC and the aorta is. And that is important, not so much for 5-1, but for 4-5 is big time important, because if your bifurcation is high in the IVC and the aorta, then you may approach 4-5 like a typical 5-1, but if you didn't look at the film, I guess there's here we go. So, I suck at jokes, so you don't want me to tell you jokes. So that lower picture is so important. Like probably about 14 to 17% of my L4-5 exposures are done like a 5-1 exposure. So I don't take the left iliac artery and vein and swing it all the way to the other side. And that wasn't the case before I looked at films very carefully. Also down here, if you see big osteophytes, very important. Transitional anatomy, extremely important. So this is what, when I walk in the operating room, I kind of have a nice deal. The PAs or someone in the room is going to have this structure on a computer for me, and I just walk in, patient's already intubated, I don't even know who the patient is. I look at the belly, bring in the x-ray, take a picture, mark where I'm going to do, and then I run those series, and I basically look for the bifurcation of the aorta, IVC, and I follow it all the way through, and I want to see whether internal iliac vessels bifurcate. That information, it literally takes me 20 seconds, and I've already decided my plan for surgery. And it's so simple to do and so important. So we'll go through this very quickly. In my opinion, there's 5 critical steps to approach the direct anterior aspect of the spine. So 1 is your abdominal wall and how you manage the abdominal wall. 2 is how you establish your retroperitoneal space and how quickly you establish your retroperitoneal space. The 3rd issue is how you deal with vascular structure. You don't need proximal distal control. You basically just need to release and rotate, or some people will say mobilize and rotate, but I like to call it R&R. And so that is critical to move structures if you have to move structures. The 4th issue is establishing a safe corridor for your spine surgeon to do his work. Not only just to do the disc prep, but to put the implants and to put the screws in, whatever else he needs to do. And then the last one is the closure. Just make sure you didn't damage anything on the way in. All structures are intact. The Foley is okay. There's no blood. The ureter is okay. The vascular structures are okay. And you don't have a bunch of lymph fluid in the field, which means you have a lymphatic problem. So general setup, this is kind of tip number 2 or wherever I'm at for optimizing. I make it super simple. That Mayo stand is all I have in regards to retractors. I only use 2 retractors. There are 2 Goulet retractors. I don't use Richardsons. I don't use Wiley's. All that other stuff is not necessary. Now, that's not including my table-mounted retractor, but for my approach for step 1 and 2, when I'm dealing with the abdominal wall and the retroperitoneal space, it's very simple what you need. Always put a Foley catheter, with the exception in the outpatient setting, I tend to not put that in, but the Foley catheter gives you a good mark that you haven't damaged the ureter. So if there's blood in that catheter at the end of the surgery, and there was no blood at the beginning, then it may be something we did it in the operating room. A pulse oximeter is always on the left lower extremity. The next picture there is electrophysiology. Do you need electrophysiology in the anterior space? Not really, but we do use it probably 50% of the time in the United States. And that last person there in the corner is Dan, the anesthesiologist, and you have to have a good communication with your anesthesiologist. When I do an anterior case, the patient's paralyzed, even if there's an electrophysiologist in the room. 0 twitches for the whole entire part of the anterior aspect of the operation. Again, these are just for your purposes. These are the instruments I use, very simple. Bipolar, I like the Stryker Silver Glides. Those are very good. They're reproducible. You don't need irrigation on the bipolar. This is probably tip number 3 that's critical, that really changed how, when I came out of fellowship, I was an Omni retractor user. Good retractor for vascular surgery, sucks for anterior spine surgery. These are all decent retractors. This is a Synthes Synframe. There's a Nuvasive retractor there. There's a Thompson. There's a Globus. I've helped design 2 of those 4 retractors. I'm not going to ding any of them. They're good. But in my opinion, the best retractor that I've also been part of helping them design is the TDAN. And I think it's just the simplicity of use and the engineering that has gone in it that makes it a more useful retractor. So step 1, abdominal wall. We won't get into details, but you have to understand the abdominal wall to do this operation. Number 2, this is Sal Brow's paper. It's a good paper if you're just getting into the anterior space to read. His technique is, I've modified it from what he did in 2002, but he explains a lot of the principles of doing MIS approach work. This is a 3rd step, dealing with vascular structure. You don't have to get proximal distal control. You just have to release the vessel and rotate the vessel off the spine. So in a typical L4-5, that big vessel in the middle is the left iliac artery. That's going to be swung over to the right. That second image right there with vessel loops and umbilical tape is completely not necessary. If you're doing that, or if your approach surgeon is doing that, you got to get him out of that habit. And this is step 4. This is your corridor. So when you leave the room, if you're leaving as an approach surgeon, or if you're going to stay in the room, the spine surgeon should see a nice midline mark where the midline is. That's that Bovie mark on the bottom. And basically, the retractor blades are such that they can put in small, medium, or large interbody graft, or they can put in an LDR cage if they're doing artificial disc. The final step of the operation is looking at your field, looking at your ureter, look at your blood vessels, make sure your pulse oximetry is reading 100%, check your Foley catheter. And then I also think this is important for the approach person. Do your AP and lateral fluoroscopic image. If that cage is off to the left, I feel that's not only a spine surgeon's boo-boo, but that's also the approach surgeon's fault. That cage should be in the middle. So for 15 years, I didn't really believe in the oblique corridor. I've been to the OLIF course up in Northern California. I've been asked to do OLIFs. I have no role to do OLIFs in my practice. If there was an ALIF approach that I could not do, I would tell the spine surgeon, do a T-lift, do a PLIF, do an X-lift. Sorry, I'm not interested. But after looking at films repetitively, I saw this space, and that space is avascular space. And I thought, that's an interesting spot. It's easy to expose. So there was a couple things that led me to my progression to use the OLIF space probably 5 to 6% of the time when I approached the spine. This was the second reason. So for many, many years, if a spine surgeon had a 4-level anterior or 4-level fusion case, I had no problem exposing 4 levels and doing an anterior fusion at all 4 levels and then supplemental fixation in the back. But in this one case in about 2018, I ripped the ureter right out of the pelvic hilum. So right there is a retrograde showing where the ureter was disconnected. And I didn't even know it happened because if you look at the hardware is significantly lower. That top disc is L23, where the hardware is placed. So this was picked up on this CT scan post-op day 3. So after that, I stopped doing L23 exposures, and I limited my anterior spine work to L3 to S1. Then I was on a project with NuVasive. This was the lateral ALIF project, but I was the only guy in the group that was basically not copying OLIF. I wanted to do a true lateral ALIF. So you see this picture. This is the patient, L5S1 disease. Before we rotate the patient lateral, I mark off like if I was to do an ALIF. That would be my typical incision. We put the patient lateral, we put some Schulberg retractors posteriorly so when they're putting in the implant, the patient doesn't move off the table. And I basically designed or had NuVasive modify their lateral ALIF retractor to allow me to do a direct ALIF, and there's your final pictures. It was a royal pain in the ass. And a lot of the reason was I didn't realize when I was working on cadavers for 6 months that in a cadaver, the fat doesn't just fall down on your operative table, but I was using 200 centimeter retractors or 200 millimeter retractors to get to the spine in this situation where if the patient was direct anterior, I probably would be using 160 millimeter retractor blade. So I did 2 of those cases and felt there was no value in that, but that actually opened up my eyes to a different concept of approaching the spine, and so this is where the 0-degree ATP came about. So this first image over here to the left is how a spine surgeon views a direct lateral. The second image is the viewpoint of a spine surgeon doing an OLIF approach with the patient in the lateral position. And that last picture is ZD ATP or supine ATP. The patient's flat, and that the spine surgeon's working on the left side, and that's his field of view looking into once the spine is exposed. You have to secure the patient to the table securely, and you're tilting the patient pretty much maximum 25 degrees. So we, and I say we, T-Dan and myself, we had some prototype blades. We came up with the concept. We made some modifications to the Phantom ALIF retractor. And I had these blades available at this hospital where I was planning to do a 2-level ALIF on this patient, Dr. Taib's patient. And this lady had multiple C-sections, hysterectomy. And so I was going to do a retroperitoneal approach. Couldn't get into the retroperitoneal space. So then my conversion plan at that point is go transabdominal. She had complete matted down intestinal content with adhesions. So I went to the lounge and I asked Dr. Taib, you want to try something new? And we did. So we did. That's our first 0-degree ATP case. As you can see, the spine surgeon's on the left side working at that angle obliquely. And those are 2 anterior spine cages, 2 NuVasive cages, which at that time was 3 screws. You can't put in all the screws. So only one of the 3 screws were replaced. But we're able to put the cages direct anterior, and those are medium footprint cages. Patient did great, no problem. So when do I use ZD-ATP? It's when it's an adjacent segment and I don't want to go direct anterior. It's upper level 2-3. If the patient has 4 levels of disease, I'll do 2 levels ALIF, 2 levels ZD-ATP. Hostile abdominal wall, for example, mesh, or multiple operations with scar tissue or hernias that I don't want to get into weak tissue. Hostile vascular disease, like an aortic aneurysm or an aortic aneurysmal stent, or peripheral vascular disease with iliac stents. Those are my primary indicating factors. If I don't have any of those factors, it's ALIF, ALIF, ALIF on all those patients. There's no reason for me to be in the oblique corridor. So it's devices and retractors that are important. I'm going to quickly go through this. It's very interesting that all these devices, and there's probably a few more, these are all anterior spine implants with the exception of LDR oblique. That's an implant that was designed direct for oblique, and then Spinology was direct for oblique, and then Nova Approach was direct oblique. So all of these implants can be done direct anterior or obliquely. Camber spine, I think the other thing that's important here is the degree of insertion. If any of you know camber spine basically puts in an ALIF cage, but they're doing it in the projection of an OLIF. So the patient's placed in lateral position. And so they're coming at a steeper angle. So they're coming at 65 degrees. When the patient's supine, you don't want to be at 65 degrees. You want to be about 35, 40 degrees. So that's the sweet spot. So we'll go through some of these devices. That's camber spine. Spino Elements has a oblique attachment point. T-spine, oblique attachment point. Titan spine, oblique attachment point. Nuvasive, this is a 4-screw system, also attachment oblique, 35 degrees. Cascadia, which is just a static cage, not a standalone device. Spinology has 2 implants. One is direct anterior, one is for oblique, but only 2 screws, not FDA approved for standalone. Zimmer Biomed has LDR, which also 2 implants, oblique or direct anterior. These are anchors. And lastly, Nova Approach is the first FDA-approved device that can go in obliquely or direct anterior that's FDA-approved for both corridors. So if you're using, or your spine approach surgeon is using these retractors, I'm going to call it old school Stone Age. These retractors, I mean, they work, but there's way better technology out there. And in 2019, we modified the Phantom. We put a couple hinges on and came up with a couple different blades. This allowed us to create this curvature that wraps around the abdominal wall that gives us a little bit better to expose, and some different blade designs that allow us to toe off the anterior aspect of the spine. Here's some illustrations of a L5S1 exposure, just to show you where the retractor blades are mounted and how they're pulling vascular structures off the spine. This would be what you would see for a 4-5. So what's the advantage of doing this? You know, you see that aorta, there's not an IVC in this picture, but instead of that aorta going completely over, or the iliac completely over to the opposite side, it only has to go to what I call the 50-yard line. I don't need to push that more than midline aspect of the spine, which is a big deal. So some of the steps for ZD-ATP, as you remember, there were 5 steps for direct anterior. There's 7 steps for ZD-ATP. Some of it has to do with positioning of the patient, being able to secure the patient, making sure you're tilted fine and there's no issues. The abdominal wall dissection is a little different because you're not going through the rectus fascia, and the rectus muscle doesn't have to be manipulated. But a lot of the steps are similar. This is unique. So I stole the concept of hip positioners from the orthopedic joint guys, and I used 2 of these. You can see how I put one in the axilla on the right side and one just above the kneecap on the right side. I also place a belt around the patient and 2 surgical tapings like you all use typically in lateral spine surgery. We test before we prep, make sure the patient doesn't fall off the table. Knock on wood, patient's never fallen off the table. Then we will do our x-rays like if we were doing an ALIF. We bring the C-arm in for an AP and a lateral fluoroscopic image, and we're going to mark off where we're going to put our incision. I usually mark off as if I was doing an ALIF, and then mark my second incision, mid-clavicular line, as I'm going to be doing the ZD ATP. You got to understand the abdominal wall, and the difference in the abdominal wall with ZD ATP is it's kind of similar to the O-lift technique. You're just going to do a muscle splitting technique. The first aspect of the spine being on the right side of the table is creating the retroperitoneal space. I always have a bodyguard in the room in case any invasive reps are around who want to assault me. So the first step is this one retractor, and there's a special blade handle that allows you to more securely hold it. That needs to sit where those fingers are. So all I do when I'm approaching that spine and the patient's tilted 25 degrees is I want to see the psoas muscle. And then I put my fingers down there. I know the kidney's up out of my way because I'm seeing the psoas muscle, impossible the kidney's down, and I put a blade at that point. And then I go to the other side of the table, and now I'm going to work that blade up to the 50-yard line of the spine. And so now I'm on the other side of the table holding that blade handle, and we're just working our way up, and we're putting in our 4 retractor blade. And that's where the spine surgeon's working from the left side. That's the view of the spine surgeon. It's almost like an ALIF exposure view. You pretty much can do a complete discectomy. You don't see the left side as well as you do the right side because you're not coming at it straight on, but you do see the majority of the disc. At the end, same thing. This is closure. Look at your Foley catheter, look at your pulse ox, look at the area for any free fluid and lymphatic fluid, and make sure your cages are all in a good position. This is a spinal elements cage, utilization of only one of the 2 screws. So we'll go through some cases real quick. Having 2 young daughters and having recently been to a nice beach resort, the bikinis are getting too small. And too much butt and too much boobs being exposed, but that's a whole nother topic. And if I've confused you at all, you can't be as confused as this guy. I mean, he doesn't know where he's going. There we go. All right, case 1, L5S1. Typically, should take you less than 45 minutes to 60 minutes. The exposure should take less than 10 minutes. So if it takes me less than 10 minutes, the spine surgeon's got 50 minutes to do a disc prep. If it takes him 50 minutes to do a disc prep, he may get a scalpel in his hand if it takes that long, so it shouldn't take that long. But really, it should be a safe approach. You should be able to get the cage midline. The incision should be 5 to 6 centimeters in length, and you should be out of the operating room in 60 minutes. Right, 2 levels. 2-level case, exposure, 20 minutes. Out of the operating room, 90 minutes. Blood loss should be typically less than 25 cc's. Maybe I'll give you 50 cc's. And cages should be in the middle. I typically do a midline incision. I don't do an oblique incision. And this is a front-back case. So 3 levels. I have no problem doing 3 to S1. It's a very common operation. If I can keep the incision below the umbilicus, I do. If the incision has to go above the umbilicus, I do a perimedial incision. I don't like curving around the belly button. I've had too many wound issues doing that. So again, exposure, 30 minutes, total operative time, 2 hours, all the cages in the middle. So before 2019, I've done hundreds of these. So this is just the anterior part. This patient got posterior fixation. So 4 cages. This is a Synthes-Synfix. Big incision. There's a little bit morbidity with that incision, higher tendency to have hernias. It's a hard operation, but it's a very powerful operation. I don't do that anymore. So if I have a 2 to S1, this is what I'll do. So I'll make an ALIF incision for 4551, and then an oblique incision, mid-clavicular line for 2334, and all 4 of those cages are anterior spine cages. The 2 up at the top were put in obliquely. So hostile abdomen. This patient had multiple abdominal operations, big ventral mesh, and we needed to do 3445. Oblique incision. This one I put out a little bit more obliquely. This was probably one of my earlier cases. I don't tend to go that far out obliquely anymore. But 30 minutes exposure, operation took 2 hours, 50 cc's blood loss, And there you go, the cages are in the middle. Those are anterior fusion cages, only one screw, so those patients are going to get supplemental fixation in the back. These are kind of the steps. This is the view. The second picture is what the surgeon sees. I've never had a surgeon tell me that was painful because I couldn't see what I was doing. So it usually is not that difficult of an operation for the spine surgeon's perspective. This is adjacent segment disease. This was a patient that had a 5-1 exposure that was done transabdominally. The patient was in the hospital for a prolonged hospital course. I did not do this exposure. This was a spine surgeon that I took over his business. And I didn't want to do 4-5 in the midline. So I put an oblique incision, and there's your 5S1 previous fusion that happened a number of years prior. There's my retractor blade docked. You can see the needles at the 50-yard line. That's where the spine surgeon has his eyes. That's where that cage has to end at that point. So you mark that point appropriately. And there's your cage being put. This is a Titan spine cage. And he uses anterior fixation plate, so he put a plate with 4 screws. This is a striker plate. Excuse me, this is a K2 plate. Here's another scenario. Say a patient had a lateral fusion at 4-5 and 3-4. So fusion lateral 3-4-4-5 now has adjacent disc syndrome at 2-3-5-1. So same prep, patient's flat on the table. 5-1 is done first. Typical ALIF, 60 minutes. Change the retractor position, do 2-3, DD-ATP, takes about an hour. That operation took us a little over 2 hours. And you can see the implants there, the ALIF cage at the bottom and the spinal element cage at 2-3. This is a hostile vascular case. This is a patient that had an aortic aneurysm. This was an anchor endograft, no longer being used, but it wasn't a stent-supported cage or stent. It was just basically fabric for the most of the length of the device. Most of the device hung over on the left side, so I did a right-sided approach for 4-5-5-1 and basically did ZD-ATP, and those are your two. This is a Nova approach cage with multiple screws. In this case, it was, if you wanted to go standalone, this could be a standalone case. So I wasn't tasked to talk about complications, but I'm giving you this list. You have to master these complications. And the first one I think is important. If you are boarding, say, 10% of your cases that you can expose, say, 4-5 or 5-1 or 3-4, to me that's a complication. Or your approach surgeon is giving you that complication. You should be able to expose what you're asked to expose. And I'll show you some data a little bit later. So the complication rate, major vascular rate, it's all over the map, depends on the study you read. But if I was to say, if you were to ask me what's an acceptable major vascular complication rate, I would say 3%. If your approach surgeon or you as a spine surgeon have more than 3% major vascular complication, which is defined as either 250 cc's or 300 of blood loss in the anterior aspect of the surgery, if you had to do a repair, or if you had to do a thrombectomy, or if you had to abort a level because of a vascular injury, those are all considered major vascular injuries. 3% or above is too high. So what we did, and this was presented at NASS last year, we had 3 high-volume approach surgeons. I was one of them. The other one was in Cincinnati, and the last one was in Colorado. In about I think it was about a 18-month period, we studied close to 1,700 patients. This data was all put in prospectively in a handheld device database. It was equal distribution amongst females and males. 60% of these patients were seen for preoperative clearance. I don't see all the patients. I probably see about 40% of the patients for preoperative clearance. Revision surgery, this is an interesting one. 27 of those patients had removal of failed T-lifts. Very few A-lifts were removed. There were 3 patients that had A-lift cages removed, and there was 1 artificial disc removal. 13% of the cases were standalone anterior cases with no posterior decompression or fixation, and electrophysiology was used in 70% of the cases. This kind of gives you a breakdown of the levels. As you would expect, most common level is 5S1. Second most common level is 4-5-5-1, and then 4-5. But you can see here, these 3 approach surgeons were doing all levels. We were doing 2-3s, we were doing 3-4s isolated, we were doing 4-level cases. There's 10 4-level cases there, so a broad breadth of exposures. Typical incision length, there you go, 7 centimeters up to 11 centimeters for a 3-level. You see your exposure times, so 25 minutes should be your exposure time for a 2-level if you're a high volume approach guy. Operative time, again, within reasonable, a single level should be an hour. Fluoroscopy time should be less than a minute. And then EBL, if you're in the hundreds, you're doing something that's not necessary. You shouldn't be having 100 cc's of blood loss during an ALIF. So here's just a summary of the data. I think this is an important part. Aborted cases. Out of those cases, and it was close to 1,700 patients, but that was way more than 1,700 levels. So only 3 levels were aborted. So that's less than 0.18% of cases where we had to bail out because of whatever reason. The death rate was only 1 patient that died on postoperative day 26 of a PE. Our complication rate was well below the 3%, so our major complication rate was 0.35. And the other complications, if you look at all of them, DVT was picked up a bit because there's a number of doctors that do a DVT study on every patient before they leave the hospital, and many of those patients were asymptomatic DVT patients. Again, this is just a summary of the vessels. So most often it was a venous injury. It's very rare to have arterial problems. And how it was managed in over 60% of the cases is not with a proline suture, it's with a hemostatic agent. And those are various pictures of hemostatic agents that we use. This is a breakdown of, minor versus major. It's interesting, you would think L4-5 would be the more common area, and that is the case when it comes to minor vascular injuries, but our more common major issue came about at L5-S1. So I don't think you can say that L5-S1 is not associated with vascular injury. It just depends on the anatomy of the patient. So in summary of that study, major vascular complications, less than 0.4%. Operative time for a 2-level exposure could be 25 minutes or less. The DVT rate is in an acceptable range of 1.4, and the aborted case is 0.2%, and having a good grasp on managing the complications. Quickly just show you some of the cases for ZD-ATP. You can see the majority of those cases are at 2, 3, 3, 4, but we can do ZD-ATP all the way down to L5-S1. The indication, the most common indication was adjacent disc syndrome. Upper levels was the second most common issue or reason, and then a hostile abdominal wall. And since I put together this data, we've had a couple hostile vascular cases, and you saw one of those in the case presentation. 26% of these had concurrent ALIFs done at the same time, the ZD-ATP, monitoring 50%, and 100% of these patients got posterior fixation and stabilization. No deaths, no major vascular complications, 1 sympathectomy, a couple DVTs, minimal blood loss. So what corridor is best, or what pathway is best? I'm biased. I think ALIF is the best approach to the spine, but I think pound for pound, the safest place for a patient to be is supine on the operating room table. And if you have a good approach surgeon, you should be able to capitalize on all those positive things. I think second area for me at least is going in the oblique projection, and lastly lateral. So ALIF is king, ZD-ATP is the queen, direct lateral is the bishop, PLIF is the pawn. Thanks a lot, appreciate it.
Excelente plática acabamos de escuchar por el doctor Terramani. Y sobre todo la evolución que ha tenido tipos de abordaje, los que estuvimos en la vieja escuela.
Approaches for those of us who are part of the old school, where we saw major incisions from major surgeons. I first learned from Professor Silke, from Professor Hagen, and we have seen how techniques have been evolving towards minimally invasive. So thank you so much, Dr. Terramani, for this Excellent recommendations to prevent complications. And of course, what is evident to us is your expertise. So on behalf of the organizing committee of this 7th symposium, we want to present you with this token of our appreciation. And thank you so much for your participation. We want to remind you that this is our lunch break. I invite you to come back at 15:40 in order to resume our program. We will reconvene at 15:40. Thank you. Kindly turn off your translation devices during the lunch break. Les agradeceremos apagar los receptores de traducción.
2, 3, 4, 5, 6. Sí, ok. 2, 3, ¿sigo hablando? Ok. ¿Está?
Sí, 2, 2, 2, 2, 2, 2, 2, 2, 2, 1, 2, 3. 2, 2, 2, 2. Sí, 2, 2. Prueba de audio, 1, 2, 3, sí, 2, 2. Sí, 2, 2, 2, 2, 2, 2, 2, 2, 2, 2. 2, 2, 2, 2, 2, 2, 2, 2, 2, 2, 2, 2, 2. Sí, 2, 2. Sí, 2, 2, 2, 2, 2, 2. 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 13, 14, 15, 16, 17, 18, 19, 20. Y 2, 2, 2, 2. Sí, 2, 2, 2, 2, 2, 2. Prueba de audio, 1, 2, 3. Sí, 2, 2, 2, 2, 2, 2, 2, 2, 2, 2. Sí, 2, 3. ¿Por qué? Sí, 2, 2, 2, 2, 2, 2, 2, 2. 3, 3, 4, 5.
Prueba de sonido. 1, 2, 3. ¿Sí? ¿Ya? ¿Sigo hablando o ya no? Prueba de sonido. 1, 2, 3. ¿Todo bien o se escucha ruido? ¿Sigo hablando? Ok, las bocinas no están funcionando, o si están funcionando, o hacen ruido, o no hacen ruido. No le llega el ruido del micrófono. ¿Ya me escuchas, Nachin, por ahí, o no? ¿Ya? Ok. Sí, estoy hablando por estos micrófonos que parecen antenitas. ¿Se escucha por la bocina o no?
2, 3, 4, 5, 6, 7, sí, sí, sí. Ok, 2, 3, 4, 5, 6, 7, 8, 9, 10, probando. ¿Sí? ¿Solo es esa? De todas, solo es esa. Una, no, nada que ver, ¿verdad? 2, 3, 4, 5, 6, 7. Pero, ¿se oyen con la misma intensidad? ¿Una y otra? 2, 3, 4, 5, 6, 7. Sí, 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 sí. Ok, 1, 2, 3, 4, 5, 6, 7. Sí, 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 sí. Ah, es que esta... Okay. 2, 3. Y bájale tantito, Temo, por favor. 1, 1, 2, 3, 4, 5, 6, 7. 2, 3, 3, 3. Acá estamos en 1, 2, 3, 4, 5, 6, 7. 2, 3, 2, 2, 2, 2, 2. 1, 2, 3, 4, 5, 6, 7. Sí. Ok, 2, 3. Ahí estamos.
Sí, 2, 2, 2, 2, 2, 2, 2, 3, 4, 5, 6, 7, 8. 3, 2, 4, 5, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23. 2, 2, 2, 2, 2, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Este era el que estaba cortando 2, 3, 4, 5, 6. ¿De baterías? Mira, de aquí es de donde estaba 2, 3, 4, 5, 6 tronos. Sí, se cortó, ¿verdad? Sí, sí. Ahí se fue. 2, 3, 4, 5, 6.
1, 2, 1, 2. Sí, 1, 2. 1, 2. Entonces, este es el 3, ¿no? 4. 1, 2. 1, 2. Sí. 1, 2. 1, 2. 1, 2. ¿El 3? ¿Eh? Sí, sí. Cuarto. Sí. 1, 2, 3, 4. 3, 3, 3. Sí, 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 sí. Pongo este es el número 2. Sí. 1, 2. 1, 2. Sí. 1, 2. Probando. 1, 2, 3. Sí. 1, 2.
Ok, perfecto. Es el 3. Me confundí, güey. Ey. Este es el 3, mira. Este es el 3, porque si lo...
Bien, por respeto a todos ustedes.
Well, in respect, tonight is time to resume with our program. And I'm here to introduce you to the following speakers that will be talking about the prevention, identification, and potential managing during the anterior and oblique lumbar spine exposure. The speaker will be Dr. Niall Tayeb. Thank you very much. Voy a hablar en inglés.
Okay, so thank you for having me here for this very outstanding conference. I'm very pleased to be here, and I'll have the unenviable task of speaking about complications right after lunch. So thank you for coming in after the lunch. Very good lunch today. So to start off, just my disclosures, just so you can see that. But as far as approaches to the spine, we're going to focus on the anterior approach today and also the oblique approach. In particular, I'll talk about the zero ATP approach that Dr. Taramani and I have been utilizing in San Diego. But there are other ways to get the spine. Those are not the only two. Obviously, there's the anterolateral, there's PLIF, there's TLIF, and direct lateral, which I also use quite extensively in my practice. But again, today, that's not part of the talk. As far as anterior to the psoas, ATP, so to speak, there's OLIF, which is obviously the most common one and one most popular nowadays. There's also the lateral ALIF, and then the zero degree ATP, which again, Dr. Taramani and I kind of stumbled upon during the surgery he discussed earlier. So just quickly, the history of anterior fusion. Again, this has been around for over a century as far as accessing the spine from an anterior approach, first utilized for tuberculosis cases. The first attempted anterior approach with a transperitoneal approach was done by Muller in 1906. 1944, Iwahara formed the first retroperitoneal approach, which is what we use nowadays. That really has revolutionized how we access the spine anteriorly. As Dr. Taramani spoke about, Dr. Mayer in 1977 first came up with the concept of OLIF, which was then obviously then became popularized through Medtronic, and they really made that more a mainstream operation. And 2002 was the first mini-open retroperitoneal approach, and that's what we utilize commonly in our San Diego practice. So just before I get into the complications, as far as advantages of the anterior lumbar fusion, I don't want to get too much in the next talk, but these talks are all very interrelated, and it's hard to talk about complications unless you talk about why you're doing this in the first place. But you have direct visualization of the disc space, have efficient access when you have a very good approach surgeon you work with. This is a very efficient, seamless operation. In most cases, obviously some cases are harder than others. But there's once you're accessing the spine, performing the discectomy is not difficult in general because you have outstanding exposure. You can perform indirect and direct decompression. So you're directly decompressing the spine by taking the disc out, but you're indirectly decompressing the spine by opening up further by putting in the cage. You can place a very large interbody device, which is important as far as fusion, as far as preventing subsidence and things of that nature. There's no iatrogenic trauma, the paraspinal musculature that you would get with the posterior approach, although the vast majority of cases I perform are with posterior fixation through a minimally invasive approach as well. No neurotraction. Again, with the right people, this can be a very efficient operation. Minimal blood loss, less time. So in the US, there's been a big shift to outpatient surgery for spine, especially with fusions now. And so this can be done very safely in outpatient surgery centers. Because in the U.S., it's obviously the goal for most insurance companies is to get people out of the hospital as quickly as possible. Obviously, our goal is to make sure patients are doing well before they leave, but there is some pressure, not but just by the hospital, by insurance companies, kind of get people out as safely and quickly as possible. And again, I put indirect decompression in capitalized letters because really get great indirect decompression approach and not have to actually touch the nerve roots, decompress the nerve roots physically, which I think is safer for the patient if you don't have to. So the benefits contribute to a higher rate of fusion through Wolff's Law because you're healing under tension. There's obviously the stress of age, allowing for higher fusion rates. Restoration of lumbar lordosis. So again, I'm not going to get too much into this, but obviously I think you get a much better restoration of lordosis. Not only that, but also in the coronal plane, if you have a scoliosis, you can definitely get a good correction of in the coronal plane as well. Reduction of spondylolisthesis works very well. As I said, improved coronal and sagittal balance. And if you have a focally kind of kyphotic disc angle, you can just do that one level of surgery. You can basically reshape the entire spine and avoid these big kind of constructs later on that you see. And as I say, you want to do surgery the right way the first time. Otherwise, it can lead these massive surgeries with PSOs and vertebrectomies and all these things. And do the surgery the right way the first time, we can hopefully avoid those situations, although say there's a need for that too. And then doing this through a minimally invasive approach, there is a possible reduction in getting adjacent 7D, which our biggest issue with fusion is people coming back because of adjacent segment disease. So just a few slides, and I will get into complications here, but I just want to lay a foundation. But this is a typical patient I see. I have an adult degenerative practice, and this is a very common problem. You have grade 1, 2 spondylolistheses, bad stenosis. So in this particular individual, I was able to go in the front, get a nice size cage, get some reduction of the slip, and then do the percutaneous screws in the back, no laminectomy. And these patients do very well, nerve pressure gone. That's, again, this is a very efficient case and safe case. So another similar issue, there's a young woman I operated on, but you can see she has an isthmic spondylolisthesis, L5S1, had a lot of facet arthrosis at 4-5. Because she was so young, I didn't want to leave that 4-5 alone. But you can see here, even though it was a difficult angle at L5S1 with angled instruments, we were able to get in there, open it up, and get a really good reduction of the slip. But more importantly, 6-8 months later, she's doing very well, no leg pain, and getting back to activities. So shortcomings. This will get into the actual talk of the complications. So number one, and I know Dr. Termine would disagree, but we do need an approach surgeon, and I'm fortunate enough to work with him, and I have days that I work with him, so I don't have to worry about the scheduling conflicts that can occur. And I'm lucky enough to work with a surgeon who is one of the pioneers in this field. But scheduling can be a problem if you don't have someone you work with very closely. Trying to get two surgeons coordinated together can be a very difficult task, as we all know. In the U.S., we share fusion code with the spine surgeon. So that doesn't drive me what I'm doing. I want to do what I think is best for my patient, but there is an economic issue here, and I personally think it's a little. I don't agree with that because he's doing a very particular, specific thing to get me to the spine, very separate from what I do. But this is the way it's traditionally been, and it won't change anytime soon. And while safe, complications can occur. So this will kind of segue into why I'm actually speaking. So as far as complications of ALIF, we number one will think about the vascular complication, and for good reason, because we're working around the big vessels of the spine. Subsidence can be a big issue. I'll talk more about that. Ileus, that can be an issue. Acute colonic pseudoobstruction, which is also known as Ogilvie syndrome. I've seen that occur, I think 3 times in 18 years, but it does happen. Retrograde ejaculation is a known complication, lymphocele, ureter injury, and then sympathetic dysfunction. There are other complications, either by far the most common. I'm not going to get into DVTs and things like that, but that's also an issue that can do. But with vascular complications, again, you're working around the great vessels, depending what level you're at, deal with the aorta, vena cava, or if you're lower, iliac artery vein. You have the segmental vessels you have to worry about, and numerous veins. 5-1, you have the middle sacral, you have the iliolumbar. So again, this is where you need someone like a Dr. Taramani who's facile with this approach to keep you safe. Because again, I'm talking about complications of surgery, but what I'll tell you is most of these complications are more approach related, not really related to what the spine surgeon does, other than, I'd say, the subsidence and cage placement, things like that. So you need to really work with someone well, trust that person, because in the end, this is your patient, and your name's on the chart, and you have to live with these complications. So as far as the vascular complication, most commonly occurs at L4-5, and Dr. Taramani showed in his slide that's true, but which I didn't know because I didn't see that slide before I came up here. But L5-S1 has the greatest risk of actually having major vascular complication. Published rates of injury vary from 1.9% to 24% in the literature. Obviously, what Dr. Taramani will publish will be a lot less than that. So if you have a very facile approach surgeon, I agree with him. This should be a very rare event where it's a problem, and I agree should be less than 3% in our hands. It is. If it weren't, then I'd probably think about doing the surgery differently. Venous laceration is the most common complication, and of the veins, most common is the left common iliac, inferior vena cava, and iliolumbar are the most common. And that's what we do get these small bleeds once in a while, and those are. They can be annoying, but they're not something that's going to stop the case or make us abort the case or anything like that. We use either manual compression, or there's a lot of hemostatic agents like Fibrillar, which works well. We can pack it, and then through that and pressure of the vein on top, that usually will stop the bleeding. Everest, which is another hemostatic agent we use. I'm not sure if that's worldwide, we use in the US. And then Tacosil is another hemostatic agent. All 3 of these can work very well in stopping these small bleeds if you get them. Arterial injury, fortunately, is much less frequent. And actually, the left iliac arteries thrombosis is the most common. Difference with the arterial injury is at least that is easier to repair. That's something you can actually put a stitch in and repair. Veins, we've learned over the long term that that's not a good idea. Veins are so thin that these stitches don't work very well, and that's why we've shifted to the hemostatic agents as far as treating that complication. But as I said, fortunately, these are all very rare. And if they were not, then I wouldn't be standing here giving this talk. That's for sure. I'd be doing something else. How to avoid things? Well, number one, we put a pulse oximeter on all our patients. If the pulse oximeter goes below 90%, then it usually beeps, and that tells us and the anesthesiologist that they need to raise the blood pressure. Or we also will sometimes intermittently release the retractor to just give the artery a little rest. The other two, as far as avoidance of machine bone dowels, so that's really not utilized anymore. We had a surgeon in San Diego using that till the bitter end, but that device is no longer made, so that's not really something we have to worry about at this point. And also avoidance of cylindrical titanium implant. Again, that's really not utilized. The main things would be the pulse oximeter on the patient's big toe, and then the intermittent release of retraction. It seems to work very well. Subsidence. This is one where we as spine surgeons will have to take full responsibility, because that's certainly not related to the approach. That's related to our preparation of the disc space. And it basically, the definition is a decrease in vertical height of the disc space prior to complete incorporation of the fusion. So this is something that usually you see shortly after surgery, or I'd say within 6 weeks or 3 months of surgery. And this is actually, in my opinion, it occurs at the time of surgery, usually due to violation of the end plate with your disc prep. And again, and I with Dr. Richter, I agree with U.S. is the same as Germany. We're seeing a lot more older patients. Baby boomers are now becoming older, and I've seen quite a lot. I've seen a huge increase in osteoporosis since COVID. I rarely saw it before. I'd see it once in a while. Now I see many more cases of osteoporosis where I actually have to delay surgery. We put them on medication to get bones stronger. But this has now become very common where I have this conversation usually once every time in the office, and this is not a conversation I had 5-10 years ago, or if I had it, it'd be very rare. But you have to be careful with these osteoporotic patients because they're very high risk. Even if you do an excellent job, or you think you're doing a good job, it can get subsidence quite easily. So this again, not my case, but I'll show you a case of mine later with a complication. I will take some. I'll show some of my things here, but this is a good display of what science looks like, and that's something you want to. That's not a picture you want to see in the office. That's for sure. So ileus. This has been a fairly big deal. Even retroperitoneally, we're not going we're going retroperitoneally. You can still get an ileus in most patients, not most. I'm sorry, in many patients. We see this mostly in big bowel operations, extraperitoneal abdominal operations, and I tell you that this can be the one reason it keeps people in the hospital is they're not passing gas or passing flatus, and that's what keeps people in the hospital. So this can be a very annoying complication because they can be doing really well otherwise, but then have the ileus. Then as their abdomen gets more distended, then they start getting more back, more leg pain, and then they want more narcotic, and then you get this vicious cycle. And so this is something that we want to try and avoid. And I think through time, we've come up with some good ways to avoid this. But number one, you need to optimize people preoperatively and postoperatively, not only with medication, but also with nutrition. So one thing I frequently ask my patients nowadays is if they have constipation issues before surgery, well, if they have that before surgery, it will get worse after surgery. So if they have it before, I will routinely recommend people go on some sort of over-the-counter medication for constipation or increased fibers, something so they're not so how should I say, stopped up before surgery. And that seems to work very well because especially older patients, this is a very big issue, and older patients are more prone to this issue in my experience. Non-narcotic pain control strategies are also extremely important. So I use minimal narcotics today compared to what I used to do. Part of that has to do with, I'm sure everyone here is aware, the U.S. has had a huge problem with narcotics. I've never been a big user, but even compared to what I used to do, I'm using probably a quarter of what I used to do post-op. Most of my people off narcotics within 2 weeks of surgery. And if you talk to people beforehand, they can be reasonable. I know in other countries it's not even an option, but in the U.S. it can be very difficult because people are coming in expecting things and no one wants any pain. And it can be very hard to, but if you discuss this before surgery, I find things work out very nicely. I switched a lot to Tylenol. High-dose Tylenol works very well. Gabapentin can work very well for the post-op nerve pain people might have, and muscle relaxants. And these are all non-narcotic, non-addictive, and are very effective as far as pain control. But the number one thing that we need to do is get people up early. So when I do an ALIF or a front back surgery on my patients, I will have my PA, my physician assistant, go up the night of surgery. Even though I write the order for the nurses to get people up, they tend not to do that. But he will get them out of bed and walk them the night of surgery whether they want to or not. And I found with that, my rate of ileus has gone down dramatically, just getting people, even if they take a few steps. Because if you think about it, if you do a surgery in the morning and then physical therapy sees them the next day, that means they've been lying in bed for 24 hours without getting up. That's human bodies simply just not made for that. So I found early ambulation is by far the most important thing to get people going. Also, and again, this is not, this is what my hospital provides, but this drink is a pre-surgery carbohydrate drink. And I talked to my colorectal colleagues. They give this to all their patients for colorectal surgery because this does prevent ileus. It reduces risk of nausea and vomiting. reduces insulin resistance, and that will reduce time in the hospital. So I have all my patients drink this either the night before or the morning of before surgery, which I think between that and early ambulation, it really turned my practice around. Ileus is really a very uncommon situation in my practice. Acute colonic pseudoobstruction, also known as Ogilvie syndrome. Now, this is very interesting, but describe a Wilhelm Ogilvie in 2 patients with an intraabdominal malignancy. It likely involves a sacral plexus, and that provides parasympathetic innervation of this colon. So, how it occurs, we don't know, but I've seen it occur 3 times in my practice. And if you don't treat this properly, this can lead to perforation, which can obviously lead to death. So this is one where you've got to be, once you recognize this is occurring, you have to be very quick in taking care of this problem. So this is what an X-ray usually looks like. You see the colon, and this is actually, I've seen worse. It's not the bowel, it's not the small bowel that's dilated, it's the colon itself. And I'm telling you, sometimes the colon can get enormously distended, and you see how this could lead to a perforation. But if you see an X-ray like that, then there's even really no reason almost for a CT. You know what you're dealing with. So it can be caused by metabolic, mechanical, septic, pharmacologic mechanisms. Symptoms include most commonly abdominal pain. And what's interesting with this is that, everyone's concerned about, are you passing gas, having a bowel movement after this type of surgery? Well, in this case, people can still they can have quote unquote bowel movements. Usually it's more diarrhea, but they can have bowel movements. So then you think, okay, well then it's not an ileus, then what is it? But then you get the X-ray and you'll see this type of problem. So, but people will be distended, their belly will be distended. That's one thing you will see in almost all these patients. They will feel nauseated, vomiting, yes or no. Constipation, again, you can be fooled because they can still be having diarrhea and you think that things are okay. But again, the treatment for this then, two options, and I've used both. One is neostigmine, which can reverse this kind of parasympathetic blockade, if you will. Can work very well. The only issue is at least in the U.S., you have to put them on a monitored unit while they're administering the neostigmine. But that can definitely decompress the patient. I've had that used with my patient. Or you can do a colonic decompression, either with colonoscopy or sigmoidoscopy. It can also work very effectively. I've seen both, and both work very well. And if you do that, then you can avoid further risk of a colonic rupture, which would be devastating. That could lead to death. Retrograde ejaculation, again, this is one I've only seen once in my 18 years, at least once told to me. Usually most men are very open about talking. Well, they will definitely tell you if there's a problem. I find with men. This is one, that's why the men, I always bring this up beforehand, and especially their childbearing age, I always discuss this because it's a possibility. Even if you do the surgery the best way you can, this can happen to anyone. Obviously women, not an issue. But it occurs due to injury of the superior hypogastric plexus, and that lies beneath the peritoneum, courses anterior to the aorta, and then anterior to the left common iliac vein. So it's very close to where we're working. And now we don't do, this is a study I looked at, it occurs very commonly in laparoscopic cases. Now, U.S., I'm not really aware of anyone performing laparoscopic ALIF surgery. Around the world, I'm sure that is occurring. But it can occur up to 6% of mini openings. That's what, and so this is something that I've seen it happen once that someone admitted to, but maybe it is higher. I'm just not aware. But I find that most men would usually say something. Lymphocele, again, very uncommon. There are lymph vessels and nodes along the spinal column, and persistent leakage can result in lymphedema, mechanical depression, nutritional deficiencies. That'd be things that are going on for a long time, and immunosuppression, death. Now, again, this is not one I've seen personally, so I think you'd have to have that going on quite a long time for it to cause a problem, causing death for sure. Management would be simple observation. A lot of these will get better on their own. Drainage, which we have any kind of fluid collection, we tend not to like people to drain unless there is a problem because of the risk of introducing infection in the setting of an ALIF. Or you could create what's called a peritoneal window, that I've described. Fortunately, I've not seen this complication, but again, out. Ureter injury, again, fortunately, I've not seen this, but Dr. Termani alluded to it, this can happen. Again, the ureter, it passes anterior to the psoas, so it's right where you're working, enters the bony pelvis at the iliac bifurcation. So again, this is a structure that, in our practice, we don't actually look for the ureter, but we're aware of the ureter. It's extremely uncommon, but obviously can be life-threatening. Usually presents days after the index operation. So now what we're doing, and since, I guess more since Dr. Terabani's become a little more aware of this, I will now, we always put a Foley catheter in, but I will actually look at the catheter, the Foley bag, make sure there's no blood in it after we get done with the part, dictate that, we're documenting, but if there is blood, obviously then we can take care of things sooner rather than later and not have things delayed. That's where you're under problems, is delayed diagnosis. CT scan will show a fluid collection and may show hydronephrosis in some patients. This is more Termani's realm, but to prevent the ureter from being injured, it needs to be rotated immediately to the rest of what we call the packet, so to speak. So it's not, you're not isolating it, you're being rotated with everything else. The highest risk of ureter injury is at L2-3. So with him, we don't do ALIFs at L2-3. We'll do the oblique approach, or I do a lot of lateral surgery, so I'll do lateral at L2-3. And again, treatment can be drainage, stent placement, or in some cases. Sympathetic dysfunction, this is one that usually you'll have kind of, patient will come in saying my left leg is, well, they won't say the left leg is warm, they usually say the right leg is cold is what they'll say. But that's kind of that clues you in that sympathetic pain has likely been disrupted. Fortunately for this, it usually resolves within 6 months. This is not something you have to deal with long-term with people. The big thing is do not use a bovie along, especially on the lateral edges of the disc space. We use bipolar instead of the bovie, and blunt dissection, especially laterally, when you're getting close to the sympathetic chain. So as far as factors to consider, and this is just an overall kind of what I take into consideration would be prior retroperitoneal surgery is one. Any kind of prior graft placement, stents, these are things, these are pages I would send to Dr. Termani to take a look before we get into operation. This is not something I want to spring on him the day of surgery, where that, hey, by the way, he has a stent placed, we want to plan for this, have the appropriate equipment in place. Iliac stent, same thing, pelvic kidney transplant, radiation therapy, any kind of aberrant anatomy. And large anterolateral osteobites, not such a big deal for direct ALIF, but it can be more difficult for the oblique approach. That's where the osteobites are. But that's more difficult for me, and could be difficult with the approach, trying to get the retractor over the psoas. So when do I use the 0-degree ATP or the oblique approach as opposed to the anterior approach? Adjacent stem disease after a prior ALIF. Now again, for me, I will do laterals as well, but this has come in very handy for a lot of cases that I do. L2, L3, again, if I can't do a lateral, or if let's say I'm doing an L2 to L5 case, I'll use the oblique approach for that. 4-level cases, you can do an standard ALIF at lower levels and then do the oblique approach levels above. And if you have a case where you've done let's say an L3 to L5, and then 2, 3, and 5, 1 fall apart, then that's a good place to do as well. Also abdominal wall, that can be for many factors, and especially if people have severe arterial disease and a lot of calcification. With the oblique approach, you're not moving the vessels as much. Matter of fact, you're really not moving them at all. So then that reduces the risk of a thrombus. So the pros of 0-degree ATP, again, it can be used when the standard ALIF cannot be performed. Supine positioning, so for us as spine surgeons, it's still the same kind of place we're used to. Same retractor. We use the T-DAN retractor, which has worked very well for us, and that's good for either way. Simplifies retroperitoneal exposure. less manipulation and retraction of the vessels, which that's especially if they have calcified vessels, that's very important. Better surgery ergonomics. When we did that kind of lateral surgery, the X-rays looked good, but it was a really terrible surgery to do. It took a lot out of both of us. But you only look at the X-rays, you wouldn't know. But that's why that was a one and done. We did that one time, and that was it. Cost savings, minimal setup time. And I do use neuromonitoring, but you have to use the answer no. But I do use it, and less instances of neuropraxia compared to a lateral approach. So as far as the cons, ALIF is still optimal. Visualization of disc space is not as complete. You can usually get kind of halfway or a little halfway over the disc. So you can see enough. So there's definitely enough to work with to see what you need to do, but it's not as good as the standard ALIF. There are more devices being engineered for this, but there's still a lot of devices that are not specifically engineered for this corridor. So you have to kind of make those devices work. And it is a quote-unquote new surgical technique. And again, that's why we're talking about it, because there is obviously a learning curve for this stuff too. As far as the 0-degree ATP, again, this is an individual. This is a guy, early 70s, but very active, very in shape, and he's not on his deathbed. He's going to be around for a while. So in this case, you can see he has severe disease at 2, 3, and 3, 4. And if you look, the 4, 5 disc looks pretty healthy. But so initially, I kind of thought, okay, I'll do a 2, 3, 3, 4 lateral surgery, and then just that'll be it. But with the MRI, which I did not show, 4, 5 had pretty significant central canal stenosis, and because he's young, he's healthy, and he's active. Not young, but he's a young 70, I just couldn't leave that 4, 5 alone because I suspected he'd probably degenerate very quickly. So then you can see 4, 5 is not very favorable for a lateral. He has very high pelvis. And so that's when Termani came in, and we did an oblique approach for this one. But you can see here, so the cages went in fine at all levels, and just be very, I'll just pick on myself here. 2, 3, I would like to have been a little further back, a little anterior. I'd like to be further back there. And 4, 5, you can see there's even a little subsidence there. So even though I thought I was very careful with the end plate, obviously, now, fortunately that didn't change. That's the way all X-rays looked, and he's 8 months out now, doing extremely well, no leg pain, no nothing. And believe it or not, this gentleman went home the day after surgery. But this is the kind of the power of this 0-degree ATP with minimally invasive screws in the back. But there are complications too, and these complications mimic with the direct lateral, with the direct ALIF. So vascular injury, ureter injury, sympathetic chain injury, cage malposition subsidence, that I think is, and actually not I think, that is more common with this approach, cage malposition and subsidence, because, and that's more surgeon driven. That's not an approach problem, that's a surgeon problem. And I'll go over a case that I have, and I can show you kind of what happened to me. But vascular injury, again, it doesn't usually occur with the great vessels, usually more the segmental vessels. What Dr. Termani said is exactly right. With this, you want to really study an MRI or CT to make sure you can see that corridor between the psoas and the vena cava, and you can even measure that. Some people it can be very narrow, other people can be very wide, but you want to really look at that interval and know exactly what you're getting into before you start the case. Just like if you do lateral surgery, you always want to see where the vessels are, make sure there's not aberrant veins or arteries. You want to see where the psoas is, make sure it's not being pulled off the spine. You have to do the exact same thing with this procedure as well, so you're not surprised. And injury, we don't use a tubular retractor, but a lot of people will use a tubular retractor and actually will fixate a screw in the vertebrae. In those cases, there is a higher risk of having a vascular injury in those cases. Again, with our retractor we use, it's made for, quote unquote, made for this corridor, and works very well. Ureter injury, again, is uncommon, greatest risk at L2-3, even with this approach, but fortunately rare. And again, you just want to retract the retroperitoneal fatty anatomy with everything else to the medial aspect. And you want to directly inspect the intervertebral space. And of course, you're going to do that. If you see a ureter in the middle, you're not going to do the surgery. But Sympathetic chain injury, again, same thing. It's found along the anterior third of the vertebral body. It's frequently reported, but there's really no technical advice on how to avoid this as a complication. So, but fortunately, this is usually self-limiting within 6 months. But incidence in the literature is up to 13.4%, but suspect it's likely higher than that. So cage malposition. So here's what I'll talk about. This is one where you have to be a lot more careful than with a direct A-lift. A-lift, you're looking at the entire disc space. You're coming at it from a position that you're used to. With this particular approach, you do need to use more fluoro. If you do lateral surgery, I treat this like a lateral surgery. Because with lateral surgery, when you're putting your cage in, you're putting the cage in with an AP view, not a lateral view. And that's what I've kind of switched to doing. I always make sure now everything is set up in the AP and lateral plane with this approach, because you can get fooled. And I'll show you x-rays come up of how I did get fooled. But I check repeated images. So this, for me, the oblique approach does have more fluoro time than a standard A-lift. But that, you want to do things well and safely, so with a little more fluoro time, that's not, to me, a big deal. And again, as I said, I treat this like a direct lateral surgery in how I view this in terms of the AP and lateral imaging. And for instance, when I get in, so what I don't do with a direct A-lift, since you're seeing everything, I'll just go in and start working, and I won't get any x-rays until I start putting my cages in, my trials, and then I'll see what things look like. With this, I will make sure that when I put my cob across and I'm going to release the contralateral annulus, I'm checking that with an AP image, make sure I'm across, and make sure I'm staying within the disc space. Because it can be, especially people who don't have as good a bone, it can be easy to think you're in the disc, but you're actually maybe getting into the actual vertebrae. And so I'm very careful with this now, not that I wasn't before, but even more careful as far as checking this imaging. So this is the case I'm referring to. So you can see on the AP image here, you can see that cage is I'm not proud to show these x-rays, but you can see that cage is put in a suboptimal fashion. And this is a case where I did not check an AP image because I hadn't in cases prior. I've just relied on lateral images, but if you look on the lateral image, you can see how that lateral image, it makes the cage look like it's in fantastic position. And that's what it looked like when I did this until I got the AP, and I thought, what the heck is going on here? But obviously I didn't do a good job of getting the cob across. Even though I thought I did it, I didn't release the contralateral annulus. I actually was getting into the vertebrae through the end plate. And you can see what this cage looks like. So this is what you want to avoid. I learned this the hard way, but now I do check a lot more imaging. It's not, so as I said, it's more like a lateral surgery. So it's not so much imaging where it's delaying the case by 30 minutes, but it's just a little bit more here and there, and just to make sure you're in the right spot. So you can't be fooled. And this is completely my error, has nothing to do with the approach. This is all on the surgeon. Subsidence, again, this is a surgeon issue as well, and if you use fluoroscopy and you prepare the end plates well, this should be, for people who do this a lot, this should not be a big issue. This rarely occurs to me, but it does happen. But I've been doing this 18 years, and I've done a lot of these cases, and there's a force you have to use, but also more a gentle. You can't just be in there and gouging things. You have to be more gentle as well. But you need to protect the end plates, and a major thing is avoid over-distraction. You don't want to over-distract, especially an osteoporotic bone, because that will lead to subsidence. And again, that goes towards, if you do lateral surgery, same thing, you're told not to overstuff. A little is a lot more in lateral surgery, same thing with the oblique approach. That being said, you want to avoid a small cage. Now I say that, you want to put in, I'd say the biggest width you can, but I'd say height is not as important, but width you want to have a wider cage would be better. And studies are showing that the superior end plate may be weaker than the inferior end plate. So just keep that in mind when you're doing any of these types of operations. So this is what not to do when you're doing an oblique approach. So if you look on the left side there, it looks like you're kind of coming in lateral to the disc, but that's not lateral enough. Okay, so you see, if you go from left to right, this is what happens. You start too medial. By the time you get across, you're you're going too far across, all right? And so then what I mean by that is you're not going back far enough, but you're going too far over the other way. So what you need to do is, this is the no-go sign here. So what you need to do is you need to start a lot more lateral than what you think. So you actually are starting more over the psoas muscle, and that's something you have to kind of get used to, because with A-lifts, you're obviously you don't even see the psoas, you're looking at the disc. But here, you have to get over the psoas, and then as you mallet in, then you rotate over your hand and push it across. But by then, not only are you getting far enough across, but in the midline, you're also getting further back. And with that case I showed earlier, with that individual, I could have gone a little further back, and I just didn't want. So that was more of aesthetically, I don't like the way it looks, but fortunately, clinically, it didn't affect him at all. He's healed fine. He's doing well. So this is the to-go sign. This is what you want to do. That's what you want to do here. So as far as A-lift versus oblique approach, there was a good meta-analysis, 2,000 patients from 36 studies. OLIF had a higher complication rate, most notably subsidence. Okay, and I can attest to that. I think that I think it is easier to occur with this approach. But over 90% fusion rates in both groups. So basically, both OLIF and ALIF, and I'll put the 0-degree ATP in that as well, are very safe for adult degenerative conditions in a well-trained spine surgeon. And of course, Terramani won't like this, but in this study, they pointed out that ALIF is more expensive because of the vascular surgeon, but I think a vascular surgeon is indispensable in this type of case. So that being said, I'm biased. So multiple ways to approach the spine, becoming facile with these different ways, it just gives you more opportunity to treat people safely and effectively. I like to say more arrows in the quiver. So if you can't go direct ALIF, you can go try to oblique. And I don't do T-lifts. I'm not a big believer in that. But if I think a T-lift is better, I can refer to a colleague of mine who's really good at that, and he can do that. But basically, with these approaches to the anterior spine, we can really get there no matter what. There's really not a case we can't do with these types of approaches. It's effective and safe, and most importantly, low complications. So, as Christina Aguilera would say, what a girl wants. I'll just say that's Christina Aguilera. I know I'm dating myself here, but what a spine surgeon wants. Not Christina Aguilera, maybe some, but you want patient safety and low complication rate. You want excellent clinical outcomes. You want efficiency, reproducibility, and a less stressful OR experience. So, what to look for in an approach surgeon? Because again, both these, what I'm advocating is not, again, I'm not going to take sides, but I believe in the 0-degree ATP. I do think an approach surgeon adds a lot of completely worthwhile in the OR and indispensable in the OR. But you want an approach surgeon who's willing to see people preoperatively, number one, competent, and with the anterior approach, that's obviously very important. You want somebody who you can trust because you're trusting your patient with them. Compatible schedule. Again, I'm lucky enough that we work together long enough that I have that, but you need to have schedules that are compatible. And open-minded to new and novel techniques. And again, that's not everyone, but you want someone who's open to learning new things. And me in my practice, I'm doing things completely differently today, 18 years later, than I did out of my fellowship, because I think you have to keep your mind open. Technology is changing, it's getting better, and I think we have to adapt to that as surgeons. I think that will be better for our patients moving forward. So that's what I have. And thank you very much.
Excelente presentación, múltiples vías de abordaje para llegar a la columna anterior. Y eso me recuerda de un buen cirujano sabe resolver las complicaciones, pero un excelente cirujano sabe prevenirlas. Muchas felicidades, muchas gracias por esta interesante presentación. Y a nombre del comité de este simposio de columna.
Of the committee of the Spine Symposium, Dr. Taya received this token of our estimation. Now, to continue with this interesting topic, and to keep talking about how to biomechanically solve many of the problems people have in the spine, now we are going to move to a new topic that is from the ALIF, its indications and challenges. And to talk about this, let me introduce you to Professor Christopher Wang. So this way of talking about the spine and these new surgeries or types of surgeries, we know that we have to think about new techniques and innovations. Thank you. Muy buenas tardes todos.
You probably know. And I'm from Australia. And I'm going to have to apologize. I didn't have time to change my topic or my talk because we had two excellent talks before from Dr. Tiramani, Dr. Heb. They probably covered everything I'm going to cover. But what I will do is I'll give you from an Australian perspective and some of the data, some of the things we picked up and caused along the way. So I work in Sydney and I work at Prince of Wales Hospital in the adults and the kids, and my background is neurosurgery. Now, forgive the topic of the talk, if I could get just an opinion from everybody. So I'll present two cases and we'll see what people think. So I've got a 45-year-old male. He's ADF, so he's Australian Defence Force, so very active life, retired semi. And he's had pain for about 3 months now. It's in the back, as well as left S1 distribution, classic radiculopathy. So he's got a background of a previous microdiscectomy done probably about 9 months before, so got a good result, and close to 2 years before that. And that's his MRI, as you can see. So he's got that warping huge disc, and he's got those degenerative changes on the sagittal. Now, in terms of options, so raise your hand if you go back and do a decompression purely. Anybody? No? No one? Yep, yeah, we got one there. What about a decompression infusion? Who'd probably do a decompression infusion for this chap? Okay, so the majority. A lot of people there undecided. And who would do a posterior? So a posterior lumbar, of the ones that your favorite PLIF. What about TLIF? Any takers? Yeah, okay. OLIF. You can't do lateral here, so anyone? No? No one? After the two excellent talks, no one do an OLIF here? Okay. What about ALIF? Anyone keen for an ALIF? Yeah. Okay, I mean, there's no right or wrong answer. I think each surgeon has their own particular set of skills. Would anyone do anything else? Not operate? Okay, good, all right. Next case, JR. So this, she's a lady. She's a janitor or a cleaner, works in a high school. And she's been there for decades. And she presents with 8 months, bilateral radiculopathy, but worse on the left. And she does have mainly dynamic and axial back pain as well. So worse when sitting, standing, a little bit better when lying down, but not much. So on the top, you can see the MRI. She's got a little slip there, which you can confirm there on the X-ray. Probably a grade 1, and you can see some past defects and some or past fractures, whatever you want to call them. And there's quite significant stenosis on the left in the foramen, not so much, a little bit on the right. And I did get a bone scan for her, so bone spec CTs we do in Australia. I don't know if they're popular amongst other nations. For, I don't know, more settling the mind of anything else. So once again, options. Now who would do a decompression alone for that left-sided radicular pain? No takers for just a decompression. Okay, with the slip, Decompression and fusion? Most people? Once again, PLIF. The same. TLIF? OLIF? ATP? I'm looking in that direction. No? ALIF. Okay. All right. And who would do a combination? So ALIF, OLIF, and then back them up. No? Stand alone from the front? Couple. Okay. So I think Mr. Casper went through this quite extensively yesterday, quite nicely. So I won't dwell too much on that. But weight distribution, low degeneration leading to foraminal stenosis and facet arthritis, hypertrophy. We'll cover this. So it's good that, so I bring this paper up. So I work with Rafe, we're in the same practice in Sydney. And if you see Andrew Lennox, so he's the access surgeon. Greg Mellon is one of the other ones. So he's my vascular access surgeon. And they wrote this paper, which apparently that picture has been utilized the most in seminars. I'm not sure, that's just Rafe being tooting his horn. But it is a good comprehensive review. It's a bit outdated now, so there are other things. But in terms of what it does run through for ALIFs, my indications, as you've seen before, there is quite a number of different pathology which are favorable. There are others which are not. I think the one really strikes from what we've seen is patients who've had previous discectomies or multiple discectomies with axial back pain as well as radicular pain. That really, really does give probably the best result. Not to say that it's superior to others, but I think there's a non-inferiority result there, which I'll show you in a second. So recurrent disc herniations, obviously, foraminal compression, and spondies. Now, spondies you have to be quite careful with. So I'll show you. So with grade 2s, grade 1s, definitely no problem. Grade 3s, you can. We have done them, but back them up, but they do present a challenge anteriorly. Dr. Gaines was a big propensitor of the vertebrectomy. I don't know if you know Rob Gaines in States. Did a lot of pediatric L5 vertebrectomies. So I don't have the stomach for that, I have to admit. But that would be the approach. So in terms of why ALIF, you've heard this before. I mean, you all know size matters, right? Big surface area and height restoration. I think the end plates are strongest on the side, as Dr. Tabor was speaking before. So if you can get a nice big cage in, it really does help with the fusion. That's what we've seen anecdotally and probably structurally as well. The benefit is you're not working around the new elements and you have preservation of those posterior structures, which we've talked about. And you can combine them with different techniques at different levels, and you can do a TDR. Now, I know that's a bit contentious. I do the odd TDR in the cervical and the lumbar. I think as my practice goes on, I'm doing less because I'm seeing more unsatisfactory results with them. If they do fuse up, that's probably the best result, but I'll show you a case later on which has presented a bit of a headache. You can do TDRs from lateral. I've never done it. I've never seen it. I don't know if they've gone out of fashion. But in terms of size of cages, look, surface area, direct or oblique, and ALIF, probably the best, but you do get grafts along there in the PLIF and the TLIF, so it's not completely devoid. But in terms of getting that strong end plate to the lateral surface, I do like that ALIF cage, you know. So I won't dwell too much on that. I mean, probably autologous bone graft is the best. That back cage was probably about 20, 30 years ago, had the highest failure rate, and now we've got peak titanium. And you can put in nice big chunks of bone. So what I do usually is I put in 2 big bone blocks into the cage, which covers up pretty much the whole area and fill it with glass bone. So this is the view you see, which we saw before. This is 5-1. So at 5-1, from anterior, I mean, that ALIF really is quite appealing for myself. The veins and vessels out of the way, usually the median sacral vessels are taken. The plexus is higher, so that's the hypogastric. So if you worry about retrograde ejaculation, that usually isn't a problem. You're not mobilizing. So it's quite nice, quite neat. That's a phantom retractor, which is what I use as well, which is one of the nice. I did use a SynFrame for a bit, but they're similar. OmniTrack, I used a long time ago, starting out, and that was terrible, I agree. And so you get a nice cage and you get nice screw surface. So, TDR, once again. So this is some other papers. They're about 6-7 years old. So one had 125, the other one had about 110 patients, just looking at fusion rates. So they were pretty good. This is over 20 to 24 months. So they were not inferior, and this is radiological evidence. There was no subsidence, and there was very little take back in terms of failure of fusion. And we did also do the patient satisfaction and ODI, and they were all satisfactory or significantly different in terms of the indications that we did them for. Disadvantages, look, we've been through this before. So we talk about obesity. So, I mean, in Australia, we have a lot of well-covered patients, of which ALIF can be a little bit more of a challenge. So with the vascular problems, so with the atheroma, or if they've had previous vascular disease, my vascular surgeons, they get a CT beforehand if they're worried, especially if the patient's a bit more mature, so more than 60, 65. Good to look out for those things. Previous hernia and previous abdominal surgery is actually not a complete contraindication, as you heard before, but it does increase the challenge a little bit, and you worry about the urogenital problems. Now, the sympathetic trunk is interesting because I've had one patient who, so, I mean, the way to avoid that, I've been taught and seen, is to avoid any form of burning and just use blunt dissection. The same for the plexus, the same for the sympathetics. I don't know if you're using a polo, so there's a polo, which is a really nice instrument, cotton bud or peanuts, basically the same thing. But I had a lady who had a very swollen, she felt hot and cold in that left leg for about 3 months, and she was very upset because she couldn't wear high heels. So that's why it stuck with me, so I do warn them a little bit about that. In terms of our complications, so this is once again a little bit older, so this is 227 cases at our unit, which is done between 2009 to about 2013, so about 50 a year. So we looked at the indications, which is mostly for back pain, degenerative disc disease with and without radiculopathy. And in terms of the, it's a bit of a busy slide, sorry, I'll try to not fill up too much, but in terms of our vascular injury rates, so we had mainly all veins, so the IVC was the most common, and it's usually at the junction. But our blood loss, I put this in quickly because our blood loss was not that significant, more than 300 cc. because it was 6.6%. As Dr. Turner was saying, anything over 3%, we shouldn't be doing it. So I'm a bit sheepish, but that was our result. In terms of others, we had one thrombectomy, which was picked up only that evening. So it was a lady who had quite significant atheroma, and she actually developed ischemia in that leg, and she went back and had an endovascular procedure. So with regards to our retrograde ejaculation, so once again, I warn males who are childbearing age, the only reason we found that out was actually we had a questionnaire. So we look for it. And I don't know, if you don't look for it, they may not report it. If patients are not noticing how much they ejaculate, or they're not looking at their post-coital urine, it's most likely that they will be missed. And they're usually transient as well. So they all recovered, I think, those 4. But that was, and if we compared our complications to, that was just a quick review of all the other papers. I think Brow is in there as well. It wasn't deviating significant from the range. But now it'd be interesting, so we are doing a more recent review as well. So the first case lady, she had an ALIF. The second one, this is not hers, but she basically had an ALIF. And I didn't back her up because she looked pretty good, but I noticed, it is something I want the patients, so I don't always tend to back them up if it feels pretty solid. So a couple of problems. So this case was interesting. This was one of the first, this is the first one I used a PSI, so a patient-specific implant, at the advice of one of my senior colleagues. So in Sydney, the last 8 years now, we've been 3D printing implants. So, and in the spine, we use them mainly for corpectomies because we worry about the cages not being able to grow along fusion. So the benefit is, so we get a pre-op CT and we get an engineer to design and recreate that vertebrae or whatever we want, that disc. And they give us variable sizes, and it is standalone. You can put a plate on or you can put screws in. And I've done probably 4 or 5 corpectomy cases, and you can pack it with bone. So I mean, the problem with expandables is the bone doesn't grow across. I don't know if the bone really grows across. I'm going to have a good look, but it does make me feel a bit better. But this was the first one. We tried to do a patient-specific implant, and it was from grade 2 spondy. Lesson learned, I mean, we thought we're being smart. We weren't very smart. So it spat out. So this is the day 1 standing x-ray, which we get for the patients. So we had to take them back, put in a bigger cage, and we backed them up as well. So he was supposed to get a staged procedure on Friday and Monday electively. So that was a big learning point from us. I don't use any PSI discs anymore. This was another lady. This is one of my first ones, actually, which my colleagues had never seen. So this is the intraop x-ray. So that's, it was a system. I sound like a bad surgeon now. I was using a new system with unfamiliar equipment. Everything intraoperatively went okay, but on the post-op CT, she had a fragment of bone pushing on her L5 nerve there on the left-hand side. She wasn't in pain, but she had numbness, and when she got up and walked, she did have L5 radiculopathy. So I'm a big fan of the URIC. They have a Uvitis sort of discectomy system, which is good for larger patients as well, which she was sort of in that category. So I didn't have that set. And then this particular, they didn't have the trials I really wanted. So more tall at the front, lordotic, and small at the back. That was the only reason I could think of how I could have prevented this. But it's an interesting case. So I ended up taking her back posteriorly, decompression, and then fusion. So I'm very wary now not to put in 2 big cages just for that, but I think it's all off. So how many of you have seen this? I'll be interested. So this gentleman, he's in his 40s, and he had a TDR hybrid at 455 about 7 years ago. And he presented with really severe back pain over about 8 months with bilateral sort of leg pains as well. So, and you can see there surrounding the TDR, that's an ESP. So there's osteolysis. Now I know it's been described quite nicely with M6 previously, but ESP, I must say, that's a bit new. Anyone have any experience with that out of interest? Any hands up? No? So, thank you, Professor. Professor Rector. Now, this was a dilemma. So I spoke at length with my vascular surgeon. So I have 3. Andrew is probably Andrew Lennox is the most experienced one. And given the time and 4-5, he was a bit reluctant to just go plowing in to remove that, given the vicinity. Usually it's the veins, he says, the problem to try and mobilize. Scarring, edema around that area. So the MRI probably doesn't show, but there is quite a lot of inflammatory tissue anterior. So I decided to do a posterior fixation for him, but I'm still watching. So he recovered somewhat, but he's still early days. But I'll be interested to see if anyone in the audience, what they would do. And this is exactly what you're describing, Dr. Tayab. So this is a case from last year. It's actually not mine, my colleagues. And I don't know, for some reason, so I originally get AP lateral to avoid this, but it is an avoidable, and it does make you look a bit stupid and sheepish when you put a cage into the foramen, but that's a learning point, I guess. So, got no more comment on that. So I'm from Australia, all the way down there. You guys are up there. Takes about 26 hours in travel, and you do lose a day when you travel there, but you're getting back. Just a little background. So Sydney, look, it's a nice place. Got the Opera House, Harbour Bridge, you probably know, and beaches. People are generally nice. And we've got a whole bunch of local populations you can come visit. So this is the Prince of Wales Hospital. So it's in Sydney. It's got a children's hospital on campus, which I work at as well. We are one of 2 big trauma spine centres. So in Sydney, you're divided into north and south of the bridge. So north is North Shore. They get all the other trauma spine, and we get the other ones. The other peripheral hospitals do deal with trauma spine, but not the complex one. So come visit if you want. Thank you. That's a summary. Yeah.
Gracias. Largo viaje para venir a la plática y presentar directo. El doctor Federico Landriel nos va a presentar su plática acerca de tumores intra y extra canal tratados con mínima invasión.
Canal tumors with minimally invasive. Well, this is my last talk. Thank you so much for staying. I hope you are anxious to move on to tequila night this evening. Okay, so we are going to be looking at intracanal and also the famous sand clock tumors. And this is my disclosure, and I'm going to give you 10 tips or techniques that will help you avoid complications. Please raise your hand. Who uses hemilaminectomy as your approach to extract this or excise this type of tumors? With hemilaminectomy, I'm talking about a single side where you extract lamina, half of the upper and lower, and then the lower half of the lower portion, and you take the upper half and then the lower half. But who performs a full laminectomy? You take the spinous with both laminae. Of all of the tips, if there's anything I would like you to take as a take-home message is the usefulness of the hemilaminectomy. This is an hemilaminectomy involving 2 levels, assuming that the tumor is located between L4 and L5. The advantage of hemilaminectomy has to do with the fact that we are not altering the band of posterior tension. We leave totally untouched the spinous above, the spinous below, the supraspinous, the contralateral structures, and the intervention can be minimally invasive or conventional, but since we are not altering the tension band, we decrease the possibility that with time the patient may develop a segmental kyphosis. In the second place, if this is a unilateral process, we lower the possibilities for bleeding and infection. The patient presents less pain, and we have a dead space between the skin and the bone. And if we didn't close the dura correctly, or we have our dura with pure quality, there is less option to have the LCF going into the space. And if we add to this the possibility of a minimally invasive procedure, then we will have all of the advantages of a minimally invasive procedure because the patient will have a shorter hospital stay. And for me, the pain object would be to opt for a laminectomy. So there are very few intracanal tumors, and I'm talking about schwannomas that cannot be totally resected through a hemilaminectomy. The second place, my tip would be an adequate planning. If you are going to perform a laminectomy with MRI or other means, we need to evaluate our incision. And this changes if we are going to be having a patient that may require a cervical approach where the facet joints are flat at dorsal level because of the ribs and the shape of the facets, then it would be more medial, closer to the midline. And if we're going to work in the lumbar area, it would be similar to our approach in the cervical area, but we would have to take into account the patient's BMI. So it all depends on the patient's BMI where we are going to be planning our incision. So we require pre-op studies, look at where the tumor is located, and then measure the distance that we are going to have between the midline and the line for the surgical incision. Now, of course, this changes, and this is the case of a 66-year-old female with a meningioma that is anchored in the dura. And even with these lesions, with an hemilaminectomy, we can have an adequate approach to the tumor. At the upper portion of the screen, you will see the base of the spinous, and then we are going to be cutting the denture ligament, and then we are going to be releasing where the tumor is attached, and with an adequate view, we can extract the tumor in a single block. Of course, we could also do this with ultrasound or aspiring the tumor, but you can see how we were able to extract and block because we went in obliquely, and very much so. And this was due to the fact that the facets are not so high because we have flat facet joints. So if you're going to work on meningiomas such as this one, it is safer to first empty the tumor. But this is a pathology, a type of pathology where we can not necessarily take it en bloc, but empty it or start taking it piece by piece. Now, if we have a lumbar tumor, the schwannomas are more frequent. These are tumors that grow from the sheath of the roots, and when we perform a minimally invasive approach, you can see that we have numerous nerve roots, and then we have to look for the tumor, identify its surface, and this tumor moves lots more than a meningioma that is attached to the dura. When we bring the tumor out, we stimulate to determine whether we have a motor root. In this case, we cannot sacrifice the root, so we extracted the tumor, we peeled it, and we tried to preserve the root, and then we brought the root back, we closed. But with this type of approach, even though it may appear to be simpler, you have to bear in mind that the tumor can move, and therefore you need to plan to include tubular expandable devices in order to be able to expand 0.5 centimeter or 1 centimeter sideways. And this is how we perform the hemilaminectomy. Now let's go to the dorsal level. When we look at deep learning, it is difficult to go to the upper dorsal region. If we do not have adequate devices, then we will have to open the incision. Now, since we do not have a clear view in the OR with fluoroscopy for patients that have high thoracic tumors, and we know that we are already going to have issues in order to locate the site of incision, we use a pre-op landmark with carbon. This is the tumor. This is a very small tumor. So what do? We use activated carbon that is used for sentinel techniques for breast cancer. So we used CT to identify the anatomy, and so we start injecting this liquid carbon that has as advantage in comparison to other means to mark soft tissues that it does not dilute so much. If we use methylene blue, then you have to bear in mind that methylene blue dilutes. Surgery, we are quite simply following the black mark that the carbon leaves behind, and then we perform our conventional hemilaminectomy, and we start working. If you remember the tomography, this was a meningioma. You saw that the lesion was white. That is because it was calcified. With an hemilaminectomy, what happens if the tumor is calcified? Well, these tumors do not have a consistency that is as hard as stone. No, you can grab them easily, and that is not a limitation. The fact that a tumor is calcified is not a limitation. So once we open, these are the tubular spreaders that can help us add 1 or 2 centimeters. It continues to be a minimally invasive procedure, and as Dr. Gordon talked about yesterday, 1 centimeter or 2 centimeters more ipsilaterally does not change the concept of a minimally invasive surgery. So we are spreading by 1 or 2 centimeters, and that doesn't change things much. And here is the dura, and you can see a calcified meningioma, and you can see the famous capsule calcified mangiomas, and then we can start detaching them. If they cannot be aspirated, we can use ophthalmic scalpels to make small cuts. And then I, for instance, made a small cut with the scalpel, and then little by little, I start breaking it bit by bit. And this is no problem if we compare it with a common meningioma or a schwannoma. And so I start extracting the calcified portion, and the rest I can suction. This is the post-op control in T1 and T2. Now we are going to go one step beyond. Here we have a schwannoma in T12. It's an intercostal. It can be approached endoscopically. That is correct, but we can also use carbon marking. So we use the same technique as before. And so what we do is here we have the carbon marking. We go all the way to the rib. And there we place the spreader. We fix it to the table. And then we're looking for the, we follow the steps that we currently follow to operate a schwannoma. We identify the root. And this is how we are pulling the schwannoma out with a very simple approach without having the need for a thoracoscopic approach. This is a pleura. You can see how it is palpating. This is how I took a sample of the rib. Tip number 4 has to do with thinking about alternative routes. This is an 11-year-old patient with a schwannoma in C3. To approach this case classically, we would have to go for, we have to approach from the back of the neck, and of course that would be destabilizing, and we have to think that this is an 11-year-old patient, and then how to control this patient in order to prevent future issues. So, but we learned based on surgeons that use vagal stimulators, we looked for an anterior approach. And so we first located the base of the tumor, which is what is marked here in green, and then we emptied the tumor. And once we know where the vertebra is, we can remove the lesion entirely without altering the stability. So this is an alternative approach. So not all described approaches are the ones that we have to follow, but if we are versatile, if we have used vagal stimulators, well, we can follow a similar approach for a tumor of these characteristics. So this is a schwannoma where we intervene with an anterior approach with no need to destabilize the spine. Tip number 5, use technology at hand. Technology that perhaps wasn't developed to be used with tumors, because there are situations that we can use the spreaders that were used for lateral cages. And with the same lateral approach, this can be done with regular devices. But if we use technology, we know that with these autostatic spreaders, and we can have an adequate spread during an hour or the 2 hours that the surgery will require. But of course, we will have the entire muscle separated, and we can act faster. We will have less bleeding. And here we're using technology that was developed to place implants in the spine, but we are using it here to extract this tumor, to excise this tumor. Here we opened the capsule, we emptied the content, and then we were able to remove the totality of the tumor. And this is the control that was pre and that post op. Now, tip number 6, it has to do with opting for the shortest path. And this is a lesion between L1, L2. This is a tumor that is located in the psoas, but in a higher position. So here we use a lateral approach, but we already have the ribs right in the middle. So we have to deal with the anterior portions of the floating ribs. And then at that moment, I realized that I could use the technology of these spreaders and go to the psoas, and at that level of the psoas, the plexus will not be an issue. But the thing is that its position is very deep. It's far away from the surface. So this makes the control of the lesion to be very deep. So for tumors that are born from the sheath of the nerve, we have to identify from which sheath did they come from. And of course, we can see whether we can ligate so as not to lose CSF. And because I love the control of the root that gives origin to the tumor, we have to remember that we are working at a significant depth. So I realized that the lateral transpsoas approach would be too distant. So if it is true that we can have an adequate control, I wasn't able to ligate in order to prevent the fistulization of CSF. So if we are not totally sure of a good control of the root and an adequate closure, then we decided to use this type of sealant material that would help us control any leakage. Now, if you do your post-op control within a short period after the surgery, this liquid, this sealant works as CSF. So it looks white in T2, but it looks black in T1. So you must not mix the dural sealant with CSF. This is control after surgery. Now, since for me the oblique approach, when patients have tumors that I call high in the plexus, then I decided to opt for another approach. And this is a patient that had a tumor inside the canal, so we opted for a posterior approach where we took advantage of all of the spread. If this image looks flat, my approach is oblique from below and then lateral to medial. And so here I'm placing the procedure in a fixed position, and then it is easier for me to approach with a surface that is less deep. And here it is the area where I am working in the transverse, and I can have an adequate view of the root without the need of a facetectomy. And so here I can cut, I ligate, and then I cut, and this will enable me to have a better control and prevent a potential leakage, potential leakage. And so this will take me now to tip number 7. And so the idea is to preserve stability. This is another patient with schwannoma in L5S1. The schwannoma was right below the joint, and in order to excise it, it would be very difficult to go for a PLIF because the crest wouldn't let us adequately manage. So our approach was much more lateral, and we went through the iliac crest for a small notch. So we go through with the osteotome or a drill. We produce a small notch in the iliac crest, and then we introduce our device, and then we have an oblique access to the L5 as one space, and then we open the dura and we start excising the tumor. We empty it with ultrasonic vacuum, and then we remove the lesion, and then we suture the dura, and we can have the right approach with this option through the iliac bone. This is the post-op control. And this type of approaches were discussed in this paper in this issue of neurosurgery for tumors that are correct for a posterior approach or a transpsoas approach, but it all has to do, of course, with the anatomy of each patient, and you have seen the different approaches. Now let's go on to tip number 8. You have to remember that these tubular spreaders are mobile. We not necessarily have to stay static in a single position. This patient has a tumor more outside than inside the canal. So we start always working in the most difficult side, that is inside the canal, that then can compromise the bone marrow. So once we deal with that part, we move the tube slightly, and then we approach the nerve. Here we have it. We cut the nerve root, and then we approach the posterior portion. We change the microscopic view, and so we can excise this portion that was over the pleura, the major vessels, and this is simply done by moving the tube and moving the surgical table. And so you can see how that notch on the vertebra was made by the tumor, because these are tumors that grow very slowly and remodel the bone. And that was the post-op control. Tip number 9. As you saw, I like minimally invasive approaches, but not all tumors can be excised with minimally invasive surgery. For instance, if we have to deal with schwannomas such as this one, where we're working in the upper portion of the apex, then we have different delicate anatomical structures. So for the intracanal portion, we operate with an hemilaminectomy and a minimally invasive approach, and then we moved on to conventional surgery. So we are not always standing our ground in terms of always opting for minimally invasive, but it all depends. It all depends on the type of patient and the type of tumor. And the last tip number 10, dural closure. To close the dural, we can opt for a minimally invasive approach, but if we do not close the dura, you will have a CSF leak. And the dura, for that, you have to use a spreader. If you do so, it can be easier to close. And here, if you use a rigid tubular spreader, my advice for you is when you tie the knot, you do it outside the knot, and then use the devices used for laparoscopic surgery, because if not, it would take you way too long to close the dura. And so we use the Castroviejo needle holders, and if it is 6-0, that would be it. So the take-home message is, if you practice hemilaminectomy, whether conventional or minimally invasive, well, I remind you that minimally invasive may avoid additional pathologies. Thank you. And one more thing. To promote the publications, I am coordinator of different publications, so our objective is to publish So I invite you to contact me, and here you have our webpage. So please send us your project. We do not pretend to be co-authors or anything like that. All we want you is to publish your project in national or international publications. So we need to publish. So yes, you can have multicentric studies or studies from your center only, but please contact us. Very well. On behalf of the organizing committee, we present Dr. Federico Landrell this token of our appreciation, thanking him for his participation. And now we invite the rest of the panel to join us at the front of the room so that we can move on to the roundtable discussion and see what the audience has in terms of questions. Dr. Teramani, are you here? Dr. Neil Tayab, are you here? And Dr. Christopher Wang, could you please join us? We have questions already. Let's start for questions for Dr. Landriel. In case of broad resections and metastasis, have you had to perform revision surgeries? Would a navigator help you in these cases? Yes, we start with a decompression or laminectomy, and then the evolution of the patient may require something else later on. I'm sorry. So in terms of navigation, we use it for osteotomies, for primary tumor, not for metastasis or not to place screws, but basically because we do not have that technology available with our navigating device. It doesn't work with screws. It is a very expensive technology. So in our country, navigation wouldn't be authorized for metastasis, for instance. It would have to do with the survival possibilities and the patient's age, but we hardly would have financement approved for this type of navigation system. We have another question. This is an open question. How safe is ALIF or OLIF for revision surgeries? What would be your recommendations in case of having to remove an implant for any of these two approaches?
It is the most challenging approach to do on a revision case if we're going directly at the same level that there's a failed artificial disc or an ALIF gauge. So for me, I tend to go transabdominal. It gives me more flexibility. I have cell saver available. I will have basically different alternatives to try to remove the cage. It depends what we're trying to remove. Sometimes we're just removing a screw. Sometimes we're trying to remove the cage. But the other thing I always will do is I'll put bilateral ureteral stents. So I take a couple pictures and I kind of know the outline of the ureter and where the ureter is in relationship to where I'm going to get to the spine. And by going transabdominal, I'll get to the spine right in the midline, and it gives me flexibility. It doesn't force me to come from the left side as if I'm doing a retroperitoneal approach, so I avoid all that scar tissue by staying out of the face.
Y otra pregunta para tres también. ¿Cuál es la mayor complicación que ha tenido los abordajes anteriores y laterales? Y hay otra pregunta también que creo que tiene relación que
There is another related question. Have you had cases of peritonitis, perforation, gut perforation? Con ALIF, yo, pues lo ideal es hacer un diagnóstico temprano. La señal se está cortando, no podemos ofrecer servicio de interpretación.
After surgery. And now I found that in 2 of those cases, it occurred when I did an ALIF and a lateral and a posterior all on the same day. So let's say I had an L5S1, I do an ALIF there with Dr. Karamani, then there's a problem with L4, then I just do lateral. This is before we were doing the oblique approach. And then I put in the back, put screws in. So I actually had this happen to me twice. I'm talking to Dr. Karamani, I think it's only happened to him once, and he's done over 7,000 of these cases. So I have unfortunately have the most in San Diego, according to him. But so I no longer will do these combined approaches all in one day, number one. And now with the oblique approach that we're doing, there's no need for me to do the laterals on those patients. I'll keep them supine and do everything from the supine approach. And then I'll go posterior. But I think doing this, all these different table, lateral, supine, posterior, I think it's just too much for the abdomen to handle. I've never had a case, I've had, let's see, a small bowel obstruction after doing an ALIF, which turned out was completely unrelated to the surgery. It was kind of very bad timing, which led to peritonitis and led to her getting more surgery. But that was completely separate from what we did. It just turned out it was just kind of a bad timing situation. So the answer is yes, I've had these complications occur, but in doing, several thousand of these cases, it's unfortunately a very rare event. But if you see things not really going well after surgery, you have to be very in tune with that. Get an X-ray, if that doesn't show anything, get a CT scan, and then you can treat people appropriately. Because as I said, if this diagnosis is delayed, that can lead to death in those situations. Fortunately, all my patients I'm discussing lived, and all are doing well. But then one patient in particular had to have a lateral bowel removed. Despite that, she's doing very well. And with the surgery itself, all her preoperative symptoms are gone. But in that situation, I'm not worried about the surgery, I'm worried about her life.
Okay. Tengo una pregunta para el doctor Christopher Juan. Vimos casos muy interesantes ALIF. La pregunta sería, ¿siempre utiliza la caja como standalone o en algunas ocasiones utiliza alguna instrumentación posterior para...
Posterior instrumentation for protection.
So for the spondylolisthesis, if it's grade 2 or more, I would back them up. Because with the grade 1s, I think we get a decent reduction, we can do some purchase. We've got good fusion results. But with the grade 2s, they're a bit iffy.
Felicidades a todos, muchas gracias. El profesor Juan, doctor Juan, el primer caso que presentó el paciente de 45 años, que tenía previas disectomías, se consideró prótesis de disco en su momento y Y sí,
I mean, at a certain moment, or what did you prefer to do something different? Esa es muy buena pregunta. Bueno, no hago muchos TDAs, pero he hecho algunos a nivel de las uniones. Creo que en la tecnología nos ha ayudado. Como les decía, cada vez estoy haciéndome más hacia el otro lado. Sí, me ha alejado de ellas. Probablemente por un puñado de S1 son los que me han llevado a TDAs. He visto a que otras que migran. Entonces sé que hay cirujanos.
Putting in a screw into the S1 sacral body to try and prevent it coming out. And depending on the company you speak to, they say it shouldn't move if you put a nice big one. But I have no appetite to do L5S1 TDRs. Sure, that's the experience of the panel as well. Thank you.
Gracias.
El MOLID, igual que el LIF, son nomenclaturas nada.
Sorry, the signal is too bad. I couldn't get it. Let's see. I wanted to ask you if olive is the same as molive? Or is that just, I mean, the lateral, anterolateral approach, is it the same, olive and molive? So, no entiendo claramente a qué se refiere.
A-lift typically is direct anterior. Anterior lateral has been described in the literature, at least the way I interpret it. Anterior lateral is just lateral to the rectus muscle, but you're coming in at maybe 10 degrees, 15 degrees, so it's kind of a direct lateral. I mean, a direct anterior case. Much of the implants are similar to A-lift. The moment you start pushing out to 35, 40 degrees, and maybe 60 degrees, depending on how you're coming to the spine, that's your ATP/O-lift approach. Does that answer your question?
Muy bien, tenemos tiempo para un par de preguntas más del público.
We've got some time for 2 more questions. No further questions, apparently. Thank you very much. It's time for us to continue with the presentation of some other cases. Thank you all the members of the panel for their participation.
Continuamos con la presentación.
Now we'll resume with the presentation of clinical cases, and now I'm happy to introduce you to my friend Manuel Celis, a physician working in section of spine, graduated from with important experience on spine surgery. Good afternoon, everyone. First and foremost, I would like to thank you for your attendance here at this time of the day, even though we're tired. Thank you very much. We're going to make a revision of the clinical case, and we'll be asking for your interaction and for your participation. Thank you very much. And probably we'll be closing the day with a little bit of what we've been listening throughout the day. Thank you very much. But the idea is getting a specific basis of what we've been talking about. As Fernando told me, I'm Manuel Celis. I graduated from the medical center in Guadalajara City, and now I work in this hospital of the picture. Thank you very much. So let me give you the background from this patient. This is a case of a female patient that is 51 years old. In general information, she had upper studies, married, currently working at an office. And she spends long hours sitting with no previous diseases, not abdominal problems. Previously, she had surgery for hemorrhoids, no traumatic background, no toxicomanias, and she's having painkillers and in a very high dose for anti-inflammatories because of the amount of pain that she presents. About her background, well, she presents chronic pain for more or less a year of evolution. Her pain is referred when she is standing, mainly when walking and moving around, inflection, tension, and physical activity. She said that the pain increased importantly in these situations. Lately, she had no improvement after medication. She exhausted the resources of rehab and presented no progression or no improvement. What she referred practically was radicular data. Basically, she referred to lumbar low pain without presenting radiculopathy. Occasionally, she said she felt radiation of this pain to the buttocks and occasionally a loss of strength in the limbs. Symptoms were mainly referring to the lumbar area. After consultation, her limbs were without any alteration with a normal radiological results. These were the initial images taken from her. She came for the first time to the doctor's office this way, and you have the AP and lateral x-rays. Here we have something pretty clear. Now you can see basically the space between the L5S1 is inexistent. A little bit of the platforms is more sclerotic, or basically we have no more data about that. The first question we asked to ourselves for the initial diagnosis was, and we would like you to give us your answer. Which diagnosis would you give to the patient in this case? I know it's difficult by only looking at the x-rays, but the first one would be dynamics and would be lumbar discopathy, then narrow lumbar channel. And number 3, the first option, there is greater coincidence. Initially, we think this is a case of lumbar discopathy. Let's go back. The third one was a syndrome. And the second question is, if we have these simple x-rays, what would come next? First of all, would you ask a dynamic x-ray and an MRI? Or second, an MRI and an EMG? Or would you ask for a TAC and an CT scan? Would you go back, please? Okay, let's take a look at the results from our survey. Okay, most of us agree on the first answer. The next study we would ask for would be dynamic radiographs or X-rays. And to complement this information, we would use MRI. This is a result. These are the dynamic X-rays from our patient, inflection and extension. Here we can appreciate that the space in the posterior part is modified a little bit. In both cases, inflection and in extension. The rest of the lumbar spine is unaltered. Now, let's take a look at the MRI. In the sagittal view, what really called our attention is the one that is on the right, where you have two levels, L4 and L5. L5S1, both of them are compromised. It is the first one at the bottom that is enlarged. At this point, we corroborate that the L5S1 space disappeared. Most of it. There is a protrusion we find to the outer part. And at the upper level, we see that this hasn't been collapsed, but it's been affected with a protrusion. The patient, however, didn't refer to us as having radicular pain. At that point was when we started thinking, what are we going to offer her? What are we going to do with her and offer as a treatment? So among the different options for the posterior approach with instrumentation and only making a posterior fusion with posterior instrumentation and complete this with an anterior fusion using cages and transforaminal approach, or for using that with an AL leaf. So which is your vote? Okay, let me go back, please. Apparently, option 3 was the one with more voters, that is the transforaminal by posterior approach. And the second question is, after looking at the MRI, we thought we're only going to work with L5S1 segment, or shall we work both problems, both segments, L4, L5, and L5S1? Which is your vote, 1 or 2? Could you give us the results, please? Okay, let's move back. Here, most of you decided to work in both levels. What we did was the opposite. We decided to work only the lower part. So this is what sometimes comes into discussion. We don't really know which way to go, what to offer the patient. If we only care for the posterior part, or if we complete this with the posterior part, but including cages, and we go anteriorly, or we do the transforaminal one. So considering all these things, we decided to do this in an anterior, with an anterior approach, and only working with L5S1. These are the transsurgical images we got, and at the bottom we could see the fluoroscopic images to showing our progression and how we decided to start working on the spine from our patient. There we see the space from L5S1, where we started working with a dissectomy on the vertebrae, and we started trying the different cages with a greater and a lower angulation level. At that point, we started assessing how to improve the spacing in between vertebrae and improve the sagittal view. At the top, we see the sagittal vision. We're reaching the disc, and the cage has been placed. Something that might be important to highlight is, as the surgeon we work with, the vascular one that helps us with the approach is completely against retractors. So basically, he uses some pins that are basically some chance screws to help himself to separate the tissue, and he completes that this way. He uses this technique. So using this instrumentation, he feels at ease, and gives us a good visualization of the area. This is the immediate final fluoroscopic view. There we see the placement in full. We think it's a very adequate result about the recovery of balance, and the placement of the implant. We think it was an adequate one, and there we have the foramen. The area of the foramen, relatively, that was not a problem because of the type of patient we had, but she really experienced improvement. A month afterwards, our patient looked this way. There you have the approach, probably what the doctor mentioned, the size of the incision was big. It's a little bit wider than what he usually does, but practically next day we asked her to come and stand up, and she referred a little pain. And with the surgery, the patient said at the beginning that she was suffering pain at the level of 7 out of 10, and then 1 out of 10, just to mention that there is some discomfort at some point. And she continues being in rehab, but she's very happy, of course, because what really made her suffer a lot was the amount of pain in her daily life. Practically, she has recovered the capacity of moving around without feeling pain. So she's quite happy for her results. After checking all this and supporting our decision, well, we were educated to make posterior approaches more than everything, and trying to change paradigms and changing concepts and being aware of the evolution and progression of patients that has been quite satisfactory, especially at post-op when you have little reference of pain with little pain and they may start ambulating soon. We have looked for options and tried to offer them an anterior approach exclusively, and many papers have been published on this issue. The fusion rate is quite high. They practically talk about a 95-96% of fusion via anterior view, or and when there is a long instrumentation, that increases the possibility of increasing the channels. At the recovery rate is also very important, especially considering the sagittal balance for the body, as well as the height that we can reach with foramen. The different patterns are recovered very adequately using this approach. And for those patients with spondylolisthesis, we also have very good results. Spondylolisthesis that might be referred as third level problems using this technique with disectomy and with an indirect decompression. The reduction is very adequate, not 100%, but really adequate. That's why in spondylolisthesis this seems to be a very good option. Some papers already mentioned this, and they mentioned that in a higher degree of spondylolisthesis, this might be completed by a posterior instrumentation too. And for example, when considering in FEMICOT, for example, last year, in some cases, some conferences, people said that I have no need to have a vascular surgeon in my OR. I can do this approach. But if anything happens, you would want to have him there, probably close or at least in the same hospital. So they all professors agree on the fact that a vascular surgeon is always a good resource to have, if not in the OR, at least handy, because a series of complications that might arise for us are just immediate and they come out of a sudden. So at that point, all the danger will be for the patient, of course, and later complications such as a retrograde ejaculation, etc., or having an ileum, and developing some other issues such as a ureter or in bowel injuries are important. But vascular or arterial injuries in a greater or in a minor manner are going to make complicate our lives. So angiologists refer about that, and in this publication of a magazine on angiology refers how important it is to have a vascular surgeon in the OR. They themselves say that they have lost their interest in this kind of surgeries. They prefer to use minimally invasive treatment, and they say that they also want to look for other opportunities to, especially working hand in hand with these specialists. So the way to go now is that one, and the option of carrying out an ALIF in the anterior approach is satisfactory, is providing us with very good results, and after giving follow-up and checking the way our patients evolved, the patients that in comparison with those that had a posterior approach, after some 48 hours, and you look at the results, you see, wow, there's a big difference. So looking at the right candidate and having the good patient selection, you know that you must be sure that this is he's going to have a good recovery. So this is the way we like to work, working in a team and working professionally. And here we are in Guadalajara. Thank you very much. I want to welcome you all again to Guadalajara. Thank you.
We have one question here in the app. Did you use a brace? And for how long? In the post-op, we do use a brace. It is more like a girdle, actually. And we use them for the first 1 or 2 weeks while the patient goes to a rehabilitation program, and we start weaning the patient as soon as possible, weaning the patient from the brace. Well, we have time for more questions, so are there any more questions? Congratulations, Manuel. Excellent case, and these are precisely the perfect case, one of the perfect cases for ALIF. On the other hand, in a perfect world, and if you had all of the necessary resources, would you have taken a CT scan to look at the status of the facet joints or a bone density, or I don't know what there could have been other options? Yes, that is true, but there are many options. Yes, but in the MRI, we saw that the facets weren't so much of an issue, but the issue was actually the disc, and this was a 51-year-old patient. And the patient didn't have sarcopenia. She's a healthy patient with an active lifestyle. So we didn't want the patient to spend additional funds. So she had already invested in her surgery, and this was paid by her privately. So we said, this is not a facet issue. This is a disc-related origin. So we decided to opt for this conservative approach. Perhaps in an elderly patient with degenerative issues, then we would contemplate additional studies. Are there additional questions or comments? Hi, congratulations. In the last image, in the cage, apparently, compared to the wall, it's a little bit outside the area. And we usually take the cage as back as possible, but it seems to me that you didn't do that. So wouldn't you consider the option of complement with a posterior approach? Well, in the trans-op, we showed you an image that when we were placing the cage, we looked at the two bodies, L5, S1, and the cage was inside the bodies. And we impacted the cage, and it fit perfectly. And in the image with the fluoroscope, well, the image left us convinced that we did, the best, and we didn't want to risk because we didn't want to use extra force. We decided to leave it there because we didn't want to run into any complications. And the fluoroscope image, we saw that the cage was inside the body. So this is why we decided not to do anything more. I'm sorry, without a microphone, we cannot translate. Well, what happens is that this cage has this plate right in front of the pick. So with this mini plate in front of the cage is where we place the screws. But if I understand correctly, the patient is aware that because of this protrusion in L4, L5, we have the option of a posterior approach if necessary. Yes, we would have to go for and include both levels. Yes, good afternoon. With respect to this last comment, did you consider to go A-lift in L5 S1, TDR L4, L5, and posterior screws in lateral decapitus? Well, as we thought about it, yes, this is why I am saying this because the patient, because of the listhesis, in spite that it is grade 1, she's mobile, and this is why she's presenting a disease in the adjacent segment, and further up, she's also presenting issues. So what might think in TDR for L4, L5 with Exalif S1, L5, LS1 with posterior fixation, but this is a young patient. So I personally would contemplate that option. Yes, this is our question was, what do? We go for one option for all options? Two levels that are involved when we discussed this with the patient. And we decided to go for the minimally aggressive option. And the patient knows that there is another level that is involved, and there is the probability of requiring another procedure. And this is something we discussed with the patient. And yes, we discussed how far would we go, and we decided to do what we shared with you. All right. Thank you so much, Dr. Celis. Thank you all. Thank you all, on the contrary. Yes, thank you all for joining us, and see you tomorrow. Thank you. Yes, I look forward to seeing you again tomorrow at 8:30. Yes, tomorrow we will start at 8:30, not 9 a.m. Okay? Okay, see you tomorrow. All right, tomorrow, 8:30.